So these ones? Those ones? If not, I'm going to get started. And to advance this? How do I advance this? So is this one working or not?
Just a minute, please.
We may have to use this microphone, but that'll. It's this one. Yeah, no problem, no problem. Good. Well, look, welcome everyone. If people can take their seats, we're going to get started. We are a little bit behind schedule, so we will work to make up time. And what I will start with is just these initial slides. People in the room can see them, and people online can see them. So just for people in the room, you have those headsets on your table. Channel 1 is the English channel, channel 2 is the French channel. And if you're joining online, if you go down to the bottom of the Zoom screen, you have that little interpretation globe, and then you can select English or French. If you're experiencing any technical difficulties, if you can send a message via the Zoom chat, just explaining the technical difficulty, or you can email the group at that info.tiseh email, they will address those concerns. Just finally, a couple things. The bathrooms are behind this wall here, but when we're in session, we're going to close those doors. So if you want to use the bathrooms, you can exit out those two doors there, exit out where we came in. And the coffee break is obviously going to be right behind us. The other issue is, we met yesterday just to prepare for the meeting. We'd really ask participants during the meeting, during the technical working session on Wednesday, and then during the campaign digitization, if as much as possible, if you can stay in these rooms for that session versus organizing kind of separate sessions. Just important we're together and we can get the most out of this meeting. Good. So look, I'm finished with the kind of admin issues. I wanted to start by welcoming everyone to this year's 2025 AMP Partners Meeting. And our theme this year is rethinking the ITN status quo, maximizing the impact on malaria. So as we begin, I really wanted to start by thanking the AMP staff team who've pulled this meeting together while managing enormous change and uncertainty that we've all been going through over the last few months. I also wanted to thank the AMP partners and the AMP core group members who've worked on the agenda for our meeting. But most importantly, I wanted to thank you, the people in this room and the people who are joining virtually. Your virtual and your in-person participation allows us to continue to deliver this important annual meeting. And as we begin, I want to acknowledge who's not with us this year, both the programs supported by the President's Malaria Initiative and our colleagues who work for PMI. It's been 20 years since PMI was established with a mission of reducing malaria-related mortality by 50% across 15 high-burden countries in sub-Saharan Africa. And as we start this meeting, I wanted to thank and acknowledge the PMI team and their partners for their work and their enormous successes to date. So if we could give that team a round of applause, appreciate that. So we gather today during a time of change. And over the last 20 years, so AMP was formed over 20 years ago. And after we were established, it took us a few years to realize who we were as a partnership. but we are a partnership of change. We changed from the first distribution of 14,500 ITNs integrated with measles vaccination in Lara District, Ghana, to national in scale targeted under 5s, to universal coverage, to multi-product campaigns. We transitioned through the COVID-19 pandemic through periods where we were resource rich and for periods where we were resource constrained. So we start this meeting as we always have, hoping we can navigate a clear path through this time of change, but also preparing for what may come. We are a country-driven partnership. Change is part of our DNA. It's this country focus, it's the 25 national malaria control programs that are participating this year that know what is essential in their countries when tough decisions are needed to be made, what those decisions need to be. So the answers for us are in this room and with our participants online. And we start this year's meeting ready to write the next chapter of change for the AMP partnership. So congratulations again on your collective work, the power of this partnership, and I wish all of us a very productive meeting. I'm going to now hand over to Dr. Kibor, and Dr. Kibor is standing in for Dr. Joseph. So Dr. Joseph is the Director of the Primary Health Care at the Kenya Ministry of Health. He'll be joining us tomorrow and giving us an official welcome. But we're happy to have Dr. Kibor here, and Dr. Kibor is the Program Manager for Malaria, but also the Deputy Director for Medical Services with the Ministry of Health of Kenya. And we'll hand over to Dr. Kibor, who will just give us a few minutes of welcome.
Thank you so much. My name is Dr. Kibor Keitan, Deputy Director of Medical Services, Ministry of Health, Kenya, and the Program Manager, National Malaria Control Program. And to acknowledge all partners and program managers, representatives of various organizations that have attended this meeting. I know we were here last year as well with quite a number of deliberations. At this moment, my director will be joining us. As you may be aware, that today is also the World Health Day with the theme of healthy beginnings and hopeful futures. So he is with the Cabinet Secretary and the Principal Secretary, and he will be joining us tomorrow to give his official remarks. For now, I just want to say welcome to Kenya, all of you who are visiting. And just to give you an highlight of the malaria situation in Kenya is that over the last decade, we have managed to bring down malaria by over 50%. And as of 2023, we had a national average of about 104 cases per 1,000, which has since been reduced further to about 84 as of the end of last year and the beginning of this year. That is 84 per 1,000 cases. And that is about an equivalent of about 6% prevalence at the country level. And this is because of quite a number of concerted efforts that is including, of course, top in priority is the use of ITNs, which we concluded a campaign. The last time we were having this meeting, we were in the middle of a campaign, which happens every 3 years, where we managed to distribute about 14.6 million nets through a fully digitized platform. And it was quite efficient because we managed by December, we had closed everything, met all remunerations to the participants, and every household that was registered and eligible to get the net got the net. That was about 4.6 million households, 4.06 million households, and that is a population of about 28 million that was protected from that distribution of the nets. And this, we are certain that everybody received because we were using their mobile phones to come and pick the net. So that was a very successful campaign, which was fully digitized. As we move towards the future, where we have, as we are all aware of the dwindling resources, it will be good to look into ways of replacement of nets. with minimal costs, especially through modalities like community replacement or continuous replacement, rather than putting so much resources in administrative costs that goes into a campaign. Some of the other interventions which are here in Kenya include the indoor residual spray, and some of the regions, malaria in the country, just to assure you that Nairobi is considered malaria-free, or there is no transmission. Of course, it may not be fully malaria-free, because if you got malaria elsewhere and you come here, you will not be free from malaria. But I can assure you that the transmission is zero in Nairobi. However, in some regions, we have up to 748 per thousand in some regions, and some regions like Nairobi is zero. And with some of the high impact interventions like IRS in one of the regions where we did IRS from 2023, we started towards the beginning of 2024. And by the end of 2024, malaria dropped from 738 per thousand to 358 per thousand, which is almost 50% drop in one of the regions, which is Busia. And we, as of last week, we are working closely with our counterparts in the East Africa community and the neighboring countries to also address the issue of cross-border transmission of malaria. And there are quite a number of discussions in that sector to ensure that, the mosquitoes don't recognize the borders that we use as people, and they don't need those passports. So we are including that. So I want to now welcome you officially to this country as well as to this meeting, and mention that the director will be here to make his remarks tomorrow, but feel free to travel around the city. Last time we were here, we were also experiencing some other issues. You might have had the conversation around Gen Z and, expression of, everybody has a right to communicate in whichever way they have, and we've seen in other countries which we didn't know that such demonstrations can take place have been happening in the last week. So this was part of democracy, and but this week it's very calm, so you are free to travel around. There is a national park, we have museums around, and the city, there is a national park that you can visit. And nearby we have Naivasha, there is also Mombasa. So karibuni sana, welcome, wish you great deliberations, and as soon as the director comes in tomorrow, we will invite him to make his remarks. Karibuni sana.
So thank you very much, Dr. Kabor. I'm going to now introduce Irene Kiza, Manager for Health and Care with IFRC in Africa Region. It was a welcome from IFRC.
Thank you so much, Jason. Good morning, everyone. All protocol observed. As introduced, my name is Dr. Irene Kiza. I work with the International Federation of the Red Cross and Red Crescent Societies, that is IFRC, as the Regional Manager for Health in Africa. I'm based here in Nairobi and Karibu. I'm excited to join you this morning on the topic malaria, a very preventable and treatable condition, and yet it's still among the leading causes of child mortalities, particularly in Africa. IFRC, a membership organization, has presence in 191 countries globally and 49 countries in Africa. Its members, that's the National Red Cross and Red Crescent Societies, have an auxiliary role to governments, and they continue to work with the countries and their national public health authorities on several programs towards malaria prevention and control. However, today, I am here on behalf of the IFRC Regional Director for Africa, Mr. Charles Businge, who could not make it because he has certain commitments that require his attention. He was really looking forward to this meeting because he's new in the position. We hope that when he's back in the week, he will come by. But with your permission, allow me to read his opening remarks as was shared with me. So ladies and gentlemen, good morning, and a very warm welcome to each and every one of you. It's a true honor to join you at this year's Alliance for Malaria Prevention annual meeting. The third time we've had the privilege to host it on an African continent since the partnership began in 2008. The Africa continent, we gather here today with a shared commitment, a world free from the burden of malaria. But as we all know, we are not there yet. Africa continues to account for more than 95% of global malaria cases and deaths. Tragically, more than 3/4 of these deaths are children under the age of 5. This is not just a health issue. It is a human crisis that requires coordinated, urgent, and sustainable action. Despite this sobering reality, there is hope, there is progress, as you've heard from our counterparts in Kenya, and across the continent. We've observed a rapid scaling up of the insecticide-treated nets, including the new dual active ingredient, dual AI nets, which are designed to combat the increasing threat of insecticide resistance. These innovations are vital, and we are beginning to see their impact. Evidence now shows that consistent use of ITNs can reduce malaria incidence by between 25% to 60%. Bravo. In this context, I would like to commend the Alliance for Malaria Prevention, a model public-private partnership, for its invaluable role in facilitating ITN use globally. Your efforts have saved countless lives, and we thank you. The Red Cross and Red Crescent movement is very proud to be part of this journey. We believe we are an ideal partner in the delivery and support of ITNs across malaria endemic regions. Whether it's registering households during mass campaigns or
Ik weet niet of het er
doing
nog op zit, want we hebben een paar mensen afgegooid met Don de Man, Moore
or
en
spearheading
Chris
social
connecten. Ja.
mobilization and behavior change communication, we bring value through the deep community engagement and the trusted relationships we have on the ground. Across the African continent and in other regions, the Red Cross provide holistic health services with malaria prevention integrated as a core priority. We have nearly 4 million community volunteers. As Red Cross, we are uniquely positioned to reach remote and underdeserved communities, including those living in the border and cross-border areas who are often the last to receive essential services, if at all. Today, we are joined by over 140 partners, technical experts, national malaria program representatives from more than 20 countries, a vibrant network of stakeholders. Whether you are here in person or participating virtually in the campaign digitalization meeting, your presence speaks volumes about the strength of our collective commitment. This year, as Jason mentioned, the theme, Rethinking ITN Status Quo, Maximizing the Impact on Malaria, is both timely and powerful. As we explore how to do better with less, we must also broaden our thinking. I hope that this MP partnership will expand and reinforce ITN distribution channels beyond the campaigns and routine distribution. Let's look at distribution through established community health networks. Community health structures and networks can ensure timely replacement of the old nets, and that people that need ITNs can access them when and where they are needed. Permit me to emphasize this. The community health workforce, which includes the trained volunteers, the community health workers, and community-based organization, has been a backbone of malaria prevention to hard-to-reach areas. Their role in delivering health commodities and driving social and behavioral change cannot be overstated. Strengthening these delivery systems is no longer an option, it is essential. AMP's true strength lies in the diversity and dedication of its partners, the governments and private sector players, civil society, all of whom are represented here. We remind us that the global challenges demand multi-stakeholder alliances. In today's context, this global context, both politically, economically, coordination and collaboration are our most valuable tools for maximum impact. The Red Cross and the Red Crescent have been part of this journey since its inception, and today, I affirm our commitment. We will stand with you until the last case of malaria is eliminated. Let's continue to build on the incredible work we've achieved together. Let's stay bold in our ambitions, tireless in our efforts, and united in our purpose. Congratulations on the work you've done so far, and on the work we will do together. I wish you all a very productive and impactful meeting. Asante sana, and thank you.
Good, thanks very much, Irene. So now I will invite the the RBM partnership to end malaria. I will invite Hannah Bilak to welcome us. And Hannah is the Country and Regional Support Partner Committee co-chair. Hannah also works for PATH. So over to you, Hannah.
Good morning. Dr. Kibor, Dr. Irene, representing the IFRC Regional Director, Jason and the whole AMP team, participants from national malaria programs, local and global partners, dear participants online and virtual. It's my pleasure to stand here today, and I'm just going to give you a few opening remarks on behalf of the RBM CEO, Dr. Michael Charles. As has been said before, this meeting comes at a pivotal time for our community. The recent shifts in the funding landscape come in addition to challenges that we were already facing: insecticide and drug resistance, climate change and extreme weather events, and conflicts and humanitarian crises. As the needs continue to grow, the resources that are available to us are tightening, and we are called to do more with less. In response to this shifting reality, the RBM partnership has intensified our data collection efforts to consolidate crucial insights in our RBM dashboard to guide our responses. And I would like to take a little moment to thank all of you here and online and everywhere who have been working tirelessly to collect and collate data and key information, to track commodities, monitor stockouts, and keep a daily pulse on key indicators. On a personal note, I want to say that in these challenging times, it has been extremely comforting to see the power of partnership and people really rallying together in a collaborative way to try to address these new challenges. So thanks for that. One key milestone is that we have established a Malaria Incident Management Leadership Group, which is jointly led by WHO and RBM. And this is a group where we can elevate specific needs and gaps, and we can together for a faster and more coordinated responses to these gaps. At the same time, RBM remains committed to other pressing priorities, for example, coordinating efforts to tackle drug resistance. RBM, together with WHO, recently convened a meeting on AMDR. We are also continuing to advance dialogue and action around the integration of malaria vaccines into broader malaria programs. And as I said, the current environment demands a shift in how we work. And I think now more than ever, we need a unified global framework to guide our efforts and to keep us strategically aligned. And this is why the big push is essential. I won't go into the details of the big push because I think you've all heard it before. It's built around 6 pillars. And it aims to clarify roles and responsibilities, to align stakeholders, avoid duplications, and I think very important right now to enable maximization of the resources we do have. It also aims to enable more efficient and coordinated resource mobilization. And the success of the big push relies on country leadership and on us globally ensuring that efforts are rooted in realities on the ground. On resource mobilization, the RBM board has mandated us to intensify those efforts with countries to ensure that gaps are filled, and we will be engaging with countries on this in the coming weeks. So now I will wish you all a very fruitful meeting, and the discussions that will be held here are essential, and I really look forward to taking them back and sharing them with the broader partnership, with our CEO, so we can continue to include this information in how we guide our response and the support that we provide. So thank you very much. Merci.
So thank you, Hannah. Before we start our first session, we're going to do self-introductions. And what we'd ask you to do is just stand up, introduce yourself and your title and the country you're coming from. So I'll ask Miko to start by passing the mic around.
Good morning, everyone. My name is Ambrose. I work with an NGO called Good Life for All. We are based in Kibra.
Good morning, everyone. I'm Valence Nimbona from Burundi.
Bonjour tout le monde. Giovanni Dusabi, consultant AMP.
Good morning, everyone. My name
Good
is
morning,
Geronimo
everyone. This is
Zanamela.
Dr. Muhammad
I'm
Mukhtar from
IMP
Pakistan.
consultant. I'm based in Mozambique, Maputo.
Good morning. My name is Patrick Mburugo, working for the National Malaria Program. I'm Minister of Health in Kenya.
Good morning, everyone. My name is Senule Chafortuné Dayan. I am Malaria SPO for Francophone Africa from the Gates Foundation. Thank you.
Bonjour tout le monde, je suis le docteur Diar, le coordonnateur du PNLP Tchad.
Bonjour, docteur Clément Keraï Nzomé, je suis coordonnateur du projet d'appui à la lutte contre le paludisme au PNUD Tchad.
Bonjour à tous, je suis Olé Bagamla, chargé de suivi et évaluation du projet d'appui à la lutte antipalytique au PNUD Tchad. Merci.
Good morning, everyone. I'm Roch Aikpon. I'm the Deputy Coordinator of NMCP Benin.
Good morning, all. I'm Dorothy Onyango. I'm an AMP consultant based in Mombasa, Kenya.
Good morning, all. I'm Godwin Aiden Agbo. I'm an AMPTA provider. I'm based in Abuja, Nigeria. Thank you.
Good morning. This is Joseph from Chai, Zimbabwe. I lead our vector control work in SADC.
Good morning, everyone. I'm Laurie Abraham at Chai as well. I'm based in the Benin Republic for vector control and entomology.
Bonjour tout le monde. Je suis Dr. Madi Sissoko, responsable prévention, programme national de lutte contre le paludisme du Mali.
Bonjour tout le monde. Moi, c'est Boubacar Sidik Maïga. Je travaille pour Catholic Relief Services basé au Mali.
Good morning. Paul Romosia, National Malaria Program, Kenya. Karibuni.
Bonjour à tous. Médecin colonel Aïsta Kone, je suis la directrice du PNLP Mali.
Good morning, everyone. My name is Dominique Guinaud. I work for Catholic Relief Services. I'm based in Geneva.
Good morning, Cedric Manga. I'm the PSM team lead at Results in Health based in the Netherlands.
Hello, my name is Chris Warren and I am AMP consultant.
Morning, everybody. I'm Kate Kolozinski from the malaria team in the Global Fund based in Geneva.
Good morning, everyone. I'm Molly Robertson, co-chair of the Surveillance Monitoring and Evaluation Working Group based at the Global Fund in Geneva.
Good morning, everyone. Mary Kante with Eau Claire Consulting.
Good morning, Jessica Rockwood, International Public Health Advisors, also AMP Core Group member and Emerging Issues Working Group co-chair.
Good morning, everyone. I'm Alex Heimsch, BASF, responsible for IG2.
Morning, I'm Gitanya Peter from Tanzania NMCP ITN coordinator.
Good morning, everyone. I'm Andrew Glover from Imperial College London in the UK.
Good morning, everyone. I'm Stephen Poyer, Senior Technical Advisor from Tropical Health.
Morning, everyone. I'm Eleanor Sternberg. I'm the Research Manager at Tropical Health, and I'm based in the UK.
Good morning, everyone. My name is Julianne Tangana, and I am based in the UK for Innovation to Impact at Liverpool School of Tropical Medicine.
Hello, everyone. Alex Bowles, Program Officer at GiveWell, based in Canada.
Good morning. I'm Sarah Eustace Guthrie. I do vector control at GiveWell in the United States.
Good morning, Jenna Umlani. I'm a program associate at GiveWell based in the US.
Hi, morning. I'm Neil Gutka, Senior Operations Manager at the Against Malaria Foundation, based in Nairobi.
Hello, bonjour à tous. Julian Austin at AMF, I'm based in the UK.
Morning, everyone. I'm Duncan Kobia. I'm the Senior Technical Manager for Public Health at Vestagard, and I'm based in Kenya.
Good morning, everyone. I'm Christian Natawabin with the NMEP Vector Control Specialist, Ghana.
Bonjour à tous, je m'appelle Neoza Habib, je suis MNI analyste PNUD Guinée-Bissau.
Bonjour, je m'appelle January Ubiage, coordinateur des programmes de lutte contre paludisme en Guinée-Bissau.
Bom dia, sou Mohamed Ulamed, responsável do segmento de avaliação do PNLP Guiné-Bissau.
Good morning, everyone. My name is Stefanos Sharge. I'm monitoring evaluation and country analysis team in the Global Fund.
My name is Emmanuel Busera. I am a research fellow at the Afro-Asia Institute of Strategic Studies here in Kenya. Thank you.
Good morning, everyone. My name is Katin Glove Sichalwe, ITN coordinator from Zambia, and also the MP CD Working Group co-chair. Thank you.
Paul Mwangi, Civil Society Kenya.
Morning, Francis Nyagaka, Kenya Environment and Waste Management Association, Kenya.
Good morning, I'm Robert Opoku, a Senior Project Officer with IFRC and also AMP.
Morning, I'm Marcy. I am the lead for malaria at the IFRC, and I'm the lead for AMP.
Okay, good morning. I'm Joseph Alade. I'm the Surveillance Monitoring Evaluation Officer for Liberia, National Malaria Control Program.
Good morning. My name is Yata Saki Wapo. I work for the National Malaria Program in Liberia as Deputy Program Manager for Technical Services.
Good morning. My name is Tomochu Mando. I work with NMEP Ghana, and I coordinate malaria activities in one of the sub-national regions.
My name is Justus Boachiadom, IT Manager, National Malaria Elimination Program, Ghana.
Good morning. My name is Mark Grabowski. I'm an unaffiliated observer.
Bonjour à tous. Fred Vamy, je suis consultant avec AMP. Merci.
Good morning, everyone. My name is Edson Zandamela. I'm an AMP consultant based in Mozambique. Thank you.
Good morning. My name is Ochai. I'm a digital health consultant, and I'm also working with Red Rose. I'm based in Nigeria.
Good morning. My name is James Dan Otieno. I work with the WHO Country Office. I'm the National Professional Officer, Malaria Epidemics. Thank you.
Dr. Eric Chassa, je travaille pour Inter-Church Medical Assistance, IMA. Je viens de la République démocratique du Congo.
Bonjour à tous. C'est Ngoyi Marius, responsable de la recherche opérationnelle, PNLP DRC Kinshasa.
Bonjour à tous. Moi, c'est Espérance Mbia, responsable de prévention multiple PNLP à RD Congo. Merci.
Bonjour, Joris Liguelan. Je travaille pour 100 rues, PR
Global Fund Malaria pour la RDC. Merci.
Hi everyone, my name is Michael and I'm Director of Research and Product Development for A to Z Textile Mills in Tanzania.
Bonjour tout le monde, Ursula Manibertson, technicien en lutte antivectorielle au sein du Programme national de lutte contre le paludisme à Madagascar.
Bonjour à tous, moi c'est Joelson Rakoutson, je viens de Madagascar et je travaille au sein du Programme national de lutte contre le paludisme.
Yes, Amon. My name is Mukhtar Abdi, Public Health Director, Somalia Ministry of Health.
Bonjour, je suis Mathieu Aoui, je travaille avec World Vision en République centrafricaine, qui est le PIA du projet Fonds mondial.
Bonjour à tout le monde, je suis Patrick Bongo, je suis de la Croix-Rouge française. Je travaille dans le cadre de subventions Fonds mondial dans la République centrafricaine.
Good morning, my name is Andrew Amari from the National Malaria Program, Kenya.
Good morning, everyone. My name is Amy. I'm based in Kenya, and I work for Vestergaard.
Good morning, everyone. I'm Head of Sales Public Health at Vestergaard, based in Switzerland.
Good morning. My name is Harki Semi. I'm based in Nairobi. I work for Vestergaard. Thank you.
Bom dia a todos. Sou Alfa Moyane, ponto focal para a digitalização Programa Nacional de Controle de Malária, Moçambique.
Good morning, everyone. My name is Salim Fak Salim. I'm from Zanzibar. I'm working with Zanzibar Malaria Elimination Program.
Bom dia a todos. Chamo-me Inês Juleca Antônio, Programa Nacional de Controle da Malária no controle do vetor. Obrigada. Moçambique.
Bom dia a todos, sou Mariana da Silva, Programa da Malária Moçambique, plataformas digitais. Obrigada.
Morning, Makori from Civil Society, Kenya.
Good morning, everyone. My name is Uluka Odudufoa. I test vector control products at the Fakara Health Institute in Tanzania.
Bonjour à tous, I'm John Bastow. I live in France near Geneva, and I'm here representing GDM, a dual AI net manufacturer.
Good morning. My name is Apal Toby. I'm from South Sudan, National Ministry of Health, Malaria Program Director.
Good morning. I'm Kidiende Chong. I work for the Ministry of Health, Republic of South Sudan, the Director General for Preventive Health Services, where malaria sits.
Assalamu alaikum. I'm Maturta Mtieng from Ministry of Health, Republic of South Sudan. I'm the Director for Health Information System and Vital Statistics. Thank you so much.
Good morning. I'm Constantino Dogale, Vector Control Focal Person, National Malaria Control Program, Ministry of Health, South Sudan.
Good morning, everyone. My name is Amira Ipen, and I'm a consultant with IFRC, and I am based in Nairobi.
Good morning, everyone. So I'm Matthew Croucher. I'm also working with the IFRC in the regional office based here in Nairobi. Thanks.
Yes, good morning. My name is Francis Kea. I'm from African Alliance for Health Research Economic Development. I'm also the member for the Alliance for Malaria Prevention. Thank you very much.
Good morning. My name is Christine Waya from National Malaria Control Program, Kenya.
Good morning, everyone. My name is Paul Ogozi. I'm a TA provider with MP based in Nigeria.
Good, I think that's it. So thank you very much, Paul, and thank you very much, Miko. Sorry? Oh, there's still, sorry, please.
Thank you. Hi, everyone. My name is Xing Chen, and I'm now an intern at IFRC Malaria team, and I'm also from China CDC and University from China.
Good morning. My name is Elena Coleman. I'm from the Geneva team from IFRC. Thank you.
Hello, everyone. I'm Elisa. I'm the coordination officer for the AMP.
Hi everyone, Oriane from AMP, AMPTA Support Officer.
Okay, thank you very much, colleagues, and welcome once again. So look, I wanted to thank Irene, I wanted to thank Hannah, and I wanted to thank Dr. Kabor for opening our session. I'm going to now, we're obviously a little bit behind time, so we will catch up. I'm going to introduce Alex Bowles, who is a program officer with GiveWell, and he's going to be leading our next session. And that session is Programming ITN Distribution in the Context of Limited Resources. So welcome, Alex.
Hello and bonjour à tous. Thank you so much to the organizers, the team at Alliance for Malaria Prevention, and to our speakers so far this morning for welcoming us here today. And thank you to everyone who's participating, those who introduced themselves just now, and to all of our remote participants. I'm very excited about this session today and the meeting in general. It's my first one, so glad to be here. I'd like to start by introducing our panelists for this session. So joining remotely, we have Dorothy Achu, who is the team lead for tropical and vector-borne diseases from the WHO Regional Office for Africa. We have in person Julian Austin, the operations director from the Against Malaria Foundation, and Kate Kolozinski, who's the senior specialist for vector control from the Global Fund. Today's session, Programming ITN Distribution in the Context of Limited Resources. I'm so glad we have this session. In a sense, of course, this is nothing new, and the malaria community is used to working with not enough resources and not having what we need to do the work we're trying to do. But I do think that this is a new context, and I'm really glad we're able to talk about it today. And I'm glad that in the first part, before the coffee break, we are going to be able to hear from WHO, going to be able to hear from funders. And then after these presentations, we'll have time for questions, both from those of you in person here, as well as from those of you participating online. And then after the coffee break, we'll hear from some more presenters about modeling for different options, as well as representatives from two national programs, Sierra Leone and Congo, about gathering and using data. So with that, I'm going to be brief considering we're behind. So I'm going to welcome our first presenter, Dorothy Achu from WHO Afro, who's going to talk to us about WHO guidance on subnational tailoring for ITNs and optimizing ITN access. Please go ahead, Dorothy.
Thanks so much, Alex. Good morning. Can someone confirm that you can hear me, you can see me?
Yes, we can hear you and see you.
You can see my slides, that's even more important. I can't see the slides, let me put that in slide mode.
We can see your slides.
Good. Just a minute, please. To exchange them. Thank you. So thanks so much for having us, and really apologize for not being able to make it in person and to meet all the amazing people there in the hall. I hope we can have some exchanges after this presentation, which we were requested to deliver as WHO on the guidance on subnational tailoring for ITNs and optimizing ITN access. Slide, please. So just want to, in the outline, first of all, reflect that we are talking about vector-borne diseases as a whole, because we are living in a context where we can't select one of the vectors, which even one of the mosquitoes that are causing us malaria, but there are so many other vector-borne diseases, and the bednet ITNs help in responding to all or some of the other vector-borne diseases. And then to look at the general guidelines around vector control, Then we will have just a few data points on the distribution, the access, the use of ITNs, and then we delve to the subnational tailoring bit of anti-malaria intervention, but specifically on the ITNs and how to prioritize them, and then I'll conclude with some practical considerations. Slide, please. So in terms of vector-borne diseases, as mentioning, they account for about 17% of all infectious diseases, causing over 700 deaths annually, and over 80% of the population at risk. So when we combine all the vector-borne diseases, we have even more mortality than malaria alone, of course. And malaria, specifically, present in 83 countries, caused close to 600,000 deaths in 2023, and of which 76% occurred in children under 5. The vectors for malaria, as we know, are Anopheles species, with over 40 species that are very efficient vectors in the region and globally. But mostly they're endophagic, endophilic, and nighttime. Of course, we have a few that are going out of this definition. For dengue, dengue is one of the most prevalent viral infections that is also causing a lot of morbidity within globally, with over 132 countries affected. It has a lower mortality rate, though, 40,000 deaths every year, but a lot of toll on the health system. It's transmitted by Aedes mosquitoes, which are both endophagic and meganophagic, and also both endophagic and exophilic. And they bite at daytime mostly. Other viral diseases that transmitted by mosquitoes, of course, are the other things that are less prevalent, but also occur in outbreak modes, which cost a lot of resources also to be deployed, like chikungunya fever, Zika, and yellow fever, mainly by the Aedes species, but also the Culex that is causing West Nile fever, Japanese encephalitis, and other viral outbreaks. So there are some emerging risks that are associated to vector-borne diseases, which we have to pay attention to, like the invasive vectors, Anopheles stevensii, and then the changing landscapes that bring other transmission patterns into habitats, such as unplanned habitation, on urbanization that introduces malaria in urban areas, and also agricultural patterns. Of course, we are supposed to also address issues around insecticide resistance. Slide, please. So in terms of vector control guidelines, the umbrella guideline for vector control is the Global Vector Control Response, which goes to 2030, and that it provides strategic guidance for strengthening vector control as a fundamental approach to preventing diseases, and especially outbreaks. So what is recommended is the integrated vector management, which is a rational decision-making process to properly think and optimize the use of available resources to address all the diseases that are plaguing any given country in terms of vectors, and to ensure sustainable vector control. So for the integrated vector management strategy, there is a global strategic framework which recommends 5 elements. First, advocacy, social mobilization, and community participation in even identifying the problems and looking for solutions. Multi-sectoral collaboration, because of course the vector control goes beyond the health sector, and integration of non-chemical and chemical vector control measures. And in that, we will mention housing, we'll mention other methods for vector control that do not necessarily require a chemical vector control methods. And we also have to integrate within the disease control measures Fourthly, there is operational research, entomological and epidemiological surveillance that has to accompany all this. And the human resource capacity has to be built, strengthened for integrated vector management programs. Slide, please. So that said, it brings us to specifically the malaria guidelines, which try to build on that. Slide, please. And this is, sorry, back. One slide back. For some reason, the other parts of this slide are not showing, but I just wanted here to reflect the WHO guidelines that are being updated. And this is the 8th iteration, last November 2024, that provides all the guidance on the vector control tools that are recommended to countries for malaria specifically. Slide, please. So the 2019 edition recommended pyrethroid-only LLINs, but this has, of course, gone through several iterations and revisions, and we are on the 8th edition. So I'll just take you through quickly the various editions and what are the updates. So in 2022, following all the systematic reviews, of course, the pyrethroid PBO nets were recommended, both for use for routine programs, for campaigns, but also for humanitarian emergency settings. Slide, please. In 2023, there was a major revision of these guidelines because although there were very few studies by then, it was very critical given the insecticide resistance levels to adopt the new nets, which have, of course, were proven very effective. It's been said already in the first session. The new nets, which are the pyrethroid clofenapi nets, were recognized as much more effective than pyrethroid-only nets in context of insecticide resistance. So we have this series of revisions to the guidelines. So pyrethroid clofenapi nets are more recommended, should be deployed instead of pyrethroid nets where there is resistance. Also, pyrethroid clofenapi nets should be deployed over PBO nets where there is resistance, and pyrethroid pyroproxifen nets should be deployed over pyrethroid nets, of course, and there is evidence against using pyrethroid pyroproxifen nets over PBO nets. So PBO nets remain very relevant even when there is resistance when compared to pyrethroid pyriproxifen nets. Slide, please. So for the other large-scale deployment interventions, we have the indoor residual spraying since 2019, which is recommended using a product which is pre-qualified by WHO. Of course, we still have issues with the DDT, which has to be transitioned in several countries, but the pre-qualified insecticides are now recommended for malaria programs, especially where there is ongoing malaria transmission. And the indoor residual spraying is also recommended in humanitarian emergency settings to be deployed for prevention and control of malaria. But there is a recommendation against the co-deployment of ITNs and IRS. So prioritizing the optimal coverage of one of them, either the ITNs or IRS, should be preferred and done and encouraged over combining. It is important that one intervention is not used to cover the gaps in the other intervention, but the one intervention should be used and ensure optimal coverage and to high standard before a second intervention is introduced. Slide, please. The other interventions remain supplementary. That's larviciding. Of course, we know larviciding is only recommended when the aquatic habitats that we want to spray are few, fixed, and findable. And this is in very specific settings. And there is also house screening in 2021 that was a conditional recommendation that we can use house screening to protect residents in given homes. And it could give, if this is done in large scale, it could also help in reducing transmission of vectors. But there is, the other two recommendations are recommendations against the use of topical repellents for community level protection, because these topical repellents and insecticide-treated clothing are only good for personal protection and not for a community level protection, public health use. Slide, please. Slide, please. Yes. So I already mentioned about the vector control interventions. What we want to specify here is just the last bullet points that really emphasizes that the dual active ingredient nets were really designed to provide greater protection against malaria than the pyrethroid only nets. And these new nets have been proven to control or to increase efficacy of the intervention by 20 to 50% compared to pyrethroid only nets. And of course, you all know several studies that have been published in that light. Slide, please. So in terms of the distribution and coverage of ITNs, I hope you can read this policy was changed a little bit. Just to mention that since 2000, close to 3 billion nets have been distributed across globally, close to 3 billion nets. But in 2023 specifically, 226 million ITNs were distributed. So it remains, the distribution of ITNs remains a very major intervention contributing to the reduction of malaria transmission and malaria burden. 86% of these 226 million nets were distributed in sub-Saharan Africa. That is about 195 million. And these nets were mostly, almost 80% of them, were the dual active ingredient nets or the PBO nets. So more and more, we are shifting towards using pyrethroid nets. Only 22% of pyrethroid only nets were distributed in 2023, which is great progress. And in terms of coverage, we are also witnessing a great increase in the coverage of nets, with now 73% of households having at least one ITN, and 45% of households at least having one ITN for every 2 persons. And the use rate, which has also increased, 49%, or close to 60% of household of ITNs, of access to an ITN within the household. And the graph on the right really shows this progress of use of nets, even though there was slightly lower number of nets distributed in 2023, sometimes really due to the cycles of the campaigns and not for any particular reason. Slide, please. So in terms of access, again, we are seeing a lot of progress, as you can see from the slide, from the graphs on the right, that's from the World Malaria Report 2024, that shows coverage at 42% in the whole population and close to 60% for use. Those that are sleeping under the bed nets are already close to 60% for children under 5 pregnant women. Slide, please. Slide. So that brings us to how do we prioritize ITNs, especially in this context of limited resources. In 2024, WHO published the guiding principles for prioritizing malaria interventions in situations where resources are limited. And you can find that online on that link provided. And this document is really giving us guidance on how to better target our ITNs in case we do not have enough resources. First, when the funding is insufficient, we need to make trade-offs between choosing effective ITNs, that more effective ITNs, over the coverage that we want to obtain. And even in terms of more effective interventions going beyond ITNs. Several people have argued that IRS is more effective and why we need to deploy that more wider. But in the resource constraint setting, effective coverage is more important, and we can always get that through the ITNs rather than an IRS. And so even using more expensive bed nets, we need to consider these choices. Also, surveillance of insecticide resistance is very important to guide the choice of the vector control interventions. So for areas where deployment of ITNs is most appropriate, the priority should be focused on access to the more vulnerable groups in general. Here we note pregnant women and children, but in other places, we can have displaced population or those in crisis, especially those moving from low transmission settings and moving into higher transmission settings. So the vulnerable groups can always be mapped in each setting, and this should be prioritized. But pregnant women and children should remain priority through routine ITN distribution in all malaria risk areas. And if resources are constrained also, all areas with very low or historical malaria transmission below a prevalence of less than 1% can be excluded from ITN campaigns. And this has been already done by several countries, such as Ghana, Senegal, most of where in urban areas, especially in the capital cities, prevalence rates are less than 1%. These populations have been excluded from ITN campaigns. So it also applies, what we need to be careful is where there is Anopheles stevensii, which has the potential of increasing transmission. So getting the data on the vectors present is very key. So in urban areas, of course, there are other vector control measures that should be associated and that could replace if the prevalence is really low, such as larvicidin, depending on the behavior of the vectors. And in case of larvicidin, there has to be microstratification to target these different interventions. Slide, please. Next slide. So we have already mentioned previous slide. So let me pick up something important from here. Of course, we've already mentioned in terms of in cases of resistance, and this is still from the document, pyrethroid clofenapine nets should be prioritized, and followed by pyrethroid PBO nets, and then pyrethroid pyriproxyfen nets. The deployment, of course, should also take into consideration the resistant status of malaria vectors. It's important to note that where the transmission is stable, countries need to carefully consider how to sustain IRS, because IRS cannot be stopped. And so if the resources do not permit continuing IRS campaigns, there should be a transition to ITNs. And when the changes are made, when either we want to decrease the intervention coverage of IRS or ITNs, when we want to reduce or withdraw any of the vector control interventions, there have to be strong surveillance systems to be able to respond to any upsurges that could come. And of course, there should be a strong case management system in place to address this. So the prioritization is really a continuous process, and it's not a one-off activity. So it depends on the available funding. Of course, it depends on the changing factors, sometimes natural disasters that happen, and the surveillance, the information we get from surveillance. And it also depends on the use of the interventions. If we find out that some of the interventions are not properly used or accepted, then these all can be adjusted. Slide. Slide. So in terms of practical considerations, so there is subnational tailoring a manual that WHO is working on. It's going to be available in the coming months. But these are some of the practical considerations that have been captured to help, first of all, prioritize ITNs, which we have already dwelled on, but I want to talk about the second part on optimizing ITNs. So we have the resources, we have ITNs. How do we ensure that with the quantity of ITNs we have, we attain maximum impact? So it is advisable to target areas of highest need. And that seems very logical, that where there is high transmission intensity, that is where we should focus our ITNs, and exclude areas of very low, either pre-intervention transmission, especially if we already have an effective case management in place. Also, ensuring that underserved populations with high malaria mortality are prioritized, because those that will highly have, it will have the highest impact if we target these underserved populations. And then there is special attention to be given to displaced populations and those that are highly vulnerable, because they are also a source of transmission of the disease. And then where a decision is needed on targeting of more efficacious or expensive ITNs, again, the highest burden areas, especially those which have high risk of transmission, should be prioritized. Of course, these are really repetitions that are important. We need to adapt distribution strategies to maximize coverage. So the operational cost for distributing bed nets can also be reduced to ensure that the intervention is more cost effective. So I'll end with the last slide, which shows that as we deploy bed nets, we need to also consider that we are working within multiple of malaria interventions. And this is a Cochrane review that assembles several studies and to see how using interventions together can really achieve greater impact, making sure that we are associating ITNs with other interventions such as chemoprevention, seasonal malaria chemoprevention, and even the malaria vaccines. So if we have a burden and we have even 45% efficacy of bed nets, when we associate with SMC, which on its own has an efficacy of about 70%, but both combined together give an efficacy of about 78% reduction of burden. And when we apply the vaccine, it gave even a higher reduction. So by combining interventions, we can actually get to reducing the burden in a very significant manner. So that is what we have for you. Slide. Yes, I think you all know how to access all this guidance and documents through either the GMP website or the MAGIC app or the toolkits. Thank you very much. Over.
Introduce Kate Kolozinski, who's going to talk to us about the perspective of the Global Fund. Thank you so much.
get this on. Is that okay? Okay. So I'm going to talk a little bit about the Global Fund perspective on the current situation, what we see as important priorities for our thinking at the moment to prepare for what might be coming next. So I'm going to talk through, if I can make this work. Okay, first of all, a little bit about the current funding environment and how it's affecting the Global Fund as well. Then I want to talk about where we already were in Grant Cycle 7 in terms of funding for vector control and gaps also already for vector control. Then put that in the context of where we are in terms of the time frame towards Grant Cycle 8. And then the second half of the presentation, I'm going to move on to a slightly different framing, which is about thinking through the types of strategic decisions or the types of operational optimization we might need to be thinking about to be ready for what's coming next in the funding landscape. I do have some final topics which are not even about funding, which would be refreshing. Okay, so first of all, the US funding freeze is of course affecting all of the malaria programs that we at the Global Fund work with as well. Partly this is due to the interdependencies at times between the Global Fund grants and the PMI grants in country. So we're spending a lot of time at the moment trying to work with the Ministries of Health and the other partners who are based in country to work out what those vulnerabilities are linked to the US funding freeze, but also noting that the context is changing very rapidly. I know most of you are living this day to day, but with the restart of some work for the life-saving programs, some of those crucial vulnerabilities are changing and shifting day to day. So working out how to mitigate those is something that needs to be an iterative process. So I come later in the slides to thinking about what programs might need to be reflecting on now to make sure that they are preparing for potentially worse funding situations to come. So I just wanted to flag here on the first side that the Global Fund is also doing that at the Secretariat level to make sure that we safeguard as much funding as possible. Whilst there isn't any specific impact on our funding right now, we want to make sure that we are thinking ahead and safeguarding the funding that we do have so that as many of those donor dollars as possible can be used to support the communities that we serve and the HIV, TB, and malaria programs. So we're cutting back on things that just are non-essential, travel, staff benefits, recruitments, things like this. So that's a sort of nitty-gritty amount of detail that may seem strange to include, but I think it's really important to understand that all of us can be thinking now about how to safeguard money to make sure that we are in the best possible situation for what might be coming next. So the Grant Cycle 8 replenishment, as you know, that is on the horizon. We were already, and I think even at this meeting last year, we were all talking about the challenging fundraising environment that we were in. The geopolitical context is changing. Many donor governments are relooking at what they're able to commit to aid funding. It's not just the US government that has got a challenging stance on that. However, having said that, the donor governments that support the Global Fund development have been very strong supporters and very stable supporters over many years. And we are working very closely in conversations with them and still targeting a positive outcome for the Grant Cycle 8 replenishment. But you can all help with that. So having really vocal stories, experiences, and voices, particularly from national governments, will be helpful. So talking really loudly and as often as possible about the criticality of having additional support to these life-saving programs really will be helpful. So I encourage you all to lend your voice to the efforts that are happening at the moment. But really, just to conclude on this topic, the main message is that we are all clear now, I think, that the financing context is evolving and evolving rapidly, and it's probably going in a downward direction. So we need to think right now, even though grants might not have changed yet, we need to think right now about how to adapt and plan and be ready for what may be coming. I don't want to press it too many times. Okay, there we go. That's odd. Some of the numbers haven't come up. But this was just to show the sizes of the investments for Grant Cycle 7 And I think I know some of these numbers. So on the big pie, on the far side, that's showing the totality of funding for Grant Cycle 7 that was signed as of the beginning of this year. The big green section is vector control funding. There's about $1.8 billion invested in Grant Cycle 7 in vector control programming. The smaller middle circle breaks out that vector control programming into the different implementation areas. And the biggest slice is for campaign distribution of nets. The other slices are continuous distribution, ITNs, larviciding, things like this. But really, more than 3/4 of the vector control funding, and the vector control funding being more than half of total malaria funding, is for campaign distributions. So having these kinds of conversations that we will have this week about how to make sure that money is spent as efficiently as possible and as optimally as possible is really, really important to safeguarding the impact that can be achieved in the Grant Cycle 7 grants. And then on the right-hand side, I just wanted to remind us all that even before the current challenging situation with USG funding, there were big, important gaps. So most programs have already been working out how to deliver malaria programming in a context of limited resources and gaps. And really now we just need to accelerate that conversation and really dive into some of those ideas and thinking that had already been happening. On the next slide, when it comes, I'm going to talk about the time frame towards Grant Cycle 8. So we're in 2025 at the moment. This is really just a reminder for us all to understand when more visibility might come on how much funding is going to be available going forward. So we're in the middle of all these conversations I've referenced about discussions with donor governments, and towards the end of 2025, probably now in Q4, there will be the replenishment conference where we really get to see how much money is going to be available for Grant Cycle 8. So implementation for Grant Cycle 7 continues, of course, but then 2027 will see the start of Grant Cycle 8. And it's unclear to us at the moment, to all of us, what the funding might look like for that context, but it should all start to become clearer through 2025. Okay, so I'm going to move on to the second section of discussion, which is really giving some perspectives from the Global Fund side on what type of thinking might be needed now in the context of really, really constrained resources. So the main message, I would say, is that we would really encourage open-minded, broad-minded thinking as to how to program whatever malaria money there ends up being. So thinking about, like, relooking at everything, relooking at channels for distribution, frequency of distribution, modalities for allocations of nets, quantifications of nets, target groups. We have, as a whole community, moved quite far to a status quo of campaigns every 3 years with intercurrent ANC and EPI distribution. And I know Global Fund certainly has been encouraging that. Campaigns are the most efficient way of getting equitable coverage of insecticide-treated nets, and that's why we as a community moved towards so much reliance on insecticide-treated net campaigns. And that was possible when there was the scale of budgets that we had. With new budget scales, we might need to move to rethinking and relooking at many approaches we've used in the past before we move to such a reliance on campaigns. So taking a really open-minded approach to what might work in each country context will be important. And also just framing that with the idea that if a campaign is coming up very soon, then of course any changes that a program considers trying out will need to be will need to still safeguard the success of that campaign. So basically no giant changes in the couple of months before a campaign, of course. But having said that, there are different things that should be considered. So I'll come at the bottom to some ideas that we are expecting and already discussing with many programs. But just to put up front some things that we assume are going to be embedded across all programs, even though other adaptations might be made. So first of all, we do assume that programs will continue to prioritize net access to biologically vulnerable groups, so to pregnant women, under 5 children, and as Dorothy said, people who've moved from lower to higher transmission areas, or migrants in complex operating environments. and to prioritize the inclusion of some kind of continuous distribution, given the absolute criticality of having nets continuously available between any other bigger distributions. We also, and Dorothy mentioned this too, stress that even though there might be many programs considering pulling back net distributions from urban areas and trying to take a differentiated approach to urban health, that in areas that do have a serious Anopheles stevensii threat, there will be an important need to maintain some kind of vector control in those settings. And also reiterating something Dorothy said, in areas of pyrethroid resistance, we still assume and encourage, and in fact, probably more than encourage, that pyrethroid-only nets should not be deployed in areas of pyrethroid resistance. So even though reverting to a cheaper net might be one of the things discussed in programs about how to deal with lower budgets, we would not support that. It is absolutely essential that in areas of pyrethroid resistance, we continue to provide the best net possible as the best way to avert most malaria cases. Again, some of this is things that Dorothy said as well, that any scale back of vector control, so if budgets get so bad that there are areas of moderate or high transmission that really can't receive any vector control, then we do need to assume that there will be an upsurge in malaria cases and be able to identify that, so some kind of data collection that will allow us to see that when that happens, and have a plan in place to respond to it with a buffer of case management commodities. And certainly, in particular, where IRS is stopped, we have all seen that in real time, that when our IRS is stopped, we may expect quite important upsurge in cases. So those places really should be top of the list for getting nets, and certainly getting chlorphenapyr dual AI nets. So then beyond that, there are a range of directions programs could consider going in, which don't need to be the same thing in each country, don't even need to be the same thing across one whole country. And I want to make it clear that the Global Fund would be open to a whole range of different ideas that that programs might want to propose. Sometimes there is a perception that the Global Fund really just wants to see campaign, ANC, EPI. We are very open and encourage, and desperately hoping for, in fact, some differentiated ideas, that's an odd phrase, but some different and open-minded ideas as to how you can make the most impact with the available funds. So that might mean differentiated approaches for different transmission level areas. It might mean doing some campaigns in some areas, but maybe with fewer nets. We don't need to target universal coverage. The WHO guidelines are very clear about talking about optimal effective coverage rather than universal coverage. Just because you don't have enough nets to do a universal coverage campaign doesn't mean it's not worth doing a campaign with lower numbers of nets. Or perhaps you could target certain age groups within a campaign distribution. You could consider changing the frequency of your campaigns, but channel diversification, I think, is the really important one that we need to think a lot more about. So making sure that there is stronger reliance on continuous distribution probably will be the main feature of malaria programs going forward, I imagine. So there are many continuous distribution channels which give us a lot of flexibility to respond to whatever money is available, the number of nets available. If you do school-based distribution, if you have X number of nets, you can distribute to years 3, 5, and 7, and if you only have Y number of nets, you can still use all the planning that you've done and distribute to just year 3 and year 5 or something like this. There's a lot of flexibility in these channels. You could use some of the things we've used in the past, child health days, mobile clinics, basically thinking about every contact point between a program, beyond the malaria program too, maternal and child health programs and EPI programs and the child, and making sure that we optimize those opportunities. I forgot to put my timer on. Okay, and the monitoring and evaluation, we'll have other sessions on that, but we do need to evolve our monitoring and evaluation to give the information that we need to take decisions. And we're going to have, there's already a lot of thinking in place about how to go about that, but that continues to be very important. And then this slide gets a little bit more detailed into terms of operational efficiencies. Now, this is not to say that campaign distributions were not already efficient. I think we have spent years honing the campaign approach and trying to make it at least as efficient as possible. And this is also not about cutting activities that would impact potentially the quality of the campaign. Optimizing a campaign budget is about trying to get the best possible outcome. And the best possible outcome isn't just nets being bought and put somewhere. It's about how many people receive nets and how many people use those nets. So we're not trying to encourage cutting of activities that are required for quality of your outcomes. We're trying to encourage efficiencies that will take advantage of some of the experience that we've built over the years, take advantage of some of the opportunities of the digital platforms, take advantage of how certain countries have tried things perhaps in complex operating environments, perhaps during COVID-19, and worked out that they were doable and had impact. So it's drawing all of that together and taking it very seriously in terms of looking forward. So we would certainly hope that all programs with any upcoming campaign, even if budgets have not yet been impacted, look at their operational plans and revisit them based on how much time is available before the campaign, to really consider seriously any potential ways of optimizing the available budget. Integration opportunities, of course, we've been thinking about for several years, but need to be taken extra seriously, and look at whether there are opportunities at all stages, from planning straight through to delivery and surveillance. And also noting that even within a country, it doesn't need to be one size fits all. Do what you think is needed in that setting, but if it isn't needed in another area, don't do it. So for example, if you know that in certain areas, net use given access is very good, you don't need behavior change communication in those areas. Target it to the areas where you know you have some concerns with net use given access. So looking at specific ideas, single-phase campaigns can be, we think can be more efficient in some places, but potentially not everywhere. So look at what might be right for your setting. For communication activities, SBCC is one thing, but of course campaigns need communication. There need to be messages getting out there when the campaign is, how to receive your net, where to go and receive your net, and who are the targets, especially if you are changing your approach from a previous campaign. Fully acknowledge that there will need to be quite careful messaging about why suddenly it's only under 5 children who are eligible for a net, or something like this. So that kind of communication will be important, but there are ways to do that most efficiently with the money. So not spending a lot of money on printing of leaflets or costly TV spots, but relying on cheaper interpersonal communication, community-led messaging, or other activities. We think digitalization, of course, I think we probably all agree, will continue to be an important way to realize efficiencies. But there will be challenges with that, and there will need to be careful looking at how to keep it affordable within what might be really quite restricted future budgets. But there are opportunities. I mean, I've included a range of different ideas here, but things like where you do your meetings, what warehousing facilities you use, reducing training days, and all of these are drawn from experiences in certain countries that have successfully managed to adapt their budgets and take out things that weren't critical. So I think my last slide, there we go. So now I'm moving on. So that is it really in terms of our views on how we need to adapt to the changing funding landscape. And before I move on to this kind of scattergun other few points, I do just want to close out that piece and say that the main message is that it really is very likely to be much more challenging going forward than it has been to this point. So even if budgets are not yet changing now, it is so important that we all are already proactively considering how we are going to adapt in future and not wait to be in 2026 and planning for a 2027 that looks a lot different than it does now. So these last couple of points, just to flag some other moving pieces in the vector control world at the Global Fund. There is a new quality assurance policy for vector control products. I think we've mentioned that at the Vector Control Working Group meeting, so this probably isn't new information. But just to let you know that there are requirements in that vector control policy about things like insecticide resistance monitoring, post-marketing surveillance, traceability, but that there is full understanding that there will need to be a period of transition to alignment of program activities with the requirements of this policy. And our quality assurance team and our supply operations division will be working closely with programs to make sure that it's achievable even in the current funding landscape. Resistance to damage scores are something that we're very excited about the potential of and keeping our eye on. So it's not something that we are changing any practices on at the moment, but it's something that we think is a really important conversation, and we'll be looking closely and taking part in the future WHO conversations on that. ITN packaging, this is really an important current activity that we're working on about how to ensure we can get back to bulk packaging for nets in campaign distributions or even high throughput continuous distributions like schools. So at the moment, as you all know, Global Fund's only providing dual AI nets in individual bags, and we're working with partners. UNICEF are leading a big piece of work on this as well. We're working together to try and find our way through the various issues that have brought us to this point, to get back to a point where we can provide bulk package nets for campaigns. And we understand that is very important to avoid waste, to avoid the waste management costs, but also the effort involved. The level of effort involved in some of the waste management activities is almost like a second campaign, and we can't continue in that way. So we're trying to focus on making improvements there. And then just lastly, on the clofenapir dual AI nets, as you all know, there was a period last year and the first half of this year where supply was really tight, given the rapid change in demand for different net types. But we have come through that now, so supply is much more flexible for clofenapir dual AI nets. So just to flag that any countries who are still considering a switch of their future plans for not yet ordered nets can still discuss the option to move to clofenapir dual AI nets. Of course, they're more expensive, so saying that at the end of a whole talk about budget constraints is maybe problematic, but countries who have planned PBO nets can probably consider changing them to clofenapir dual AI nets without much budget impact. And going forward, of course, we will be strongly encouraging that any future nets planned in insecticide resistance areas are the most effective nets. I think I will stop there. Thank you.
Thank you so much, Kate. And now I'll hand over to Julian for our final presentation of this session from AMF.
Thanks, Alex. Thanks, Kate. And thanks, Dorothy. And morning, everyone. Thank you for inviting me to speak. It's brilliant to be here at such a critical moment in global health and malaria. One of the things I love about the AMP conference is how interactive it is and how people feel really comfortable to share their experiences in all their unpolished glory, as it really helps us to improve. And each of us here has a key role to play in ensuring we don't lose those gains that we all fought so hard to achieve, and that we continue to bring malaria down. So it's fantastic we're all together discussing solutions, and I echo Hannah's sentiment that's been so nice to see how the community has really stepped up and collaborated together to try and find solutions. And I also agree with Kate that we're going to need to be creative here. Today I'm going to talk about how AMF works with partners to use data in a resource-constrained world to ensure that we protect those most at risk with the funds that we have. So, as I said, resource-constrained. Even before the USAID announcements, WHO estimated that there was a $5.3 billion gap in malaria control. And clearly, the USAID cuts have significantly added to those financial pressures without changing the challenging landscape that we were and still are in. We've heard about insecticide resistance, anti-malaria resistance. We've got this new species, Stephensii, and more internally displaced people due to climate change and conflict. So with that context, it's never been more important that we strive for the greatest possible impact with every intervention. AMF works with countries and funding partners to make sure our funding protects those most at need. And data can help with this along all stages of our process, which are shown here. I'm going to talk through some examples of how we use data at each stage to try and do more with the funds we have. But before doing so, it's important to mention that when we get it right, there's actually a positive feedback loop that is created, because the data that we generate and use with partners combined with transparency can lead to increased fundraising. And I'll talk more to that later. So first off, on funding allocation and program design, we have to choose which countries we'll support. And that typically means going to where the malaria is highest. We start off by looking at prevalence and incidence, mortality too, in many cases, and focus on identifying the communities at highest risk from malaria. But specifically, we're particularly focused on those communities at highest risk that would otherwise not be protected without AMF support. And that's also an important part for our donors who want to be sure that we're filling gaps in mass campaigns and not pushing funding into other things. Now on that, I just want to say that is not at all to say that at AMF we don't see the value of a holistic approach to malaria prevention. We absolutely do. You know, all of the tools in the toolkit are fundamental and should be used. The point is really that we as AMF can contribute most effectively by raising funds to fill gaps for mass campaigns. So it really boils down to who across the continent is unprotected in the highest risk areas. So far, that's led us to supporting the countries in blue, which is 8. And as you can see, we're willing to work in challenging contexts, such as South Sudan and DRC. In terms of program size, it's probably fair to say that between 30 small programs versus 10 large programs, our resources are more effectively deployed with 10 large programs. But that's not at all to say that if we reach 10, we would stop. Not at all. And our door is always open to hear from countries who have gaps in their mass campaigns. So let's take the example of Chad. The national program alerted us to the fact that they had a gap for their 2026 campaign. And you can see in Chad that the malaria prevalence varies significantly from the Saharan provinces in the north down to the south, where the malaria rates are very, very high. And with the funding available, there was a gap of 24 million. And the 48 million there needed, by the way, does already exclude the lowest burden areas. And that meant that with what was available, only the green and grey areas were able to be protected. Just in case you're wondering, some of the lower burden areas were included there for humanitarian reasons or political reasons. We looked at this and we saw that there were approximately 8 million people in the high burden provinces that are currently unprotected. And we discussed with the national program, we discussed with the Global Fund and with our donors, and thanks to a fantastic donation from GiveWell, we were able to bring over $20 million of funding to enable these 8 million people to receive nets, and those are the blue provinces that you can see. So in practice, how does that actually look? Because AMF's model is to fund nets, and then we work with co-funding partners to fund the distribution costs. So what we do is we fund more nets than are needed for just the blue provinces that you can see. And what that does is it enables the Global Fund to then fund fewer nets than they were planning to, and that frees up funding in their budget to cover distribution costs for all areas. So that is shown here, where you can see that the way this is going to look in reality is that AMF will fund 8.4 million nets in 14 provinces, and the Global Fund will fund the distribution costs for the blue and the grey provinces. So this is an example of subnational tailoring, which we strongly support. This is primarily at province level, but there are also 3 districts in Jamena that have been included due to them being in flood-prone areas. So just a nod to the importance of that data to help target interventions. And you'll see that there is still a gap that remains, but from our perspective, if there were 3 million of funding to be made available, that would be better spent filling gaps in communities at higher risk in another country. And these are very difficult decisions that are required in a resource-constrained world, and we don't claim at all to always get it right, but we try to be very thoughtful and rigorous with the process that we follow. So with the design of how many nets in place and where they'll go, the next step is to decide on which nets and to procure them. We view insecticide resistance as one of the biggest threats to global malaria rates. And so, in our view, getting the right net for the specific distribution and its resistance profile is really critical. But there are also broader considerations about not accelerating resistance to insecticides and making the best use of global resources to ensure that new nets can be deployed where they are most needed. So we perform, the typical process always starts with discussions with countries, and then we move to net selection, which is quite a complex process that brings together a wide range of data. First of all, we have the entomology data, and we should just take a moment to say a big thank you to PMI for all of the work they've done on this. They've really led the way, and we as AMF have massively benefited from by being a user of that data, which has informed the net choices that we've made over the years. And I completely agree with Dorothy on the importance of that entomology data continuing even in a resource-constrained world, even more so potentially. We also look at malaria burden, and then upstream we have information that is coming from suppliers through net tendering, things like pricing, capacity, timing, registration status, etc., etc. And then we also look at the studies that are available, either RCTs, operational research, durability monitoring, and we bring all of this together to analyze which type of net would be most cost effective. And once we've done that, we go back to discuss with the country to reach final agreement before placing the orders. I'm just going to talk a little bit about the types of nets that we've bought over time, because it shows just how much we are open to buying new and more expensive nets where that's supported by the data. We were the first organization to buy PBO nets at scale in 2016. And as you can see, when dual AI nets have become available, we've transitioned to them where the resistance data has shown that they would be more effective. And the work that Kate and the Global Fund did was so brilliant in ensuring that volumes were made available quickly. And so we've all been able to scale up as a community. Fostering innovation is really important. We're constantly in this fight against the mosquitoes who are changing quickly, and we see it as critical to have a pipeline of new tools. I think our contribution here is not so much as a funder of the innovation itself, but more as a early adopter of new technologies and a user. And so we have, we've been an early purchaser of new nets, but we're also following very closely the resistance to damage work, and we have been piloting GS1 barcodes as well. We're also very supportive of generating data from nets in use in real life settings, and we are looking at how we as AMF could contribute to increasing that pool of data. So with the nets purchased, the next step is to optimize coverage. And we have found that digitization helps in so many ways. You'll hear more about this, of course, on Thursday and Friday. It can be a heavy lift for a country, the first time transitioning from paper, but with support from AMP and their excellent toolkits, we've seen that it's possible to do even in places like South Sudan and Chad. And for example, we see that things like built-in data checks into the software can really result in better data quality, and that means that nets go to where they're needed. It also means that over time we can improve the population estimates, which is really valuable in terms of commodity auditing when resources are tight. And dashboards, of course, enable national programs to monitor progress in near real time and take action where needed. And the system being digital, Kate talked about this, it gives us and programs the agility to adapt to changing situations. So this is an example where registration data is showing a net need that is greater than what was planned. And you can simulate different capping scenarios, work out what's most appropriate, and then put that into the tool and adjust quickly. And also in humanitarian emergencies, we can adapt the vector control tools, and we'll hear more about that from Dr. Joris tomorrow. So once the nets are out, we conduct post-distribution monitoring surveys, and we sample households and villages to be visited randomly from the registration database. And that means that we can check if nets are getting to the most remote households. And that's really important because they're often the ones at highest risk since they tend to have lower access to healthcare. And it gives also the data, we provide these indicators, of course, to the national programs, which gives them indicators also over time. And this is an example from the DRC, where we could see that the nets were wearing out quicker than in other places. The use and coverage is actually very high, but it's the physical condition that could be better. And after sharing the results with the PNLP, they decided to move to a 30-month distribution schedule. But it's also prompted us to look at targeted communication activities to maintain good net condition for longer, because we agree that with what Kate said, that we really want nets to be lasting longer rather than doing them distributions every 2 years, and the resources are not going to enable that. So if we could find a way that would mean that the nets can last longer, then we could save money by doing distributions less frequently. And finally, the post-distribution monitoring provides AMF and donors with information collected independently on the programs. And we've recently updated our website to include summaries from all of the post-distribution monitoring surveys that we've done, and this is an example of one of those. And that makes the link back to donors, because there really can be this positive feedback loop aligning programmatic and funding incentives, since the data our partners use and generate, combined with transparently sharing, can lead to increased fundraising. So this is a screenshot of our public dashboard on our website, and if you were to give $10 to AMF, we would use 100% of the money to buy nets, and you can see our financial accounts tick up in real time. So they would tick up by $10. And if you click on your personal donation page, you can also see the status at any point of the nets that you funded. So whether they're being manufactured, whether they're on a boat, or whether they're currently being distributed. And we have literally thousands of donors around the world, and it's probably reasonable to say that a lot of them work in professions where they're using data on a daily basis. And we've found that sharing data transparently on the program can be very powerful, as it builds donor confidence and means they're more likely to stick with us. This helps drive up fundraising so we can do more, and we get into this kind of virtuous cycle that means that long term we can work with partners to protect more and more of the communities at the highest risk from malaria. Thank you very much.
Thank you so much, Julian, and thank you again to all of our speakers so far. So we are going to take 10 minutes for Q&A now. All of their presentations, by the way, will be up on the website by the end of the day, so if you're interested to follow up on those, they'll be there. So any questions from the floor? Do we have microphones? If you just want to put your hands up to ask a question, if anyone wants to ask a question, and a microphone will come to you. Please go ahead.
Thanks a lot for the presentations. Very strong start to the meeting. Julian, I'm going to put you a bit on the spot as an early adopter and a partner that maybe has more flexibility on procurement. When I do the math, I estimate that we're 0.003 cents per night at a $3 net that should last 3 years. So I'm assuming $1 per year, 365 days. If I upped the cost of that net to $4.50 to get a net that would last longer, I'm at 0.004 cents per night. Is there any thought from AMF about pushing for a net that would last us for 3 years? Because it seems that would be one of the ways we could be more effective and optimize the distribution and the impact we have on malaria transmission. So I know it's a hard question, but I do think we have to think more beyond just trying to cut operations and looking at where we can actually achieve effectiveness, efficiency, and optimization in terms of malaria transmission. Thanks.
Julia, do you want to answer that one first, and then we can get more questions?
Just working? Yeah. Marcy, you're here to ask the hard questions. I'm glad you are doing that. It's a great question, and I think the answer is that if there was a net that lasted much longer, we would be really, really interested in that. And the key bit would be the cost differential, because that's the thing that defines essentially how cost effective it is compared to your existing nets. So in your case, it was, I think, 0.01 cent more per night. So if you could find that, you would essentially be looking at the trade-off between what's the additional cost and what's the extra, duration. And that's the, those are the kind of trade-offs that we're doing all the time in terms of our net procurement. So, we would love to get stuck into something like that. I think actually the folk at, Kate might be able to correct me on this, but the folks at VKA are working on a more durable net with sort of like reinforced sections. So yeah, the answer is that we would definitely look at that, and we'd be really, really interested in it, because it may well be that it's more cost effective than the standard nets. Of course, you'd have to sort of be able to show that the chemical durability was also there, because the physical durability provides the barrier, which is critical, but we also want to be, well, even more critical actually is the chemical side of things, which is that we're bringing down the mosquito density and therefore protecting others in the community who might, either from biting at day or that might not be sleeping under nets. So there would be the questions on both the physical durability and the chemical durability over time. But if we could get confidence in that, there's absolutely no reason why I wouldn't be really interested in looking at it like that. Thanks. Did you want to say?
Yeah, I just wanted to add something to that so that we don't forget that in the past, maybe 5-10 years ago, we did have a net that was developed to be a longer lasting net. I think LifeNet was it called? Maybe someone else can remember. And it was a stronger net. It was more expensive. We did not buy it. So the opportunity we have now with the resistance to damage scores is that we're better able to say, this is a longer lasting net, it costs more, but this is better for value for money because it really will translate into a longer lasting net in the field. We didn't have that before, and it was a major stumbling block as to how to justify paying more for a net that might not actually last longer in the field. But we've moved on from there, so hopefully we can do better next time.
Thank you. Any more questions from the room? I think we have some over there.
Yes, thank you very much. My name is Francis Kea. I'm from African Alliance for Health Research Economic Development. My concern is about, like me, I'm from the Lake regions, Victoria, where the malaria is the talk of the days. In fact, I wanted just to ask you that this technology, we need it at rural there, because when you go at rural there, you'll find that a woman is just buying a net without even, the net is not treated, it's just using a net without any medicine on that. So we need this technology in that rural areas, and we really appreciate it. Thank you very much.
Thank you. Just to make sure we understood the question over here, was that about, you were asking about the use of untreated nets and the value of bringing insecticide-treated nets?
I'm talking about the treated nets, yeah.
Okay, thank you. Does anyone want to comment on that? Do you want to collect a few questions? Yeah, sure. Any other questions? Yep, over here.
Yeah, thanks. Appreciations to all the presenters. I'm Kidian Chong from South Sudan. And it's really wonderful to see where we have been all these years, from moving with the different types of nets to the best that is being recommended, and also seeing actors like Global Fund and the AMF clearly giving some guidance with regards to the choice of nets and the interventions and so on. My point is what we have been facing, and in my country, and I guess many other countries are facing the same. Definitely we have seen that the bigger the population, the bigger the amount of nets that goes to that country. South Sudan is expecting 9.5 million nets. Chad is slightly ahead of us with I just want to bring to our attention that it might be time for us to also speak about what happens after we distributed the nets and they completed their efficacy period. On the other words, about the disposal of these huge quantities of nets that we are bringing to countries. We have seen that many countries are struggling with how to dispose the nets after they're used. The impact of bringing all these huge quantities of plastic into the countries, the impact on the environment, the lives of the people. We have the good intention and the objective of controlling malaria. For us in South Sudan, we are 100% at risk of malaria. Malaria is the #1 enemy for us, and we can do whatever it takes to fight it. But as we do this, we are also bringing another burden to the environment, to the lives of the people. And I haven't seen, even from WHO, what was shared, Global Fund, and even against Malaria Foundation, any tips on what would happen. And definitely there is a cost that would be associated with that. How do we plan to tackle that going forward? Thank you.
Thank you very much. Any more questions in the room? I think one over there.
Thank you. I had a question about distribution and distribution costs. So, as I understand it, AMF have relied in the past on PMI and Global Fund. So with the PMI changes, will Global Fund kind of pick up that slack? Or what are the other thoughts on those distribution costs? And then also on the ENTO monitoring side, it sounds as though that's going to be more and more important if coverage reduces. So what are the thoughts on how the entomological surveillance will occur? Thank you.
Thank you. I think we have time for one more question, and then I'll ask our panelists to respond.
This is just a comment from, especially on the Global Fund guidance. I would have loved on efficiency to see how we can also promote net repurposing, considering the constraints we have in net distribution using durability studies. How are we addressing issues of net repurposing as part of the mechanism to make sure that our old nets are put to proper use? In addition to that, we have some information on end of life for mosquito nets. How do we make sure that we scale it up, considering that we have many nets coming in the communities? Lastly, we have had several durability studies. How do we use this information in the implementation to increase the number of years for these nets in the households? The problem is not about procurement. The problem is net use. The problem of net use is a behavior component. So when you compromise SBCC, automatically we are affecting the results. So are we procuring nets for use, or we are procuring nets as a mechanism of delivery? The answer for all of us, we are procuring nets to make sure that we maximize benefits by having more focus on net use and care. Thank you very much.
Thank you so much. As we are behind time, we're going to stop there and just ask if any of the panelists want to respond to any of those questions, and then we will go to coffee.
I'll go first and hand to Julian and also perhaps Dorothy. Is Dorothy still online?
I think so. Dorothy, are you still, is Dorothy online?
Yes, I'm here. Yes, I'm here. Thank you.
Great. Okay. So first of all, there was a comment about how on high transmission areas with high EIR around Lake Victoria, that you see such high demand for nets that people are going out and buying untreated nets. And I think that's really important to put in context of the fact that what you're seeing is there a genuinely really high demand for the insecticide-treated net as a tool. And that's something we need to keep responding to and making sure that the nets are available, but also noting that people are getting their nets from different places. And going forward, you know, I was talking a bit about the importance of considering channel diversification and thinking again about how we lean into that really high demand and the fact that people are willing to go out to buy a net, even in this case an untreated net, but leaning into that and using that opportunity to make sure that the nets that are supported by the government are in the right places for the people to access them, and perhaps re-looking at some of those channels that we have moved away from more recently. There was a couple of comments about end-of-life nets and making sure that they are dealt with appropriately, repurposing, things like that. I think we have a great session planned on Wednesday, a technical working session on end-of-life use of nets, repurposing, waste management. I encourage all of you to take part in that and actively brainstorm together about how to best manage what is genuinely a very challenging situation of an awful lot of plastic being put into communities. So whilst I did talk about the individual bags, fully acknowledge that the individual bag is a minor piece of the plastic content of the net distributions as a whole. But perhaps this is something that Dorothy could answer on, perhaps about the plans for WHO recommendations on waste management, which I think are being looked at. The entomological monitoring, it really is important that there is data being collected that will help programs understand what impacts is being faced by budget cuts and changing scope of programs so that they can respond to that. So that is, of course, something that a lot of people are considering quite carefully, a lot of programs considering carefully with other partners as to how to make sure they have access to the right data, but in a cost-effective way, collecting the data in a cost-effective way. So certainly insecticide resistance monitoring is going to remain a critical piece of information to inform decision making. But yes, I think countries will just need to look closely at what data they need to inform an actual programmatic decision and work out the most efficient way to get that information. The distribution costs for AMF. Yes, so I think, that is a challenge, of course, and these are some of the interdependencies I was talking about with the Global Fund grants, where there are AMF nets that are, that are part of a program's plans, but are relying on US funds for distribution. We're really welcome the waivers that have been announced recently and the increasing movement towards flow of USG funds in some of those places. So we're hopeful that some of that will ease up those tensions. The Global Fund grants are still focused on delivering the Global Fund grant outputs and priorities. So at the moment, that's the situation, but certainly going forward, we're having close discussions with AMF and donors about how to make sure that interdependencies going forward are as safeguarded as possible, and certainly the opportunity for partnership between AMF and Global Fund is greater than ever. I'm going to pass over to Julian for anything else you would like to add.
I think you've said it all. Yeah, we are very focused on those urgent gaps that have been created by the USAID situation. We're talking very, very regularly. The situation, as I'm sure you're aware, is changing, rapidly. But there have been some positive movements recently. I think, yeah, we will continue to focus on it, and we're really keen to explore all options to make sure that those nets, and particularly those ones where there's time sensitivity, can continue, and so that people can be protected. I'm just going to.
Yeah, I just wanted to ask whether Dorothy wanted to weigh in on any of these questions, for example, the waste management.
Well, probably not specifically on waste management. I think on the management of used bed nets, AMP and other partners have some clear guidelines that they will share during this meeting. But the approach of WHO is usually a holistic one that gives guidance on how to reduce the generation of waste, but in case there is waste, really address it in a holistic way. And there are guidelines which you can look up online. I just wanted to rather address two other points for on the opportunity to use the high demand in nets, especially in urban settings, to strengthen other distribution channels through social marketing. This has been, kind of neglected, but there is really an opportunity there, especially when resources are constrained, that those who can pay, who can afford, and who are really in areas around, especially in urban settings, that have high transmission, should be given the opportunity to have high quality nets rather than procure untreated nets. And the other issue around net use is key because there is really complaints that these nets are being distributed, but in certain areas they are not used. I think we have cleared that controversy. It shows that more people who have access to nets actually use them. So for those that do not use them, usually those in urban settings, are probably those who do not even need them because transmission is very low and they don't have so much malaria in families, and those that can access if they have, or they can have access to case management. So the use of bed nets should be integrated even in the funding of campaigns. Of course, there is the SBCC aspect, which is usually funded during campaigns where there is really resistance. But this is really not much of an issue in many campaigns. Thank you.
So much, and please join me in thanking all of our speakers today for a really excellent session. We are now going to take 15 minutes for coffee. Those of you who ask questions online, by the way, we will try and follow up on those questions afterwards, ask the speakers to follow up on that. So we'll take 15 minutes, so please come back at 11:45 for the second part of the session. Thank you so much, everyone. Great, thank you, and we'll start the second part of this session. So just 1 minute. Thanks, everyone. Well, actually, I think we can probably go ahead start now, given that we're quite far behind time, and I want to make sure that everyone has a proper lunch in due course. So we're going to continue with the agenda. Just one small change is that we'll save the Q&A for this session until the end. So it'll all be one Q&A at the end of the session, just before lunch. So I'm really pleased to welcome our three panelists today. So two of them in person and one joining us remotely. So we have Andrew Glover from Imperial College London, Musa Silakanu, a Senior Monitoring and Evaluation Officer from the National Malaria Control Program in Sierra Leone. And then joining us remotely, we have Jules Moricel Matondo, qui est chargé de suivi et évaluation PNLP Congo. So yeah, thank you very much. Looking forward to the session, and I'll introduce Andrew to start with the first presentation.
Hi everyone, so I'm Andrew Glover and I'm here from Imperial College London, and today I'm going to be talking about some modelling work that we've been doing on how best to maximise impact with ITNs in this ever-changing world that we're in. So this presentation is basically going to be split into two halves. The first half will be largely looking at, was universal coverage achievable with the status quo? And now moving forward, how can we best achieve optimal coverage? So I won't go into too much detail on this, given it's been covered a lot already, but guidance has sort of recently shifted from advocating for universal coverage towards advocating for optimal coverage. Sorry, there we go. And as I'm sure all of us in the room are aware, 80% was typically regarded as a minimum target for both use of and access to ITNs. So, as was discussed previously, as we're moving towards trying to achieve optimal coverage, this will require various trade-offs on maximizing coverage and effectiveness of different products. So, was universal coverage even achievable under the status quo that we had of 3-year mass campaign strategies? So to look at this, we fitted use and access models to DHS data and MIS data for 6 countries. We were doing this on a subnational scale. And I'm not going to go through all of the model framework in detail, but one thing I quickly want to highlight is that for all regions in all countries, we sort of estimated a similar pattern where we will have the highest level of use and access immediately following a campaign, and that this will decay relatively rapidly. And that's why surveys, when viewed in isolation, can be misleading because they ultimately are just snapshots in time. And this also highlights how difficult it is to sort of ensure universal access is maintained over time, because the epidemiological impact will be dependent on not just the use immediately after a campaign, but over that whole 3-year period. Yes, and this was just highlight that we did have a lot of sub-regional heterogeneity, which I won't go into detail today. So what's driving that decay in use and access over time following a mass campaign? Well, we found that estimated that out of all of the subnational regions, there was only a single region where the mean duration of use was greater than 3 years. So what do I mean by the mean duration of use? I mean, how long is a net on average used for? So that is a different concept to what we typically think of about retention time, which we typically think of in the context of access. However, from an epidemiological perspective, the duration of time that a net is actively used is of far more importance. This difference between use and access, given that we are estimating that nets typically remain accessible for longer than they're used, results in use given access also declining following mass campaigns. So to sort of get an understanding of what sort of levels of use are achieved over 3 years following a mass campaign, we kind of generated estimates of use by every month and looked at what the average level of use is over a 36-month period following a mass campaign. And these maps are showing our central estimates for use under 3-year campaigns at current procurement levels. I should also emphasize strongly that in all of these scenarios, we are assuming routine use, and the level of routine use has been fitted in the model to DHS data. So then if we actually just take an average across all of the regions, under three-year strategies, the overall mean use is around 47%. Increasing that up to 2-year intervals could slightly increase our overall use, but that would be requiring the same procurement levels at more frequent campaign intervals. And if we look in the context of access, the situation is slightly improved, but we can see that we are still far short of the historical 80% targets. However, if this loads up, there we go, look in the what the picture is for use given access, the picture is far more positive, with a significant number of regions having a mean use given access above 80% over 3 years following a mass campaign. And that can be sort of improved even more under 2-year intervals. So this sort of highlights that even in areas of low access, many people will, in most regions, there is still optimal use given access. Nope. Okay. So now the next section of the talk, I'm going to talk about how can optimal coverage be achieved. But firstly, I want to kind of make a little point on what do we mean by optimal coverage. Universal coverage was very, very clearly defined by this sort of 80% target that we tried to reach. Optimal coverage is a more complicated concept to define, and there are different definitions that are sort of being discussed currently. The way we have approached it, we have viewed optimal coverage as the coverage that would maximize epidemiological impact. That is not the same as maximizing coverage itself. So I will quickly skip over those slides in the interest of time, but I would like to highlight this slide, which is under our modelling, we wanted to try and identify common characteristics between countries that were associated with the greatest impact of either switching to more frequent mass campaign intervals or more effective, albeit more expensive ITN products. So the top row is showing pyrethroid only ITNs, the middle row is showing pyrethroid PBO, and the bottom row is showing pyrethroid chlorpheniapirnets. Just highlighting these slides, we are referring to these as pyrethroid pyrrole, just because pyrrole is the class of insecticide. So as we can see, there's a very clear relationship between this is showing the baseline transmission intensity and the additional benefit that we'd expect to be gained by these alternative strategies over and above 3-year pyrethroid-only strategies. However, we didn't see anywhere near as clear a relationship with the additional benefit gained in relation to use given access or retention time. Sorry, it's a bit slow for moving forward. There we go. So I'm now going to talk about that. I'm just going to emphasize these were results from over 6 months ago when the world was in a very different place. So this next slide is sort of focused on how can we maximize impact under a fixed budget that we don't necessarily expect to be reduced. So this slide is looking at what could we do under a reference budget that we peg at the cost of conducting 3-year pyrethroid-only campaigns in conjunction with routine distribution channels. I should also highlight, don't get too focused on the actual numbers of cases versus. These are, strictly speaking, case days that were presented here, but the takeaway message should be viewed as what is the relative change between the different strategies. So just as an example, I'm going to talk through Burkina Faso. That's just a map of prevalence for the country. Oh, that's not loading that very well. Okay, it's now loaded. So what we initially looked at was, given that pyrethroid-chlorphenapine nets are more expensive, to remain within a reference budget, which here we have set at 37.5 million. The way we achieved that was to maintain routine distribution at exactly the same level, but reduce the number of nets distributed through campaign channels. So that resulted in us estimating that we could avert around 30% more cases within the same budget if we stick with 3-year campaign intervals. Now, we also looked at whether we could move to 2-year campaign intervals, again, with more expensive chlorphenapine nets, and still remain within budget. So again, we maintained routine distribution at exactly the same level. We did not make any reductions to the number of routine nets in circulation, but we did have to reduce the number of nets distributed through campaign channels by an even greater amount, given that these are now conducted more frequently. So we did estimate that that could potentially increase the number of cases slightly over 3-year intervals. One thing I would like to highlight, we have since refined our estimates for the decay rates of chlorphenapine on nets, and 3-year campaign intervals is actually in more recent results is looking more promising. So that while we don't think we are overestimating the impact of 2-year campaign intervals in this slide, we are potentially slightly underestimating the impact of them under 3-year intervals. Sorry, this is just very slow. There we go. So we then wanted to examine what, unfortunately, is probably never going to be a situation we'll ever be in, but what if we were able to maintain procurement levels at the same level, use more expensive nets, and even distribute them more frequently? So under that scenario, if you look at the bottom right map there, we were estimating that you could double the number of cases that ITNs that could be averted by ITNs. And even though the cost is far greater, it is still not double the cost. But as I say, unfortunately, that is more than wishful thinking. And finally, in the context of fixed budgets, we explored scenarios about whether we could potentially maintain campaign coverage at the same levels in higher transmission settings and deprioritize some regions from mass campaigns, but still maintain routine distribution in those areas. I'd also like to emphasize that we are always assuming that routine nets in use are the same net class as campaign nets. So again, all of these maps here are for chlorphenapine nets, both in campaign and routine contexts. So focusing on the maps on the right, we can actually then predict that the most cost-effective strategy purely in terms of cases averted per US dollar would be the bottom right. So that is where we have tried to maintain the same level of coverage in as many regions as possible with 2-year campaigns with chlorphenapir nets. But that has required us to deprioritise some regions from campaigns. The regions that are deprioritised can be as shown with the cross-hatched areas and the slanted areas. That just indicates whether it's urban or rural settings that are being deprioritised. I should also highlight, even in this example, that some of those areas have actually deprioritised rural settings over urban settings in those areas. That is largely just an artifact of the optimization algorithm that we use, which basically just finds a little bit of money left over in the budget to distribute some nets through campaign channels in urban contexts in those settings. But in reality, we probably wouldn't recommend deprioritizing a rural setting over an urban one. One important thing that I want to highlight from this slide is that slight orange region that you can see in the bottom right. So that indicates that we are estimating that there would be a slight increase in cases in that region, even though at the national level it's the most cost effective. So that highlights that when we are moved towards thinking more about subnational tailoring, we sort of need to sort of think, carefully about what not only is the most impactful strategy, but what is an equitable one. Okay, so now this slide, sadly, is becoming more realistic. So here we this is more recent work where we have investigated changes to the budget again. This is showing the number of case days. It's just shortened cases there for all scenarios. So again here we distribute routine ITNs in all scenarios, and we do not change the level of routine ITNs distributed. So these are our projections of what potentially could happen with 25 and 50% reductions sticking with pyrethroid-only ITNs. So to account for that reduction in budget, we've maintained routine at the same level, but we've had to reduce the number of nets distributed through campaign channels. So underneath each map, I've shown the estimated procurement ratio for campaigns. So the reason why it's 1.7 for the baseline scenario rather than 1.8 is it's just estimated from our model, and there is still a lot of uncertainty around that figure. But nevertheless, we are sort of estimating that we could be looking at potentially up to remain within that budget. We'd need to look at moving just under procurement ratios of just under 4 people per ITN for campaigns, and we have a substantial increase in the number of cases. So, how about in the context of PBO? Slightly better picture. So, if budgets remained unchanged with PBO, again, that's achieved by a slight adjustment to the campaign procurement ratio to account for them being more expensive than pyrethroid-only nets, but it's still, with no change to the budget, it's still a positive picture. When we consider a 25% reduction, we actually estimate that with the 25% reduction in budget, the central strategy with PBO nets would avert a similar number of cases as 100% of the budget with pyrethroid-only nets. So the way that was achieved is routine was maintained again at exactly the same level, but the number of nets procured has, per campaign has been reduced, and so that results in an increase in the ratio of people per ITN procured. Unfortunately, though, for 50% reductions of budget, PBO nets alone can't mitigate a reduction in cases relative to the sort of very historical status quo of 3-year pyrethroid-only nets. And finally, a more hopeful row should be loading up soon. There we go. So then we looked at chlorphenapia nets, which gives us sort of cautious hope for optimism. So here, again, we modelled 25 and 50% reductions in budget, and for a 50% reduction in budget, we are estimating that a similar number of cases could be averted with chlorphenapia nets than sticking with pyrethroid-only 3-year campaigns at historical levels if there was no change in budget. So that has required us to enormously scale down the procurement ratios for campaigns. So here, this was modelled for 4.5 people per ITN procured. But again, routine nets are still maintained at the same level, so they are doing now a lot of the heavy lifting in terms of averting the largest number of cases. Now, this still isn't necessarily a great picture. Ideally, we'd want to be on the bottom left of this of these figures here. And additionally, I do also recognise that we're not really, our starting point isn't using pyrethroid-only nets everywhere. We're kind of probably more along, the position we are at now is probably the centre left / bottom left with some areas with chlorphenapia nets. But when we think about optimal coverage, I cannot stress enough, please, 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 do not think that means maximising coverage. Maximising coverage, if that is your aim, will take you to the top right map, the top right figure in this map. For optimal coverage, the reality may be, if there were significant cuts, for optimal coverage, we want to maximise the number of cases averted within financial constraints. And we are sort of estimating that that could be achieved by switching to chlorphenapia nets, by significantly reducing the number of nets distributed per campaign. So what that means is that optimal coverage in this scenario is actually lower coverage, because if you wanted to have higher coverage, you were just focusing on distributing as many pyrethroid-only nets everywhere. But for optimal epidemiological impact, we are estimating that lower coverage is more optimal, because we need to remember that the main epidemiological effect of a net is not protecting the individual, it is protecting the community. And to make best use of that, we are estimating that, that resources should be focused on chlorphenapia nets. I do also want to caveat, we have only conducted these simulations with budget reductions for Burkina Faso, which obviously is an area of moderately high transmission and high pyrethroid resistance. But in our previous sort of results, when we were working with fixed budgets, we did see that, estimated that chlorphenapia nets outperformed both PBO and Pyrrol under fixed budget scenarios in low to moderate all the way up to high transmission settings with less clear evidence in very low transmission settings. So I don't have much time to talk through 2-year intervals, but the results are very similar now to 3-year ones. So just finally, some conclusions and final thoughts. Okay, so universal coverage was not achieved consistently anywhere, but was briefly achieved after mass campaigns in most regions. When we start thinking about where we should be focusing on subnational tailoring, transmission intensity best predicts the impact of switching to more regular campaigns and or better nets. So prioritizing higher transmission settings may be optimal under fixed or potentially reduced budgets. And finally, if you're just going to take away one message from this presentation, please remember this. Switching to fewer but better nets could avert more cases for the same cost or similar numbers of cases under reduced budgets. And that's all. Thank you.
Thank you so much, Andrew, for that great overview of the potential power of using the right tools in the right places. And so now I would like to introduce our next speaker, Musa Silakanu, who's going to talk to us about the experience in Sierra Leone with using data and different approaches for targeting interventions. Thank you, Musa.
Good afternoon, everyone. My name is Musa Silakanu. I'm head of Malaria Surveillance Monitor Evaluation of the National Malaria Control Program, Sierra Leone. So I'm here to present our experience with the use of data for decision making. Of course, malaria in Sierra Leone is endemic everywhere. We have a perennial transmission. Of course, even though we have a perennial transmission, the levels of transmission is not the same everywhere. I mean, we do have some pockets of low transmission, moderate transmission, and then high transmission. So what we have been doing before was doing like the one-size-fits-all, wherein all interventions are the same everywhere. But now we see that if we continue with that, it's very difficult for us to demonstrate what we have done. So, and with the idea of now prioritizing what we do because of budget constraints, we thought it wise that instead of doing district level implementation, we have thought it wise to go a step further down at chiefdom level, where in one district may have 10 chiefdoms, 9 chiefdoms, 15, as the case may be, so that we actually know where we have pockets of high transmission, moderate, low, and very low. So, okay, thank you. Yeah, so now our strategic plan is also expiring this year. So going forward, we want to get a better understanding of the malaria epidemiology in the country. And then also, as I said earlier, with the funding proposals that may come up, we need very robust evidence that will inform our intervention targeting. And then, of course, this is also very necessary during the budget negotiations for grant proposals, and then also the implementation. Okay. So we have been implementing IRS in 2 districts, Bo and Bombali, with support from PMI. So what we are doing now is for us to see how we can target IRS, not only in these 2 districts. So we have, if you go horizontally, we have the criteria. We're looking at the incidence of the disease, and then the vector biting rate of the insect, and then the insecticide resistance, and then we have hard to reach areas. I mean, hard to reach in the sense that some of them, due to geography, we have rivers or they are mountainous areas. And then vertically, we have like the options that we also consider, like option 1, option 2, option 3 in the case of IRS. So option 1 looks at the incidence, wherein if any geography has more than 1 confirmed case of malaria, it's being considered eligible for IRS. And then, of course, for the vector biting and resting, so that also is one of the contributing criteria for that area to be eligible for IRS. And then, of course, the insecticide resistance also, and then also when an area is hard to reach. Option 2 looks at the case incidence of malaria, wherein we started with the moderate based on the WHO classification of malaria transmission. Moderate is 250 to 450 confirmed malaria cases per 1,000 population. So if an area is within this moderate transmission, and then also the biting rate, biting and resting, the resistance, and whether the area is also hard to reach. Option 3 looks at the high transmission areas, wherein the case incidence is more than 450 per 1,000 population. Of course, with all the other criteria, biting rate, biting and resting, insecticide resistance, and hard to reach. So, if you look at the malaria transmission, the first map tells you, as I said, we've gone down below district level so that we can get a better understanding. So you can see the colors that tells us about low transmission, moderate, high, and very high transmission. So for hard to reach areas, based on the definition, you can see they are colored yellow as hard to reach areas. These are the areas where you have community health workers that do ICCM. They suspect, they test and treat for malaria cases. The easy to reach areas, they are the white colored. We also have CHWs, community health workers, but they do promotion of malaria and other program interventions. And then, of course, the rainfall is just to tell us when we think that these areas can be, we can carry out these activities, okay? And the biting rate. And then we have widespread resistance, to the insecticide. Entomological resistance, yeah. So continue with the IRS targeting and then the application of this criteria. We say when the incidence is more than 1 case per 1,000, and then you can see now everywhere is qualified, because in Sierra Leone there is no area that cannot report a single case of malaria for a whole year. So you can see if we use that criteria, so it's like every area is eligible for IRS. And then, of course, the vector biting, the insecticide resistance, the hard to reach. The second option talks about the moderate transmission. You can see the yellow colored chiefdoms that are eligible for IRS. And then for indoor, of course, every area, we have indoor resting behavior of mosquitoes. Okay, yeah, of course, the hard to reach again, at the end you can see. And then for the 450, which is high transmission, you can see how we only have few pockets of chiefdoms that are eligible. So meaning, depending on the budget that we have, so this can actually inform if we think that if we do not have enough funds for this area that have 450 or more cases of confirmed malaria cases, we can prioritize them. As I mentioned earlier, we have only been doing them in IRS in 2 districts. So with the cut in the budget, we can even reduce that amount and only target those that really need to bring down the transmission level very drastically. Okay. So options to select IRS. Option 1, we can see where we think about out of the 208 chiefdoms or zones in Sierra Leone, we have 74 that are qualified for IRS. That is when the incidence is at least more than 1 case per 1,000 population. We consider the vector biting and resting, the insecticide resistance, and then hard to reach areas. Those are the chiefdoms that are eligible. So option 2, we also have, 48 chiefdoms that are eligible for IRS, that when the incidence is 250 to 450, confirmed case by 1,000, combined with the vector biting and resting, insecticide resistance, and then hard to reach. So option 3 only have like 5 chiefdoms that are eligible. So for us now, I think we have considered option 2 as the best for now. I mean, if we are going to do IRS. So for ITN mass campaign, that ends the IRS. For ITN mass campaign targeting, we have 3 options also. We consider incidents, vector biting and resting, IRS areas, and then urban areas. Option 1 looks at the incidence when it is more than 1 case per 1,000, the vector biting, and then, option 1, sorry. So IRS areas for mass campaign, they are going to be excluded if we are going to do mass campaign in areas that are going to benefit from IRS, if at all. They will not be part of the areas that will do mass campaign. That's the first option. The second one, the incidence is also more than 1 case per 1,000 population, looking at the biting rate, and then exclude Western area urban. Going forward, we think that we have been getting a lot of challenges in urban areas, and now we think that we should go a step further to do micro-stratification in urban areas so that we can get optimal coverage of ITN distribution during mass campaigns. Option 3 also talks about 1 case per 1,000 population, the biting rate, then exclude IRS targeted areas, and then we also exclude Western area urban. So these are the 3 options for mass campaign. So we can look at the maps. We have the malaria transmission that talks about case per 1,000 population, the biting rate, the burden, which is in terms of the urban areas, for 1 case is almost everywhere, so it means it's eligible. And targeted areas targeted for IRS, option 1 for as a placeholder. So just put it there to see. For mass campaign, basically, we are going to exclude the urban areas, especially Western area urban. There are areas that receive IRS. And then for the targeting, we say incidents, of course, everywhere is qualified, all the 208 chiefdoms and zones. So for vector biting and resting, of course, all of them again, because we have indoor biting and resting everywhere. So in areas where we exclude IRS targeted areas, we have only 74 chiefdoms qualified for mass campaign. And then when we exclude Western area, all districts, like 200 chiefdoms and zones are qualified, only Western area urban that should be out of this. So in terms of selection of the options, of course, option 2, we think that is best for now for NMCP, wherein only Western area will be excluded. School-based distribution. Of course, we are all aware that it's one of the channels for continuous distribution, in addition to through EPI and ANC services. So we piloted school-based distribution of ITNs in Kono in 2023, and then it came out to be very much successful. That informed the scale-up of school-based distribution in other districts. We have 16 districts in the country, but so there was need for us to provide justification, for us to actually give reasons as to why we select District A and leave District B. So what we did was by then before this detailed work. So we looked at, of course, the incidence, the prevalence measure in 2021, which was population-based, and then also we looked at the access to ITNs. Okay, we used those three criteria, and 3 districts were qualified for all. Cambia, Tonkolili, and Pujong, all of them had low access to ITN based on the MIS 2021. And then the malaria prevalence, also they had high, above the median value for malaria prevalence. And then also the case incidence. So all of them qualified. So they were selected for the SBD. So the SBD that we will be doing by May, June this year, we use only those 3 criteria to select them. Well, as I mentioned earlier, it's high time we started drilling down to see, even within those prioritized 3 districts, there are still chiefdoms and zones that do have moderate and even low transmission. So going forward, for SBD targeting, considering IRS options for criteria, option 1 looks at the case incidence, which is 1 per 1,000 population, looked at no prevalence, and then IRS areas only. Option 2 looks at the prevalence and then IRS, excluding IRS. Option 3 looks at only the access to ITNs, which is less than 45%, and then also exclusion of IRS. 5 looks at the case incidence, which was the average by then. It was 217 in 2022. So the prevalence is 228.8, and then also areas excluded for IRS. So if you look at the maps, you have the malaria transmission map, the malaria prevalence map, and then ITN access. Then now we have added hard to reach areas, and then areas targeted for IRS have been brought into the equation, and then also the seasonality by rainfall. Sorry. Okay, sorry. Now, the incidence, if we look at it, sorry, the first one should not be 450, it should be 1 case per 1,000 population. So everywhere is qualified for SBD if we use the criteria of the incident that says 1 case per 1,000 population. Every chiefdom or zone is qualified. For the prevalence, we have only Falaba and the Tonkolili district, if you look at only the prevalence. And then for low ITN access, we have Koinadugu, Tonkolili, Port Loko, Cambia, Pujong, and Pujong. We have those 7 districts. And then if we exclude the IRS, we have a limited number of 74 chiefdoms that will be qualified for school-based distribution. And then the map, I don't know what's happened with that map. But basically, look at the incidence wherein it's like 250 to 450. You have a number of chiefdoms and zones that are qualified. And then when we add the prevalence. If you look at the prevalence, and then the incidence that is 450 is only 19 chiefdoms that will be eligible for targeting for school-based distribution. So the options are given. What we have identified is option. Oh, sorry. I hope I'm. Yes. So for now, it's the third option that looks at the prevalence and then in the 7 districts. But this, as I said, is dependent on the budget that is available. Otherwise, we'll still have the option to look at we still have the opportunity to look at the other options. If what is provided for school-based is not enough to cover these 7 districts that we have selected. So for routine IT and targeting, ANC and EPI, the criteria that talks about malaria transmission, more than 1 case per 1,000 population, like every area is eligible. Okay, but if you look at just the transmission, so we have some pockets of these chiefdoms that we can prioritize. So the last one, if you look at it, you can see that the targeting chiefdoms for ANC and EPI district, I-10 distribution, all the 208 chiefdoms and zones are eligible for continuous distribution. And then the choice of net, since we have insecticide resistance, widespread insecticide resistance all over the country, we think that using IG2 net is the most effective way of, choosing IG2 net is more preferred than using the pyrethroids or standard net. So this is a list of participants or organizations that have worked on this piece of data use. The WHO Global Malaria Program, we have WHO Country Office, we have WHO Afro, Clinton Health Access and Initiative, in-country and headquarters, Northwestern University, Ahadi, and Imperial College, PMI Evolve, and then START SL. Thank you for listening.
Thank you so much, Musa. A really great overview of the way of layering different layers of information can provide the kind of flexibility to adjust depending on budgets and maintain an optimal approach. Okay, so we're about to move into our third presentation of this session. We do have a change of speaker. It's going to be Dr. Nyonga Bikuta, who's joining us remotely. And the presentation will be in French. And so if you need English interpretation, please do use the headsets on your table. Dr. Nyonga, est-ce que vous êtes là? Do we have Dr. Nyonga?
Oui, je reçois.
Ah d'accord, parfait. Allez-y, s'il vous plaît.
D'accord, merci beaucoup. Alors, je suis le docteur Nyonga Bikuta, entomologiste médical NLP. Et le travail que donc nous allons présenter, c'est le résultat d'une étude en OK. Donc,
Est-ce que vous pouvez essayer encore?
J'ai des problèmes avec la présentation. Qu'est-ce qui se passe? Le Japon. Japon, s'il vous plaît. Les Japon, s'il vous plaît.
OK. Un moment.
Oui.
Pardon.
Ok, merci.
Ok.
Merci beaucoup. Alors, donc, le plan de la présentation est le suivant. Nous avons un contexte, le contexte dans lequel donc s'est réalisé cette étude. On vous présentera la méthodologie, les résultats préliminaires que nous avons obtenus, ces résultats qui seront discutés, et enfin, nous tirerons une conclusion. Japon. Bien. À travers le monde, selon le dernier rapport de l'Organisation mondiale de la santé, s'il vous plaît. Japon. Non, vous êtes allé trop loin. Vous allez trop loin. Nous sommes au contexte. Non, Japon. La première Japon. Ok, celle-ci. Merci beaucoup. D'accord. Bien, selon le dernier rapport de l'Organisation mondiale de la santé, 263 millions de cas de paludisme en monde et 1 327 964 au Congo. Les principaux vecteurs du paludisme sont Anopheles gambier et Anopheles toloides. Et au Congo, nous avons adopté principalement dans la lutte contre antivectorielle l'utilisation des médicaments. Japon. À travers le monde, en Afrique subsaharienne, entre 2000 et 2019, 47% de l'incidence paludisme a été réduite. Et ces progrès sont en partie attribués à l'utilisation des moustiquaires imprégnés. Au cours des dernières décennies, la taux de dégâts est passé de 5% en 2000 à 70% en 2022. Japon. Aujourd'hui, de nombreux pays distribuent gratuitement la moustiquaire imprégnée dans le cadre des campagnes de distribution. Au Congo, tous les 3 ans, des médias sont distribués en campagne de base. Et en 2019, les 2 dernières distributions, 2 640 360 millions de moustiquaires ont été distribués. Et entre 2022 et 2023, 3 528 000 dents ont été distribués. En plus de la distribution de masse, les moustiquaires sont distribués en routine aux femmes enceintes lors des CPN et aux enfants de moins de 2 ans lors des vaccinations. Japon. Cependant, l'efficacité des moustiquaires repose principalement sur la sensibilité des vecteurs aux insecticides. Et cette sensibilité, elle est cruciale dans la lutte contre cette maladie. Cependant, nous avons constaté qu'il y a de la résistance des vecteurs aux insecticides depuis, on va dire, 2010. Japon. Donc, pour garantir l'efficacité de ces médias, il est primordial de connaître la sensibilité des vecteurs aux insecticides. C'est pourquoi nous avons donc mené cette étude qui avait donc pour objectif d'évaluer l'efficacité des médias contre les anophèles du complexe gambier, qui sont les principaux vecteurs du Plasmodium, agents pathogènes du paludisme, et d'identifier les mécanismes qui étaient associés à cette résistance. Japon. Donc, cette étude a été menée entre le mois de décembre de l'année passée et le mois de mars de cette année dans 5 localités du pays, à savoir la ville de Brazzaville, la ville de Pointe-Noire, la ville de Dolisie, la ville de Ouesso et celle d'Evo. Diapo, s'il vous plaît. Diapo suivante. L'objectif donc a été de collecter des larves de moustiques dans des gîtes larvaires, élever les larves et de l'élevage à l'insectarium.
Can someone fix that on the Zoom side?
Diapo. Donc, après la collecte des larves et l'élevage, nous avons réalisé des tests de sensibilité, principalement avec deux moustiquaires. La moustiquaire Olycénète, la moustiquaire Olycénète qui a été distribuée en 2019 et la moustiquaire Interceptor G2 qui sera distribuée lors de la prochaine campagne de distribution, mais qui est déjà distribuée en routine. Donc, les tests ont été nous avons réalisé des tests d'efficacité avec ces moustiquaires-là. La prochaine étape, comme je vous l'ai dit précédemment, c'est une étude en cours. Donc, la prochaine étape de cette étude sera donc d'identifier les vecteurs et d'identifier les mécanismes de résistance impliqués au cours de cette impliqués par les vecteurs. Diapo, s'il vous plaît. Ces tests d'efficacité des MILDA permettent d'évaluer la mortalité des moustiques pour voir si les moustiques réagissent à ces moustiquaires-là, meurent lorsqu'on les expose, mesurer la persistance de l'insecticide. Est-ce que l'insecticide utilisé réagit et est efficace au cours du temps et détecter des éventuelles résistances des anophèles. Diapo. Donc, nous avons réalisé ces tests avec 120 moustiques exposés pendant 3 minutes pour chaque moustiquaire. Et la mortalité a été évaluée 24 heures après. Et lorsqu'elle était supérieure ou égale à 80%, on pouvait dire que la moustiquaire était efficace. Diapo. Bien, les résultats que nous avons obtenus sont ceux qui sont présentés ici. Par exemple, ici, présentement, vous avez les résultats de la ville de Brazzaville où nous avons testé la moustiquaire Olycénète à 24 heures et la moustiquaire IG2 ayant une activité lente dans le temps. Donc, nous l'avons évalué la mortalité jusqu'à 72 heures. Les résultats présentés ici montrent que la mortalité a été comprise entre 47% et 90%. Et la mortalité la plus élevée a été obtenue 72 heures plus tard avec la moustiquaire Interceptor IG2. Elle était de 80%. Diapo. Dans la ville de Pointe-Noire, nous avons effectué aussi les mêmes tests. Cependant, avec la moustiquaire Interceptor IG2, nous n'avons pas pu faire les tests jusqu'à 72 heures, mais à 48 heures, à 24 heures, la mortalité, elle était de 4,8% et la mortalité avec Olycénète, elle était de 48,6%. Diapo. Dans la ville de Dolisie, les mêmes tests ont été réalisés. Donc, les taux de mortalité étaient compris entre 35 et 95%. La mortalité la plus élevée, 95%, a été enregistrée avec la moustiquaire Olycénète à 24 heures. Et la plus basse, elle a été observée avec la moustiquaire IG2 à 24 heures. Mais elle s'est étalée dans le temps, elle a progressé dans le temps jusqu'à atteindre 77,5%. Diapo. Dans la ville de Ouesso, les taux de mortalité, eux, ont été compris entre 1,5 et 86,25%. Les taux de mortalité le plus bas a été obtenu avec donc, la moustiquaire IG2 à 24 heures et celle-ci a progressé jusqu'à atteindre 86,25% à 72 heures. Enfin, les résultats Diapo de la ville d'Evo. Diapo, s'il vous plaît. Dans la ville d'Evo, Malheureusement, les tests n'ont pas été réalisés jusqu'à 72 heures, mais cependant, les résultats obtenus montrent que la mortalité avec IG2, elle était à 7,5% à 24 heures et avec Olysénète, elle était à 42,5% à 24 heures. Diapo, s'il vous plaît. Que nous montrent alors ces résultats? Ces résultats montrent que les taux de mortalité varient énormément, ont varié d'une localité à une autre. Cette différence permet donc mieux de comprendre les caractéristiques de chaque type de MILDA et de pouvoir donc stratifier comment mener la lutte antivectorielle, Diapo, s'il vous plaît. Les moustiquaires Olysénète, concernant les moustiquaires Olysénète qui sont imprégnés à la permétrine, elles ont montré une mortalité comprise entre 42,5% et 95%. Cette efficacité relative peut être attribuée à la libération progressive de la permétrine, bien que la résistance ait été observée dans de nombreuses localités entre 2010 et 2016 par le PNLP. Diapo. Concernant les MILDA, les moustiquaires intercepteurs IG2, qui seront distribués en masse et qui sont déjà distribués en routine auprès des femmes enceintes et des enfants de moins de 2 ans, elle comprend donc deux insecticides, l'alpha-cypermétrine et le chlorphénapyr. Le chlorphénapyr ayant une action lente. La mortalité, donc, comme je vous l'ai présenté dans les résultats, a été évaluée jusqu'à 72 heures pour voir quelle était donc l'action de cette moustiquaire. Les résultats ont montré que la mortalité était croissante au cours du temps jusqu'à atteindre plus de 90%. Donc, ces résultats montrent bien que cette moustiquaire-là est efficace dans des conditions où la résistance est observée. Diapo, s'il vous plaît. Comme la résistance au pyrétronoïde a déjà été observée dans ces localités entre 2010 et 2016, des études qui ont été réalisées par le PNLP, l'utilisation de cette nouvelle moustiquaire donne de l'espoir dans le fait de résoudre le problème de la résistance dans ces localités où celle-ci est observée. Diapo. Bien, en conclusion, que pouvons-nous dire? L'intercepteur G2 présente une faible efficacité initiale à 24 heures, mais son effet s'accentue progressivement jusqu'à 72 heures, ce qui confirme l'action retardée du chlorphénapyr. Donc, la prochaine étape de cette étude consistera donc à identifier les espèces du complexe Anopheles communautaire, comme je vous l'ai dit, qui sont les principaux vecteurs du paludisme dans le pays, et d'identifier les mécanismes de résistance impliqués observés dans certaines localités. Diapo. Il est par conséquent essentiel d'intégrer progressivement l'évaluation de la sensibilité des vecteurs aux insecticides pour assurer la pérennité et l'efficacité des campagnes de lutte. Pour approfondir cette étude, il sera nécessaire de faire une étude comportementale des anophèles. Ainsi, Diapo, je vous remercie de votre aimable attention. Merci beaucoup. Voilà, nous avons terminé.
Merci beaucoup pour cette présentation impressionnante et merci aussi pour l'avoir fait en 12 minutes, très impressionnant et merci beaucoup. Donc, so we now have time for Q&A. I think we have about 20 minutes for Q&A, so please do raise your hands if you have any questions for the presenters, and we'll come around with microphones and we'll take a few questions and then ask our presenters to respond. Okay, I see a few hands. Microphones are coming. Bear with us 1 second. Please go ahead.
Right, thank you, presenters. I have 2 questions. One is for Sierra Leone. You mentioned you plan on excluding the western side from your ITN, one of your prioritizers. Is it total exclusion? Because, you know, even in the urban areas, there are some at-risk population. Even in Ghana, you have slums, how are you protecting them? And then the second question is trying to get a practical use case scenario from the last conclusion of the model, which states that using efficacious ITNs are better at reducing or producing more epidemiological impact. As a country, we know that, and using Ghana as an example, we always have challenges filling in our gaps. Are you suggesting that in a scenario, you would rather prioritize investing in more efficacious nets as opposed to having enough nets to serve more people? Like, for instance, would you procure more IG2 nets to your very high burden areas? That would mean you would not even have nets, standard nets for moderate transmission. Would that be a practical use scenario? Over.
Thank you. And we'll take a few more questions before we...
Ok, merci bien. Ma question s'adresse à la première présentation. Ok. Donc, dans vos résultats, comme le Ghana l'a signalé, vous suggérez effectivement qu'il est plus efficient d'utiliser les moustiquaires à double ingrédient, même si la quantité n'est pas à hauteur du besoin. Mais je voudrais quand même savoir, est-ce que vous prenez en compte le fait que les moustiquaires, que ce soit à double ingrédient ou non, il y a quand même certaines populations qui ont des habitudes de rester très longtemps dehors et qui s'exposent à des piqûres de moustiquaires indépendamment du type que vous utilisez, et ce qui peut avoir aussi un impact dans la lutte contre le paludisme. Merci bien.
Thank you. Just a note that the microphones on the tables do work as well, so we don't need to pass around. So if you do have a question, please just put your hand up and then use the microphone closest to you to ask a question. Next question.
Thank you. Yeah, back to the modelling work at the beginning. So I got that 630,000 nets were out routinely. I wondered, just to give us an idea of scale, how many were going out through the campaigns, and what did the kind of map look like? Was it very highly targeted to the high transmission areas, or was it also to sort of lower transmission areas? Thank you.
Thank you. I think we might pause there so that we can remember all the questions. So I'll turn to my panelists to answer questions. I might ask Musa first to respond to the question about Sierra Leone.
Okay, thank you very much for the question. What I mean by excluding Western area, it doesn't mean that they are not going to receive nets at all. I think maybe that was, I didn't present it well. I mean, we have a different strategy. We are thinking of using a different strategy now, rather than just using the blanket that says every one confirmed case per 1,000 population. You know, urban areas are very complex. So for the past years, past mass campaigns, our coverage for the urban area, especially Western area, has not been satisfactory at all. Maybe we need to do a micro-stratification for us to better understand what strategy that we should use. Maybe, for example, we can say, instead of saying, like, we have certain places, even to register people becomes a problem, because in the morning they go to their offices, and then even some of them that manage to register during the weekend, for them to go and redeem the nets is a problem. And then in other slum areas in the urban setting, Western area like Freetown, maybe we need to think about, instead of saying one net to every 2 persons to a maximum of 3 for more than 5 persons in a household, maybe we have to think about looking at the sleeping places, okay? Or maybe the way of distributing, we say some of those areas that do not go to redeem the nets at all, can we do house-to-house distribution in some of those areas? So this is what I mean, not that they are not going to receive nets at all. Yeah, so but we are going to do a different strategy for them to receive their nets. Yeah, over.
Thank you. Andrew, do you want to respond to some of the modeling questions?
Yep, is that working? Yeah. So on the sort of first question, which I think was sort of in relation to whether IG2s should be to prioritise higher transmission settings, potentially over moderate ones. So I want to sort of emphasise in that last slide that I presented, when we were looking at the context of reduced budgets, we have, in that context, only looked at scaling down the proportion of campaign nets by the same scale factor across all regions. We have not yet looked at the impact of deprioritisation in the context of reduced budgets. In reality, a mixture of the two may need to be done, where areas with moderate transmission may want, you could have a more complicated approach where you maintain higher levels of procurement for high transmission settings. You have a sort of, in moderate transmission areas, you may lower the number of nets distributed through mass campaigns, and you may just sort of exclude lower transmission settings entirely from campaigns. In the relation to the second question, I think some of that point hopefully answered the first bit of the second question, but on the second bit of the second question about in relation to have we considered indoor and outdoor biting, yes, that is incorporated into the model. There will be a lot of uncertainty around how that differs between different locations, and those sort of fine-scale differences we will not always be accounting for, but yes, we do sort of largely try and account for the effect of outdoor biting. Finally, in the context of sort of the numbers of campaign nets that were distributed, so for the sort of baseline scenario, that was for procuring having a procurement ratio of 1.7 people per net. So that would have been around 15-ish million. For the baseline scenario of pyrethroid only, but when we were going down to chlorphenapir, that was about a third, roughly, of that. So we're looking about roughly, moving from a procurement ratio of 1.7 to 4.5 was the how we were sort of trying to stay within the same budget. Well, sorry, not the same budget, a reduced budget of 50% while moving to chlorphenapir. Again, that was with maintaining the same level of routinely distributed nets.
Sorry.
Sorry, I don't know if that was clear. So I got that 15 went to 5 million for the dual, and the second part of my question was about the distribution of that geographically.
Yeah, so in that modelling, that was basically scaled by that same scale factor everywhere. So that was reducing the procurement rates by 2/3 everywhere across the entire country. We are hoping to sort of move forward by looking at deprioritization strategies like what we had done previously in the context of fixed budgets, but we have not yet sort of done that in the context of reduced budgets.
Thank you.
Any more questions in the room? I see some hands. So if the microphone at your table is working, feel free to use that, as I think you'll be brought a microphone. Julian.
Ma question c'est pour Dr Nyanga. Merci beaucoup pour la présentation très intéressante. J'étais assez surpris de voir que l'Olicet, qui, si j'ai bien compris, c'était une moustiquaire standard, c'est-à-dire pyrethroïde uniquement. Et vous allez corriger si j'ai mal compris la présentation. Hein. Mais si j'ai bien compris, les résultats montraient que la moustiquaire était aussi efficace, plus ou moins, que l'intercepteur G2. Et du coup, je voulais voir comment vous étiez en train d'interpréter ces résultats dans un contexte de budget limité. Est-ce que vous considérez que ces résultats montrent que l'Olicet qui serait moins cher serait aussi efficace et du coup vous permettrait soit de distribuer plus de moustiquaires ou de faire des économies ailleurs dans le budget? Merci encore.
Dr Nyanga, vous voulez répondre direct à cette question?
Ok, c'est bon. Je peux répondre à la question?
Oui, s'il vous plaît.
Sorry, the interpreter.
D'accord. Effectivement, cette étude nous est mise dans un contexte où nous voulons voir quelle est la moustiquaire, quelle est la plus adaptée dans notre contexte. Et il faut savoir que dans ces localités-là, le niveau de résistance varie énormément. La résistance varie énormément d'une localité à une autre. Donc, pour nous, cette étude a été aussi un point pour montrer quelle était la moustiquaire qui était adaptée dans le contexte de la résistance dans une localité. Effectivement, il y a certaines localités où vous avez bien vu que le Lysenet était peut-être plus efficace que l'interceptor parce qu'elle a une efficacité, elle a une action très lente dans le temps. Donc, tous ces résultats vont permettre de pouvoir prendre les décisions pour les prochaines campagnes. Est-ce que j'ai répondu à la question?
Je crois oui, merci beaucoup. Other questions? And I think there's a problem with the interpretation at the moment, so if that isn't working, apologies. I think they're trying to fix it as quickly as possible. Please go ahead.
Yeah, thank you. My first question is for my colleague from the Imperial College. So with the scenario of maintaining equivalent coverage with deprioritization, I think you have shown that the effect could be encouraging. So what were the key considerations in terms of deprioritization? So, what exactly were you looking at? What aspects of prioritization, deprioritization have you been looking at? And my second question is for my colleagues from Sierra Leone. So, yeah, I really liked all the considerations that you have really put in place for different types of interventions and also distribution channels for ITNs. So for school-based distribution, you mentioned, so one of the criteria would be, you would be using ITN access of less than 45% as a criteria for prioritization for school-based. So my question is simple because you focused on data-driven decision making. So how have you been able to generate the estimates of ITN access for these subnational levels? So where does this data, how do you generate this data, this information for subnational levels on access to ITNs? Does it come from some small area surveys or, yeah, just I'm curious to know actually how you are getting this information. Thank you very much.
Okay, we'll take another question and we'll respond to those two together if that's all right. Yeah, over there, Kate.
Thank you. My question is also for the Sierra Leone team. In your scenario analysis, you obviously included, you did a very detailed look at different possible options and really nicely presented. Thanks for that. I wondered if going forward, based on some of the conversations we've been having today, would you guys be ever considering the idea of another scenario where you keep campaigns in as many areas as possible, but reduce the number of nets? So do campaigns that aren't targeting one net per two people, but instead saying, okay, I'm still going to do the campaign, but I'm going to understand that I can only do it with fewer nets, so it will just be nets for under 5 children, or nets 1 per every 3 or 4 people. Is that something that, as a program, you've discussed as an option, and do you think it's something you will discuss as a possibility? Thanks.
Thanks. Musa, would you like to respond to those?
Thank you very much. The question on access to ITNs, I mentioned that we did malaria indicator survey in 2021. And then we did prevalence among children 6 to 59 months, and then 5 to 9 years. And it came out, the result came out that the prevalence among children 5 to 9 years was higher than children 6 to 59 months. And if you look at the school-going children, because we are targeting only the primary school-going children, not the secondary. So we have started seeing increase in the incidence among, or the prevalence among children, primary school-going children. Okay, but we are unable to detect the access among that age group. So what we did was targeting districts that had lower access to ITNs for the school-based distribution. Okay, we did not actually get information, data on school-going children as to their access to ITN. Okay, but we took the entire district, the district that had lower access to ITNs, and then with the prevalence of this school-going, this age bracket, we think that they must be one of the most vulnerable groups. Okay, because of their behavior. Most of them are adolescents, you know, the way adolescents behave. Most times, they don't even want to sleep inside nets, but one of the ideas about school-based distribution is not only giving the nets, but for us to use them as change agents as well, making sure that the teacher discuss about the importance of using nets, sleeping inside mosquito-treated nets regularly. And they, in turn, can also tell their families, you know, when teachers talk, school children take it very, very important that this is what the teacher says, that we should regularly sleep inside nets, and then we have been provided with nets. Okay, so that was how we considered that age bracket. In terms of the option, we thank you very much for bringing that option. I think as we continue the intervention targeting, we'll consider that one as well as an option. Okay, I noted it down. We did not think about that, but we are going to look at it and see. Over.
Just on the first question about how we approached deprioritization. So the way we do that is we kind of, for every region, we'll simulate what could potentially happen if we conducted mass campaigns in those settings and alongside routine, and what would happen if we only had routine. Obviously, these are projections and estimates. Then following on from that, we basically prioritize regions for mass campaigns on the basis of our estimates of cases averted per US dollar, and whilst ensuring that all areas have full routine coverage. Obviously, that may not always be possible in real-world settings, but what we do find is that there is a very strong correlation between sort of cases averted per US dollar with more expensive nets in higher transmission settings than in lower ones, and that ultimately transmission intensity does seem to be a much better predictor of the benefit of sort of more expensive chlorphenapir nets than, say, use given access or retention time of nets.
All right, thank you so much. I think we are going to have to wrap there, but please follow up with the speakers if you have further questions or want to continue the discussion. Please do join me in thanking all of our speakers this morning for an excellent set of presentations. We are going to return to start sharp at 2 o'clock, so please do take a quick lunch. Thank you for your participation, and we'll be back to start sharp at 2 o'clock. Thank you, everyone. And I hope the interpretation will be back in the afternoon. I'm sure we're working on it. Thanks so much.
30 minutes off track, so we will do our best to get us back on track. And I'm going to introduce the moderator for the afternoon session. So it's a great pleasure to introduce Dorothy Onyango, who is a very experienced AMP technical assistance provider, and she is going to lead us through the afternoon session of day one. So over to you, Dorothy.
Thank you, Jason. Good afternoon, all. Welcome to the after-lunch sessions. God help us all. Thank goodness they are quite interesting. I have seen at least 2 of them. With a pre-recorded presentation, we have Ifoma Ozodegu, who is an assistant professor at the Health Informatics and Data Sciences Department of Loyola University, Chicago. She's been working on urban malaria for a while, and she'll discuss and, maybe finally answer whether urban microstratification is worth it by demonstrating her work in Abidjan, Cote d'Ivoire. Then remotely and live from Nigeria, we have my friend and colleague, Fatima Ali, from the Nigerian NMEP. She will be with her colleague, Chukwu Okoronkwo, and they will share the Nigerian experience with prioritization. Actually, I had the honor of evaluating one of the first Nigerian campaigns that intentionally implemented a prioritization strategy, and that was in Kwara State about 2 years ago. So I'm looking forward to this presentation. We also have Eleanor Sternberg, a research manager at Tropical Health. She's based in the UK. She will share a decision-making flowchart for ITN prioritization in urban areas. So, Ifoma, this is a pre-recorded presentation. We can move on because time is passing. So let's go for Ifoma Ozodegu from Chicago.
Chicago, also in the Department of Health Informatics and Data Science. And my talk will be discussing the feasibility analysis that my team and I conducted to provide insight into or inform decisions into whether the PNLP in Cote d'Ivoire should invest in urban microstratification for Abidjan. In May of 2024, the WHO released guidance on how countries should approach prioritizing malaria interventions when resources are limited. But prior to the release of this guidance document, the PNLP in Cote d'Ivoire, in partnership with the Global Fund, were already having conversations about whether they should target nets or target the net campaign in Abidjan due to limited funding, which I would also discuss subsequently. But I want to first of all draw your attention to some of the key points from the guidance document, which is that when resources are limited, countries should focus on minimizing debts, maintain SMC, and of course, it was highlighted that areas that could be excluded should be urban, and specifically places with very low current and historical transmission. But when my team came into this discussion, this document was not present, and we realized that there were 2 camps with different perspectives on what the PNLP should do. And I'll take you through those different perspectives and the evidence we gathered that kind of supported each of these perspectives. So first of all, there was a camp that wanted nets to be distributed in Abidjan. And I'll talk you through some of the evidence that my team gathered that sort of supports that view. So first of all, a background on Abidjan. Abidjan is located in Côte d'Ivoire, and I have highlighted it in light blue so that you can see the exact location, somewhere in the southwest of the country. And there is also a couple data points that I wanted to highlight, which is the population. So this is the enumerated population from the microplan. And you can clearly see that most people kind of live here in Yopong West, which is one of the 10 health districts that is recognized in the campaign. And there were also a lot of people in Ajame here, and a lot more people also, but not as much as Yopong East. Yopong West in Yopong East. And to get a sense of the density of Abidjan, you can clearly see from this plot, and this is density from NASA SEDAC. This is from 2020. We couldn't find one for 2021. And what we saw was that the population living here, the density was quite high in the central part of the country. So you understand why I'm showing you this data point as we progress. But first of all, what my team does as part of the Urban Malaria Lab is to really try to figure out with whatever data the country has, what are the levels of urbanization, what are the levels of malaria risk. And for this particular camp, we wanted to start also for this particular perspective, we wanted to understand, first of all, what are the levels of urbanization. And this, I'm showing you, this plot here is the built settlement extent from 2020 that we obtained from World Pop. And again, just going back to what I alluded in the map of the enumerated population, the built settlement extent kind of points us to what is happening in terms of built-up areas, urbanization. And you can see again that most of the built-up areas is actually in the central part of the city or by Abidjan in this case. And you can see also the same image depicted here when we computed the urban area percentage using the International Geosphere Biosphere Program definition of at least 30% impervious surfaces, and areas that were showing up, or grids that were showing up as almost 100% urban or built up, were also in the central part of the country. But one thing we also realized as we were doing our investigation was that urbanization, even within areas that were highly urbanized, tend to be quite heterogeneous. And one thing we found was that there was a number of slums in Abidjan, and this red points depict the locations we identified some of the slums to be based off of our literature review and searches of real estate websites and also Google Map. And you can see here that a lot of these highly dense, population dense or areas also tended to have slums. So for instance, this is Ajame right here, where you can see quite a number of slums. Yopong East, some of the slums seem to extend to that location. And here I decided to just blow up the different building morphology in Trenchville, Makori, which, as you can see, has the highest average price per meter squared, which is pointing to the fact that it may have some of the wealthiest population or individuals from higher socioeconomic status living there. And you can see that even within, even within this area where we found the highest average price per square meters, we also found some slums. And when we blew it up, we could see that there were differences in the building morphology, even within some of the wealthiest areas. So from our perspective, we believe that the camp that wanted to distribute, for nets to be distributed in Abidjan, we're arguing for this position likely because of these differences in living conditions, which is likely driving heterogeneities in malaria risk. And although we could see from the Demographic and Health Survey, so this is from 2021, that the overall burden was low at 1%, there was small heterogeneities that we could detect in areas that seem to be outside or the main highly dense areas. And so, for instance, in Yopong East, we found one cluster that had nearly 20% of the individuals there, 20% of those individuals living there as tested positive for malaria, or in this case, this was actually children under the age of 5. And similarly, we saw on the outskirts of Cocody, individuals, at least about 20% of the kids there tested positive. So, but one problem with the DHS is the representativeness. You can also see the variations in the sample size. And I previously showed you the population distribution. For instance, in Yopong West, the total population enumerated in 2021 was nearly 1 million people. And you can see from the sample or the sampling done that the sample size never exceeded even 30 or 40 for Yopong East. So the representativeness of this particular data set is in question. So we went into the incidence data that was provided to us and decided to aggregate it over several years, so between 2017 and 2022. And we also saw at a health district level, so there are about 10 health districts, again, recognized in the campaign. There were variations in the seasonality of infection and also in the test positivity rates within these areas. But based on also the information that we gathered on urbanization, because we had started to gain intuition about the data, it became clear to us why, for instance, Trenchville, where the wealthiest people would kind of reside, would have some of the lowest test positivity rates, and Anyama and Yopong West would have some of the highest test positivity rates. So it sort of made sense that the incidence data was likely picking up the heterogeneities in burden or transmission within these locations. So another point that I think sort of supported the distribute net camps is the fact that when you look at the DHS and sort of analyze it overall just for urban areas, this is for the 2021 DHS, which is the most recent, you would see that nets are actually quite effective in urban Côte d'Ivoire. And even though the net use tended to be low, so these yellow points and I think one orange point, which is about 70 to 80 in my legend, and you see yellow points that's point to 30 to 50%. But there's quite a number of blue points in the range of between 0 to 30%. So overall, net use, when we aggregated this, tended to be quite low. We found though that net use among those that have access was actually quite high. So meaning that those that are using the nets or have the net are actually using the net. So maybe what we're seeing here might also, in terms of the low overall use rates, was just maybe people just didn't have access to the nets. So let's talk about the evidence to support the do not distribute net camps. So when I was speaking of for the distribute net camps, I was just using evidence and data to showcase why you should distribute nets in Abidjan without considering other areas and needs in other areas. So when you look at this map, you start to see that in Abidjan, the burden of malaria is really low. So this is based on the DHS at 1%. And in the prior DHS, it was actually about 4%, although the country boundaries and demarcations and administrative units was quite different at the time. But it also had the demarcations contained Abidjan, and so it was about 4% overall. But when you look at the entire country, you see a number of areas with orange, which is means from my legend of between 30 to 50%. So from the demographic and health survey for 2021, the overall prevalence levels for malaria amongst children under the age of 5 was actually about 21%. And this was an increase from the prior DHS that showed that the overall prevalence was 18%. So overall, it seemed that the malaria burden was increasing in Abidjan, but decreasing increasing in Côte d'Ivoire, but increasing in Abidjan, which I think speaks to the point that maybe we should focus resources where the burden is quite high. A second point I think that was the evidence seems to support, that provides evidence for the do not distribute camp, net camp, is that the fact that net use is actually quite higher in other parts of the country relative to Abidjan. And when we also looked at net distribution specifically for Abidjan, we could see that there was also lots of inefficiencies. So this is the leftover nets after the 2021 campaign as a percentage of estimated need. And places like Cocody Bingerville had up to nearly 9% of their nets left over after the campaign, meaning that estimates of net needs were actually inaccurate. So in this case, you would have a ton of leftover nets, and maybe people don't even really need the net. So this is also something that was a data point that we considered would support the do not distribute net camp. So a final point which was made to us, but we just didn't have the data to look at this, was the fact that there was a need to expand SMC to cover all 28 eligible districts. And as you could see from the guidance, that SMC is priority, and the non-distributed net camps were for covering all 28 eligible districts, because in the prior campaign, only 3 districts were covered. So let's talk about what really should have happened if we had the information and the data. So according to the WHO, this is from the guidance that WHO has provided on how to approach the malaria response in urban areas. It's extremely important to have various data types in order to make a decision on what the appropriate action should be, or when you are trying to distribute interventions in urban areas. So the kinds of data that you need is a range of data from epidemiology data, entomologic data, intervention-related data, mobility data, climatic data, and socioeconomic data. So ultimately, if we had these data types, we could have developed a mathematical model, calibrated this model to capture historical and present-day transmission, at a feasibly implementable scale for all of Côte d'Ivoire. We'll then identify the optimal intervention strategies, focusing on prioritization approaches, and then we'll choose an approach that maximizes impact and is implementable after a feasibility assessment. But unfortunately, we just didn't have the data to do this. All the time, because when my team was approached, we had a very limited window to conduct this analysis, just under 3 months. And so the question is, what sort of analysis could we do to support decision making given the very short time scale? And so for us, that meant focusing on a feasibility analysis. Because at the end of the day, when you even think clearly about it or think deeply about it, even if you develop a mathematical model, you still need to make sure that this plan of action that you're recommending is also feasible. So how did we approach this? The TELOS framework is a framework that helped to guide our team as we were thinking through the process of our analytical approach, and also what questions do we need answers to in order to determine the feasibility of distributing nets in Abidjan. So the TELOS framework includes several compartments. So first of all is assessing technology and system feasibility. And the question that we had for the PNLP, and for which we also wanted to investigate in our data, is that can we reliably evaluate and map malaria risk at a scale that captures the most vulnerable? I've already stated that we just didn't really have the data to do that, but I will tell you how we try to overcome this limitation using an approach that my team developed. Then economic feasibility. Are there funds to cover all those identified as high risk? So this is also a question that for other countries that want to implement microstratification, they also need to ask. Legal feasibility. Are there legal or social issues that can emerge from prioritization? So in our experience, we have done this work in Abidjan, we've worked in Nigeria. We have started to come to an understanding too of some of the considerations that countries also need to, and programs need to put in place. And I think legal feasibility is important to highlight. And then operational feasibility. The question we had was, can the PNLP reliably deliver the nets if results are presented at a scale that is lower than the health district level? As you could see, the urbanized areas or the urban extent actually did not fall one-to-one with the health district extent. So there were parts of the health districts that were urbanized and parts of the health districts that were not really, could not be regarded as urban areas. And so if we were to create new demarcations, could the PNLP actually deliver nets, and do they have the infrastructure to do that at a scale that is lower than the health district level? And then the final one was schedule feasibility. I already said that we had very limited time to do this work. And so the question is, could we, if we were to embark on the analysis that's required to provide insights to inform these decisions, could we do that in time for it to be used in the microplanning and in the mass campaign? So let's talk about the first one, the technology and systems feasibility. So what we did is, we used the method that we have developed and we had found to be quite useful in assessing malaria risk in urban areas when you don't have data. So first of all, just to remind you of what the urban extents look like. So areas that fell within 50 to 100 is what we really regarded as the urban extent. And so we looked at looking at the various data pieces that were available to us to figure out which one of them kind of met our expectation of what we should see if there was this heterogeneity in urbanization. So first of all, the first one I want you to take a look at is the test positivity rate among suspected cases. And you can see dark red in areas that were not really, did not fall within the urban extent, which is what we would expect. So we said to ourselves, okay, this is picking up some signals. EVI. In the previous plot that I showed you that nets were found to be very useful, we also ran an analysis to look at what is the relationship of enhanced vegetation index and malaria test positivity rate among kids in urban Côte d'Ivoire. And we found that this was actually found to be highly correlated with test positivity rate. So we retained this variable and we said, okay, let's identify areas that tended to have more vegetation. And you can see here, this was in Ajambe and some other areas. And this is because there's actually a park located in this axis as well. And there was also a forest located here, which I think spoke to, the data really spoke to what was actually happening on ground. And then another piece of information that we felt matched our expectation was the price per square foot. So you would expect the price per square foot in terms of housing to actually, which I had previously also shown to you, to actually be much less or lower in areas that are outside of the urban extent. And that's exactly what we saw. And then finally was the daily precipitation. So we kind of aggregated this over time because we found that Abidjan tended to, some areas in Abidjan tended to have more rain, and that flooding had happened in specific areas over time. And so we wanted to capture the potential effects of that as well in creation of a risk score. So we took these variables and we sort of combined all of them together after, using their normalized values to create this composite score, which as a measure of malaria risk. And we then said to ourselves, if microstratification is going to happen in an urban area, it should only happen in areas that fall within the urban extent. So what we did was to then rank those places that fell within the urban extent in order to guide decisions on if you are going to distribute nets, where should you start and where should you stop? So areas that are lighter colored, so for instance, you can see one, are places that could potentially be excluded from the net distribution. And then the excluded non-urban districts were places that if we believe that if you are going to distribute nets in Abidjan, you really have to cover them 100% because they were outside of the urban extent. And we weren't sure whether they were peri-urban or whether they were sort of completely rural. It wasn't totally clear to us. So And the other point is, were they, in terms of the feasibility, are there funds to cover those at high risk? So I did mention that there were limited funds, but I didn't tell you what the funding envelope was. So let's do some arithmetic. So first of all, we did extensive literature reviews to identify both the procurement and distribution costs for individual nets. And we particularly looking at Cote d'Ivoire, and we found this for procurement costs to be an average of about $3.47 per net, and distribution costs to be about $2.67 per net. The funding envelope was about $3.7 million, and using these values, we could estimate roughly the number of nets that could be procured and distributed. And so we went back to this risk scored map that we created and said to ourselves, okay, if we were to distribute nets to cover everybody in the non-urban districts, could we cover all of them? And as you can see, if the population remains constant, we assume a constant population as at using the 2021 net distribution campaign data, and the total number of nets that was distributed in 2021 just for Yopong West was about 500,000 nets. So if everybody in Yopong West is covered, that means of this 600,000 nets, you have to distribute 500,000 of those nets. So that means all your nets are almost practically gone. So and then you need to move on to the next district, which is Anyama. So Anyama is right here, and this is about 226,000 people. So you can see that just covering the two areas that were outside of the urban extent, literally you would only be able to cover just Yopong East completely, and maybe just about a half of individuals in Anyama. You wouldn't even get to the program wouldn't be able to get to even Yopong East, given the number of nets that could be procured and distributed. And so this is formed, the analysis that we conducted and the plots that we shared with them, showing the program what it would cost to do a universal distribution if, they were to, for instance, decide to deprioritize just one district, if they were to use a strategy where they gave 50% of nets to only high-risk districts and then kind of gave the remaining nets to other districts, what that would look like. So they could clearly see that the funding envelope was just really small and couldn't even meet most of the distribution and net distribution or campaign needs for Abidjan. And then I think I wanted to talk about the legal, operational, and schedule feasibility. But before I say that, I discuss this, I also want to point out that when we showed the program and the Global Fund these costing estimates, it really paused the conversation, because at that point it became clear that they couldn't, within the funding level, they really couldn't afford to do net distribution in a way that even covers majority of those who could potentially be at risk. So, but I want to also speak to this legal, operational, and schedule feasibility, because I think it's imperative and important to consider, particularly for programs that are thinking about microstratification. So here are some points. My take is that if you're going to do microstratification, you want to consider any legal or social issues that might arise, because net distribution is extremely popular. And when you exclude wards and especially in an area where people are aware of what's happening in one ward, because sometimes this, people move from one ward to the other. So they would, if you're in a ward that was excluded, you would know that a ward that is included is receiving net. And this could potentially be viewed negatively and could lead to unrest and also legal issues. So you also want to think about whether the program has the legal instruments in place in order to prevent these potential events. Another thing I also want to highlight is the issue of heterogeneities. I just showed you the heterogeneities in urbanicity, in Abidjan, and this exists even within units. And if a program decides to do microstratification, it's likely that you'd want to consider using new maps for the campaign to especially in places where you see that a fraction of the district might be non-urban, and then there's a small urbanized area that you, depending on how many nets you have, you may want to exclude. But you also want to consider if you are equipped to follow a new strategy, because most strategies are typically at a much higher administrative, follow a pattern of distribution at a much higher administrative level. For instance, in Abidjan, it used to be universal coverage, so you just go everywhere in Abidjan. But do programs have the capacity to deliver nets when they need to select or exclude specific wards? So that's also a consideration to keep in mind. Then finally, schedule feasibility. Launching an urban microstratification plan also requires you to conduct new analysis, take up new processes, and might also involve fieldwork. So in the previous post that I showed, the final analysis that we presented to the program, we also incorporated the cost of doing some field work to validate some of this analysis. But you also want to consider if you can actually complete all of these in time, and also train people to do all of this analysis and take up these new procedures in time for your campaign. So these are like all the angles you need to check to determine if it's feasible to do microstratification. So now let's get back to what happened in Abidjan. So what happened after we shared this analysis that, showcasing the costs of the cost estimates, the risk analysis estimates. So here are some takeaways, is that the results of our analysis really was informative, because it helps with the PNLP and the Global Fund to kind of decide not to actually distribute nets, because in their minds, it was clear that they just didn't have the money, the resources, the time, and even maybe the flexibility to be able to organize a campaign that would be restricting or excluding areas. So it was decided that they should just redirect their resources to districts outside of Abidjan for seasonal malaria chemo prevention. So basically, the camp that was focused on not distributing nets actually won this argument or this discussion, but that's all actually on a lighter note. But really, the idea here, at least for them, the idea here is that feasibility analysis can help you make better decisions on whether you should conduct microstratification or not. And hopefully, using this framework that I've shared can also be insightful as programs think about feasibility from various looking at various dimensions. And then finally, I also want to highlight, because oftentimes in this conversation of deciding where to target interventions, we often think about impact, but outside of impact, no one is thinking about implementation. So let's think also about the feasibility of implementing a new strategy, even as we think about impact, because you can conduct an impact analysis, but if you cannot implement that strategy that you've chosen, then that becomes useless. So consider doing some feasibility analysis, particularly in the space of microstratification, since it involves new approaches and procedures, and so such that you would have, as a program person, have a better idea of whether this would be something that the program can do at a particular point in time, or whether it's something that they can plan towards doing in the future. So that's really all I have. Thank you so much for the time and for the invitation to speak. I want to acknowledge my team, who we all worked together on this, and really the conversations we had as a team kind of guided our approach with supporting the PNLP. And here is my contact if you want to reach out and you have questions. And also, this is our website. But thank you for your time, and enjoy the rest of your day. Bye.
The pain of conducting a rigorous microstratification process and then getting hit by the reality check of the funding envelope. I think we are all going to go through this. Let's find out how the Nigeria team managed this process. Over to you, Fatima and Chuku.
All right. Fami, can you hear? Hello, can you confirm you can hear me?
Yes, we can hear you.
Okay. Right then. So I'll wait. The slides to come up. Okay, thank you very much, and good afternoon, everyone. Over there, we will have as much we will have wanted to be there, but unfortunately, we couldn't make it. So my name is Chukwu. We'll be speaking with Ati, who is with IBM, and I'm supporting the SME of the National Malaria Elimination Program. Next slide, please. Okay, that's our outline. We'll go on to the next slide. Essentially, the National Malaria Elimination Program has been thinking about the strategies that will impact the malaria body in line with the subnational. We've been discussing about the issue of malaria with its heterogeneity and complexity. And we've been thinking about what would need to be done and how they may have affect disease prevalence. So the question was, could ITN distribution in urban areas be adjusted to specifically target those who truly need it, especially given limited funding for sources and the desirability of employing other measures? So this became a starting point for the implementation of an urban malaria strategy, hopefully to maximize resources and achieve impact. Next slide. So we started a pilot project in Kwara State that will guide the reprioritizing of IT in urban areas. So glad that Professor Former, so they helped us with some Bill and Melinda Gates Foundation, employing a classification algorithm to identify areas with low risk of malaria transmission, which she had just presented. So we wanted to simplify the process and deploy the learning from the Kwara pilot to other states that are conducting mass campaigns. So we've employed that principle in about 3 states. But the focus of this presentation will be for the 7 states where ITN campaigns will be conducted in 2025. And just to say that Tropical Health also supported by Global Fund, helped also to develop a decision, especially for national level macro plan. Next slide. So with support from the Urban Malaria Lab, these steps were taken. Collation of publicly available data and variables extracted for these words. A composite score generated to enable ranking words from low to high malaria risk. And specifically for the Kano metropolis, malaria risk was modeled using a machine learning approach in line with some of these above scenarios. And then they provided us with scenarios, 10%, 30%, 50%, and 70% of the world area being classified as urban. And for NMEP, the 50 and 75% scenarios were prioritized. Next slide, please. And these are the variables that were ranked: the Enhanced Vegetation Index, under 5 TPR, settlement type, distance to water bodies, flooding. Next slide, please. Additionally, we also looked at, again, on the 5 TPR as in assumed or known urban areas. Next slide. I'll come back to some of these issues. And what were the outputs? So we're going to be showing a series of slides, and I'll be not commenting on them, but this is the machine learning that was utilized for the Kano metropolis, showing the predicted malaria prevalence. Next slide. And you see in green the areas that were recommended for reprioritization.
Highly dense.
For each of the scenarios, whether it's 50% or 75%, and for each state, you will see, based on the variables that went into the model, the areas that have been identified or recommended for reprioritization. Next slide. This is for Kano. And then this is for, I think this is for Kano. Yes, this is for 50% Kano. Please go ahead. And this is for Delta. So you are having scenario 3 and scenario 4, 50% of the world is urban and 75% of the world is urban. We are taking the two of them, as we said, these were the ones that were prioritized among all the scenarios. Go ahead, please. And then this is for Kaduna. Please go on. So you see both scenario 3 and 4, and this is for Katsina, both again scenarios of 50% and 75%. And this is for Katsina, 75%. Please go on. And this is for Taraba, both scenarios, 50%, and of course, the reprioritized areas in green. Next. And this is for Yobe. Please, next. And this is for Niger. Next, please. Next. So, this is a summary of the recommendation of the recommended words with the estimated populations. Of course, I'm not going to read them, but this is based on this that was done. This was the total population of the recommended areas. Please, next. There is a national task team on reprioritization, and we also provided some guidance so that they can also do some form of ground truthing by the states themselves. So this is the guidance that was provided from the national team to the state teams. They will need to use a validation tool, which we have been developed and which was given to them to do some form of objective assessment. Are we right in actually doing some of these, in recommending some of those? And there is to have a stakeholders consensus in saying, indeed, these are low risk areas, and there will be need for other vector control measures. And at the final analysis, they will share that with the national team for them to align, and after looking through the process. Next, please. So these are the summary of the key steps. First and foremost, there are two branches who would work through the task scheme on reprioritization to identify areas for possible reprioritization per state. This is shared by the IVM branch with the states, with implementing partners and copy for validation using a standardized checklist from the M&E. So the validation will include adding or identifying and adding more words that are urbanized and with relatively low TPR. So we'll hold engagement meetings with individual states to review the list and provide orientation with the states on how to conduct the validation. Then implementing partners will support the state to conduct the validation and ensure some rigor is introduced into the process by using existing structures. The validation outcome is shared with the tax team for review and alignment. If there are any issues, they will be resolved in consultation with the state and the supporting IP. And then the state signs off on the validated list. Next. After the microplanning, the population generated from the microplanning activity is reviewed and triangulated with available nets. If there is inadequacy or there is excess, a stakeholders meeting is convened to agree on what should be done. Then there are scenarios to be considered if available nets are insufficient for the target population. And this is in line with the decision-making flowchart that was developed with support from Tropical Health. So those are the various scenarios: exploring other sources of net, seeking additional areas to be excluded, and then where additional areas have been identified for the prioritization and there's still a shortage, then capping may be done after household mobilization. And the last alternative is to do a state level capping. Next slide. So I will ask Fatih, my colleague, to please take it from here. Over to you, Fatih.
Good afternoon, everyone over there. Thank you, Mr. Chiku. A few challenges were encountered. One of the main one was rejection of other health interventions, especially for the areas that were not targeted for distribution. Also anticipated reaction from the non-targeted wards. Could be theft or violence. This was experienced last year in some of the states where wards that were not targeted for distribution disrupted activities at the nearby distribution points, some even leading to violence or theft of some of the nets. Of course, population figure is always important in any campaign, especially for Nigeria, where our census data is a bit outdated and then we're dependent on different health interventions. So sometimes the population figures don't align, and that might affect the quantification or the identification of areas to be prioritized. Next slide, please. So lessons learned, the implementing partner support was very vital, especially in supporting the state with the validation process, providing technical support and clear understanding of the reasoning behind the strategy. This really helped, especially this year, in ensuring a hitch-free acceptance by the state and implementation. Bias is unavoidable, especially at the LGA level where the RBNs left on their own. No one really wants to be instrumental in depriving any areas of ITN. So getting that state support and the implementing partner also supporting help to reduce this bias as much as possible. Political interference is something that is always there. You can't really eliminate it 100%. The state team always waits for the approval of the policy makers, who are the politicians, to get their buy-in and support to ensure a hitch-free process. Planning process needs to be started as early as possible. So based on lessons learned from last year, this year we started early as possible integrating the ITN prioritization process into the campaign planning process. And this has shown better success and acceptance in the micro plans that were done early this year for the states that are due. Again, back to the political interference and states buy-in. Early engagement of the stakeholders at all levels, especially at the high level, to deal with any political interference or state acceptance and support, and of course at the low level, where at the community, getting the relevant stakeholders, that's the community leaders, the religious leaders, to get early engagement to understand the rationale for ITN prioritization was very vital. Also, strong engagement at the community levels, clear SBC messaging. Again, this is based on a lot of lessons learned from last year, improving on that and making sure the SBC messaging is clear and is in the context of the areas that are being deprioritized. This was effective in managing community response and then ensuring critical safety and smooth deployment of the campaign process and any rumor mitigation. So for the microplan, this was very helpful, and we hope to implement this fully during the implementation of the campaign at the various states later this year. Next slide. So recommendations, I've mentioned this, start early as possible. If it's possible to do it a year before the campaign implementation, if possible, let it inform the ITNs to be procured for each state. Early state engagement, I've mentioned this. Several meetings were found is necessary, even with the same group of persons, to meet as often as possible, just to reinforce the message and ensure that we're all on the same page and the strategy is well understood by all the relevant stakeholders. Development of SBC messaging, especially for those wards where nets will not be distributed, and making sure the message is in their language, it's clear, and it's in the context of that area. Strong monitoring and surveillance is needed in the reprioritized area. Having the state to have a verified working population harmonized for use for all healthcare intervention. And then finally, to engage the state to plan for and implement other appropriate vector control interventions in the non-ITN targeted wards. It's advisable this should be conducted just before, even during implementation. That way, while distribution or campaign processes are taking place in other wards, those wards are also benefiting from some kind of vector control interventions. I think this is my last slide. All right, thank you very much.
Thank you, Team Nigeria. We have learned some of the challenges, lessons learned: start early, engage early, strong communication, M&D, and provide other interventions. We are grateful for that. Please, everybody, keep your questions for after Eleanor provides us with her fantastic presentation. Over to you.
Perfect. Okay, great. So I have a bad habit of walking away from the mic, so if I start to do that, somebody please signal to me that you can't hear me anymore. Great. So I'm going to pick up on certain parts of the presentation that we've just seen from Mr. Chukwu and Fatima in Nigeria. And we're going to zoom out a bit. So I am going to be presenting the sort of decision-making flowchart that we've developed initially out of the pilot in Kwara State, but sort of informed by some of the following experiences in other states with this approach to reprioritizing ITNs. Can I click forward? Okay, great. So you'll already have seen these recommendations in a different form in the previous presentation. So these are the recommendations that we co-created with Mr. Chukwu and his team following the experience in Kwara. And I just want to highlight that the two recommendations that I think are particularly pertinent to the flowchart that I'll be talking about today are the first and the last. So this point around needing to integrate early and as fully as possible into the existing processes for these ITN campaigns, And then also having a very clear framework or approach so that there is transparency and fairness in the process for deciding where the nets go or don't go. So just restating that, the two key things that we're looking at here is, again, prioritizing integration early and fully, and making sure that we're being transparent and fair in how we're allocating our ITNs. So that raises the questions of how can we really systematize, I knew I was going to have trouble with that word when I put it in the presentation, and I did it anyways. How do we formalize the decision-making process for deciding where ITNs go in urban areas? And how does that decision-making process fit within the wider planning that the NMEP and the SMEP may be engaged in preparing for these campaigns? So the aim, what we're going for here is we want a framework that is precise with our exclusion and inclusion criteria, but that needs to be as precise as is feasible and is necessary. So when I say feasible, I mean given the available resources, such as nets are obviously a big one, but also data and time to make the decisions around where those nets are going. And again, just re-emphasizing that it is about increased transparency and consistency in that decision-making process. So a couple of assumptions going into the flow chart. The first is that there always is an ITN gap. So in other words, some fraction of the population will not receive ITNs through specifically mass campaigns because there's not enough nets available. And I think certainly what we've heard today supports that this assumption is probably valid most, if not all of the time. And then the other assumption here is that operational considerations are not yet included in the decision process, but that will probably inform sort of the granularity and around the decision-making process. So if you would like to talk about operational considerations, please come find me at the tea break. I would love to talk about that. Okay, here's the flow chart. It's long. It's going to be 3 slides long. You start up here, and the first question that it's going to try and address is whether there's enough nets to cover at least some of the urban areas. So to do that, you need to know what your ITN gap is, and you need to know what your urban population is. And there's 2 possible outcomes here. You have the outcome on the right, which is that actually, even if you didn't give a single net out in urban areas, you're not going to have enough nets. The option on the left is that you, if you did exclude the entire urban population, you would solve your net gap, basically. So let's take the situation on the right, which is that your gap exceeds the urban population. So, sorry, see my slides better up here. So one option that actually has come out of some of the activity that's been going on in Nigeria is that there was the option to see whether nets could be brought in from other states where there was maybe some additional nets left after another campaign, or just basically seeing if there were other nets from other sources that could be brought in to help fill the gap in that state. If that's not possible, then there needs to be some discussion and identification of alternative mitigation strategies. So in addition to maybe not distributing nets in urban areas, there needs to be some thought put into what you're doing to mitigate the fact that you don't have enough nets. So then on the left, we have the situation where you could exclude your entire urban population and you would have enough nets, but we want to think about whether we can refine that further. And so that's where the thinking around reprioritization or identifying risk comes in. So we've seen Professor Fumoma's presentation around what was called the malaria risk mapping tool when we were talking about this. And this is where ranking areas on their risk of malaria comes in. And so you can use that tool, and there's a lot that goes into that box, but you can then use that tool to identify where your risk is lowest for malaria. So that may be where you want to think about not giving ITNs. Then we're going to go to the next slide. So basically, so you've gone through this whole, so there's this box that contains a lot. You've gone through this whole process and you've identified areas where you're not going to give out ITNs. And then you need to think about, well, have I solved my problem then? So that's what the next slide is. So you've gone through this process. Now, have you solved your problem? If you don't give ITNs where you've identified that there's lower risk, does that close your ITN gap? So again, we sort of have the right and the left. The right is yes, the right is no, and the left is right. So there's the option that you've gone through this process, you've identified your wards, you think you're set, but actually there isn't a big enough population in those areas that you've excluded to close that net gap. So then you need to be thinking about, well, do I need to exclude even more areas? So the way that the malaria risk management tool works is that it actually produces a ranked list of wards or settlements, depending on what your sort of area of interest is. And you could think about maybe just working your way down the list. So the first set that are excluded, the first wards or the first settlements that are excluded isn't closing my gap. So maybe I go a little bit further down that list based on risk of malaria. Or again, you have this attempt to try and fill the gap in other ways. The left option is that actually this first process of identifying wards or settlements where you're not going to give ITNs has solved your problem, and that's great. So you could just exclude those areas that have been selected by the malaria risk management tool, and you'll have enough ITNs for everyone. But then that raises the question of whether you could do even more. So do you then think about whether you want to really, even if you're not giving ITNs to the whole population in those areas, maybe you still want to try and get ITNs to groups that are particularly vulnerable, so pregnant women or children under 5 would be an example of this. So thinking about whether there's interest, appetite, capacity, particularly for doing further stratification in those areas that have been identified as not a priority for ITN mass distribution. Then at the bottom, in the sort of pink tan box, is just a reminder that as we're going through this whole process of thinking through where we're going to put ITNs, where we're not going to put ITNs, we really also want to be strengthening or sustaining complementary ITN distribution channels, and that other malaria interventions should be ongoing for all populations, regardless of ITN reprioritization. So just a reminder that, that it's not just ITN mass campaigns that we're doing. So takeaway points from this whole process is that decision-making around inclusion and exclusion of urban areas is really an iterative process based on the size of the ITN net gap and the resources available to support prioritization in that area. Starting with a quantification of the ITN gap serves to flag situations where reprioritization is not going to be enough to close that gap. And so we really want to emphasize that this needs to be done early in planning so that then you can start to explore alternative options. If reprioritization alone is not likely to close the ITN gap, then there could be an exploration of alternative sources of nets, but we acknowledge that this is quite context dependent. So in Nigeria, that was something they were able to do, but that might not be appropriate for other areas. If no other nets are available for distribution, then there needs to be a discussion of mitigation strategies. So some that came up in the discussions with the NMEP in Nigeria are revising the household capping numbers on the number of ITNs during microplanning or during household registration, focusing on other interventions, strengthening other distribution channels for ITNs, and strengthening SBC, particularly around prompt treatment for fever. But again, this is going to be context dependent, and the mitigation strategies that would be appropriate in Nigeria may not translate to another context. So, that's all I got. Thanks for listening. Let me know if you got questions or just want to talk about that.
Thank you so much, Eleanor. We'll take some time to entertain some questions. As the mic goes round, I will read 3 questions that popped online. This is for both Nigeria and Cote d'Ivoire. Number 1, what arguments resonated the most with policy makers to consider microstratification, and what barriers persisted? So that's question 1. Question 2, what surprised you the most about the outcomes of the process, and how will this inform future campaigns? And the third question that I have from the group online is, what role did community feedback play in refining your prioritization process? The mic.
I think this is working.
Okay.
So I just have a question for the presentation on Côte d'Ivoire. I'm curious why the procurement and distribution costs were so high. Thanks.
Yes, so I have 2 questions. The first one is to the Nigeria team. In the presentation, I think you showed that you are using the data to make the decision now. I'm just thinking about how you are monitoring this process, and especially going into your next campaigns. Are you going to use the same communities that you have deprioritized, or you are no longer prioritizing, or you are going to use another set of data in order to prioritize different communities that you'll be excluded from the distribution? The other one is to Ifeoma. I think she had mentioned 3 districts were deprioritized in the analysis, or they were excluded from the distribution. And in that analysis, there were about 600,000 nets that were supposed to be given to the 3 districts which had almost 1 million nets. But I didn't really get exactly what final decision they took in order to give out this 600,000 net to the 3 districts. So if she can clarify that.
Thank you, Robert. In front table.
Hi, it's a question for Côte d'Ivoire. Just building on what the previous comment was, I think I understood that Abidjan didn't receive nets, but I just wanted to ask, when they were looking at the microstratification for Abidjan, the prevalence was very low, but the surrounding region had a much higher prevalence. So was that something that was considered in their thinking in any way? Like, could there be a transmission from the Abidjan area into that surrounding region which had the much higher prevalence?
Okay, anybody on my right? Nobody on my right? Okay, on my left I see 2 hands.
I have 2 comments. One is for all of us. Considering that when we do
this prioritization, there will be an element of discrimination, especially communities that share the same ties, the same values. They would think they have been discriminated. Can we put a mechanism of looking at how we can do both free distribution alongside the commercial distribution, especially for the high-end population? We need to look at it so that we can serve the entire population, because our ultimate goal is to increase the net access, considering the resource constraint. Then to Nigeria, did you do a documentation on mobile population? It is always challenging in distribution, especially in urban areas. We have the mobile population and also people who work in shifts day and night. Do we have some documentation so that we can learn from you moving forward? Thank you very much.
Yes, my question is for Nigeria. So you mentioned that you also communicated or passed SPC messaging to communities that were not or to wards that were not receiving the intervention. And I just want to know to what kind of detail was in your SPC messaging at that level, at that community level, and whether you have any sort of takeaway about what kind of key messaging should be passed to minimize any sort of negative reaction and actually improve or increase acceptance that they will not be targeted for the intervention. Over.
Thank you. Last question, center, back. I saw a hand.
Sorry. Thank you very much. My name is Francis. Mine is just my prayer. Let's make sure that whatever we are doing, let the civil society be involved, because in every we need what we call accountability and transparency in whatever we are doing, because civil society plays a big role in those projects, because we need civil society to do something to oversee or to make sure that we are working together with civil society. Thank you very much.
Okay, over to you, Ifoma, in Chicago.
Can you hear me? Can you
Yes,
hear
we
me?
can.
Okay, so I think I have quite a few questions. Let me start with the easier ones, because some of them were a little challenging to think through. So the first one was why the procurement and distribution costs are high. This was based on our literature review. We actually have a paper, I think with Jalene Gerardine at Northwestern, on procurement and distribution costs. So we did an extensive review and we found the cost to be between $3 to $4, $5 in some places. Distribution cost was also based on our literature review. So maybe our numbers might be a little off by $1 maybe, I think. But that's what we found based on the literature review. So I'm not exactly sure how accurate it is. I'm sure it might be different if you actually have to procure the nets and negotiate with companies. For what was the final decision about the 600,000 nets, I think, so basically this was an analysis to decide if they should actually even go through the process of procuring the nets and distributing the nets. So the final decision was really to move the funds that they had, $3.7 million, towards other areas. So instead of purchasing nets, because they just didn't have the capacity, resources, time to plan and microstratification, they decided to just do SMC and extend SMC from 3 districts to an additional, I think, 25 other districts. And then someone had a question about the burden being high in surrounding areas. That's correct. But really, I wasn't sure whether the question was that a consideration, whether on whether the funds should go to those areas or whether funds should be allocated to Abidjan for microstratification. I think I could answer it both ways. I think from the perspective of if you should do microstratification, considering that the surrounding areas have a much higher burden and there could be this higher risk due to people moving from other areas where there's higher burden, so a mobility-induced kind of risk. So definitely, because you could see from one of the plots that I showed that outside of the urban extent, we found using the DHS like a number of clusters where the burden was about 15 to 20%. So it could be explained, or it could be due to the fact that those areas outside the urban extent were much higher, had local transmission going on at a much higher level, or that people are traveling from other regions that are surrounding Abidjan and helping to bring in infections. So these are things that should be considered as well, because if you have mobility being a big factor in transmission, then you want to figure out how to deal with that issue specifically. My thought would be thinking about prophylaxis, treatment really, since the infections are being brought in from elsewhere. So making sure that you deal with your mobile populations and think about what other interventions you could put in place to address that issue. There is a question about what arguments resonated with policymakers. From my perspective, because my interactions was mostly with the PNLP and also with Global Fund. I think one of the, which was kind of what I laid out, the biggest argument that why they wanted to consider microstratification was this heterogeneity in risk. They were concerned that even at the 1%, the fact that the overall burden was 1%, that there's going to be a lot of places where this was much higher, given that the DHS2 has a lot of uncertainty around how the survey is conducted. And so capturing the actual population risk was something that was in doubt. And so they really wanted to do microstratification because they felt that, particularly for their slum populations or places outside of the city, that the burden would be quite higher. So that's why they wanted to do it. But as you could see, they just didn't have the funds or the resources to do it. And I think that really speaks to the barriers. But for me, what really surprised me the most about the process was just how complex it is, based off of just thinking about what happened in Nigeria, thinking about, the analysis we did in Côte d'Ivoire. I think just the idea that you have to do microstratification is often, maybe I just exclude areas and go give nets. But as you could see from both Fatih's presentation and Mr. Chukwu's presentation, there's like a series of things you need to think about. And before I started doing this work, I really didn't understand just the complexity of programming and what that entails. But I'll leave the other questions for Mr. Chukwu and Fatih to address, because I think this is more in their area of expertise. Thank you.
Fatih and Mr. Chukwu.
Okay. Thank you very much. Thank you also, Dr. Ifeoma. So what argument resonated most with policymakers? I think foremost is just getting them to understand that we have limited resources for the targeted population, and understanding that the net will not be enough for everyone. And then also the argument about the other indicators such as test positivity rate and net use, especially the argument that in the urban areas, nets are less likely to be used, or other people being economically sound to be able to get the protection they need from malaria. What barriers persist? Well, just that fear of this affecting other health interventions, especially polio, measles, and so forth. What surprised me the most, I think how often you have to engage the same people again to keep explaining and getting them to understand, because programming of such campaigns is quite complex and there are so many different human factors involved. So just different issues coming up and having to engage people again, or likely the same people, and trying to assure them or explain the strategy to them again. What role did community feedback play? It played a huge role because, especially from the experiences of last year, we were able to really understand how important it is to engage the community at the lowest level as much as possible, and getting their feedback and interacting with them and making sure everyone understands and we're all on the same page. Then there was a question on mobile population. So our micro-planning strategy and the templates that we use have been designed to identify mobile population and cater to them. So perhaps the person that asked that question, maybe we could interact further to provide whatever technical guidance they'll need. What level of SBC was carried? It was really detailed, and we considered it by ward level. And we tried as much as possible to avoid generalizing SBC messaging, let's say, just for the whole state. Sometimes you have to break it down by local government or by ward level. So as low as possible, the lowest community leader that you can get, the different CSOs that are existing in that community, engaging them. In Nigeria, we have the World Development Committee. We also engage them as much as possible. We have found them very, very critical in, getting the everyday beneficiary to understand why they were not targeted for ITN distribution. Then a question from Robert about whether the same areas will be targeted for distribution next year and will not be targeted for distribution next year. Not necessarily, because in the first place, why a particular ward was not targeted. There are so many different factors in terms of, first of all, whether the area is urban or how urban it is, or if the population, the net availability test activity rates, the funding available and all that. So these factors may change by the time you come to the next campaign. So, but definitely we have documented as much as possible the processes and the factors and the considerations and the decision that was taken to not to target these areas. And for the next campaign, these items will look back to and consider before deciding whether the same area will be prioritized or not. Those were the questions I was able to get. I don't know if there's any I've missed, and then also if Mr. Chukwu wants to add on to what I've said. Thank you, and over.
Thank you, Fatih. I think you've basically addressed those issues. Just to say that we are monitoring those places. One of the things we're doing, of course, is to utilize the DHIS2 data, which they report on a routine basis. We'll keep on looking at those data to see what impact it is, what will happen in those areas, or what data is coming out of the facilities located in those areas. As a proxy, we're also looking, of course, we'll be looking at the surveys that will be coming on the National Malaria Indicator surveys that's planned, and a few other surveys that is going on. The rapid impact assessment. So I think those are the things I just want to add.
A huge thanks to our three presenters who have presented very transparently their experiences in microstratification. We have learned now that there is heterogeneity on the ground, and sometimes the heterogeneity is actually heterogeneous on top of it, doesn't follow administrative structures, making it difficult to implement sometimes. It is surprising how complex it is. It causes communication fatigue as you use the same people to communicate. It sometimes results in the program giving up the ITN campaign altogether and implementing a whole different intervention. And it is very challenging to get all the stakeholders together and understand the constraints that have led to this decision to be made. All in all, this is the new dispensation, and this is where we are. So this is the end of this session. We go for a coffee break, I think for about 15 minutes or so, and come back for the last session. Thank you. Karibuni sana. Welcome to the final session of the day. Let's take our seats. The faster we settle down, the faster we get to the cocktail. Yeah. How's that for motivation? Karibuni, karibuni. Let's settle down. Okay, so for our final session, we want to get everyone thinking about measurement beyond population-based surveys, given our continued and compulsory need for data for decision-making, in spite of and especially due to the diminished resources. So we have in this panel Molly Robertson of the Global Fund, who will speak to how we can continue to measure the outcomes of our work in this dispensation. We have also Hassan Mukhtar of NMCP Somalia, who will share their experience in using clustered lot quality assurance sampling, CLQAS, to measure their campaign outcomes. And then we have Julianne Tangena, the technical project manager at Innovation to Impact at the London School, who will close out our day by sharing a toolkit to support our programs to turn insights into action and encourage us in the way forward. Welcome back for this final session, and over to Molly. Karibu.
Thank you so much. I'm actually here today representing the Surveillance Monitoring and Evaluation Working Group. I am one of the co-chairs along with Wajib Mohammed, who is also a co-chair of this group. So I'm going to be talking from that perspective today. So what we started out in December was really looking at harmonization of some of these indicators that are being asked for at the global level. So this includes indicators that are being pushed to WHO, that are being pushed to the Global Fund, PMI, WHO, AFRO, ALMA, and really thinking about how we can get better harmonization of those indicators so that when you guys are providing reports, you're providing one report rather than many, and that we have some consistency in that information. We had a meeting in October, November to really move forward this harmonization. Unfortunately, the work with PMI has made this difficult, or the current situation has made this more difficult, but we are still forging ahead to make sure that we have some of this harmonization. One of the pieces under this harmonization, as I'm sure some of you know well, is a review of the Global Fund indicators. So this was led by Stefanos Shargi, who is here with us today, and Metrics for Management, which was a group that came on board to really look at going through this process. So meeting with all of you, asking a lot of questions, reviewing the indicators, some harmonization. We then went through also and made sure that that harmonization was consistent with the language that WHO is going to be publishing soon in their new SME manual, so you will see the exact same wording, so it won't be confusing what these indicators look like. So they'll be reviewing and revising those guidelines and pushing them out soon. One of the key things, and that I think that we'll get into later, is that these include indicators that are allowing for multiple data sources. As we all know, the DHS program right now isn't moving forward. We have limited funding for MIS. I think that was true before, and now is even more true. So some of these indicators, especially around ITNs, that we generally relied on these national surveys to give us information on, are no longer going to be available. So we need to look at alternative methods, and if we still want information on these indicators, we need to allow for those alternative methods to feed into the information under these indicators. Again, we're hoping that both the alternative methods and having a harmonized set of data means that when you guys track programs, it's easier to focus in on the measurement that matters, and it's also easier to transmit that information. Going into this really with the eye to the data that is collected should be the data that's used and useful to you as programs. How that then floats up to, Global Fund or WHO is a secondary concern. Really what we should focus on is what data you can use, because that, as we have more and more limited budgets, it's going to be more and more important to use every bit of data that we can. So I just want to go through quickly. I know everybody's favorite subject is these indicators, so we're going to go through these quickly. I've highlighted a couple. I really want to both highlight a couple, look at some new methodologies, and a new indicator that will require some new thinking. So number of insecticide-treated nets, I think everybody is familiar with that. Number distributed to targeted risk groups through continuous distribution, through mass campaigns. What we've done is, instead of having various indicators, we've aggregated this indicator so that you'll see a difference in what the modular framework looks like, and that really we're looking at disaggregation. So realizing that not every disaggregation applies in every context, you will be able to choose the disaggregations that you report on, but those disaggregations will come under one parent indicator so that it's more clear, how that relates to the other information provided. We're also, I highlighted O1A and O2 because we're using that for another indicator that I'll describe to you, but importantly, we have proportion of surveyed population that slept under an insecticide net the previous night, and that surveyed population is important as we start to look at other alternatives than national surveys. We're going to need to be able to target where we look at that information at where those populations were surveyed. And then proportion of population with access to an ITN in their household, I'm going to go over that, and how we are relooking at access. This work that a lot of you are familiar with by Hannah Conacher, and I'm going to present some of her slides to talk about how we are adopting the methodology that she thinks is most useful for those calculations. And then the proportion of population at risk covered by distributed ITNs. So this is really just looking at your general base population and then how many ITNs you've put out into that population. And then we also have O11 that I think some of you were familiar with. A lot of people chose to report on this indicator. And this is disaggregating those proportion of population at risk potentially covered by district, so that you're really looking at what districts you're achieving targets and what districts are lagging behind and you may need to focus more effort on. Oops. So oh, I think I skipped one here. Oh, no, maybe okay. So what I want to focus on for a second is this use access ratio. So really it's not about just access and it's not about just use, it's about if you had a net, did you use it? And that's going to become really more important as we move from universal coverage to more targeted coverage. We need to know if those nets that were put out there were used. So looking at access, did you have access to any ITN in your household? And then if you did have access, did you use that? So really being able to understand, for those with nets, did they use the nets? And this is really looking at the behavioral gap, right? So assuming you will use a net, We really want to look at that behavioral gap of those who did not use a net, be able to target SBCC or whatever else needs to happen to be able to close that behavioral gap for those who had a net but did not use it. So I'm just going to go over this really quickly. Again, some of you are familiar with this from Hannah Conacher, but this is showing why looking at one net per 2 people does not give us a great use access ratio, sorry. So this household, there's 4 people, there's 1 ITN, the population access is 50%, but this household is excluded because there is not 1 ITN for every 2 people. Even though they have some use, we're excluding them from 1 for every 2 people as our access calculation. Same thing for this. This has 7 people, but 3 ITNs, right? So now you have 86% of the population in this household with access to an ITN, but because there is 1 extra person that may actually be under a net at night, it is excluded if you do 1 net for every 2 people as your calculation of population access. And this adds up. So it adds up in a way that reaching 80% of households owning 1 ITN for every 2 people is nearly impossible to achieve. And we don't want to measure things that are impossible to achieve because we don't know what to do about them. So we really want to focus in on what is the information that we can use best. So this is the new indicator that will come in the modular framework at the Global Fund, the proportion of the population with access to an ITN in their household that slept under an ITN the previous night. So proportion of population that slept under the net and the proportion of the population with access to an ITN in their household. So these are calculated from those highlighted indicators I highlighted before. It's not anything additional that you have to do, it's just a calculation that needs to be made. I already went through these key terms, so we'll skip that. Oops. This is just looking at ownership and use. So percent of households owning an ITN under 1 per 2 people, you can see that there's actually some real problems if you're looking at that and deciding on whether or not people are using your ITNs. It looks like it's pretty bad in a lot of areas. And then if you look at the percent of population that used an ITN the previous night, then you're like, oh God, this is really bad because you use all of the populations that have 1 ITN per every 2 people, and then the people that slept under it, and it looks like a really bad ratio. However, if you look at just the ITN use among those people who do actually have a net, then you can see that actually we're doing okay. Access is an issue, obviously, that's highlighted before. We need to look at access, but this is going to be the more important indicator as we move away from universal coverage and more targeted coverage. We're really going to need to understand if we target the nets to those populations, who is using them, who has access clearly in those populations, but who also is using them. So questions I welcome afterwards, but that's the new indicator we have. The other thing that I want to go over really quickly, and I'm trying to keep this presentation short, giving time and allowing for lots of questions, is the alternative method. So as I said, we're allowing for alternative methods, under these indicators, knowing that we won't have the information available in MIS and DHS to the same extent that we had before. Not only, but I think we were moving away from having that information only come from the MIS and DHS anyways, because of the fact that a lot of interventions, including nets, are now increasingly being targeted to subnational areas, lower than a provincial level. And yet our DHS and MIS are usually targeted to provide information at a provincial level. So we have a really hard time understanding anything lower than a provincial level in those national surveys. So we were already looking at this. Now it's more important than ever, I think. One thing that you'll hear about later, and so I'll just bring up quickly, is the threshold measurement. So looking at clustered lot quality assurance and lot quality assurance sampling. So these are targeted smaller sample surveys where instead of looking at point estimates of your use and use access, you're looking at thresholds. So did this area meet above or below a threshold? And depending on whether you choose LQAS or CLQAS, you can decide on what those thresholds mean. I think really critically in thinking about thresholds is what are you going to do with that information? So if you develop 3 thresholds, for example, everybody has the use access ratio that you want. People are kind of in the middle, or people have a low use access ratio. Do you need that? Do you just need above and below to be able to target, maybe a little bit of BCC interventions that you have, or do you need those 3 stratifications? Are you going to do anything different in the middle stratification than you would in the low? Because these have cost implications. The more sample size, the more people that are going to have to go out, et cetera. These are smaller scale, so you're going to be targeting these into the areas where you feel like there might be an issue and that you want to see if there's an issue. They are targeted to areas of concern. They can be integrated with other interventions, and I think, as we move forward, we're going to be talking a lot about integration. So, these are just survey methodologies, but you can add all different kinds of indicators to these survey methodologies. And again, the idea is that these should be used for action, principally thinking about how these are used for action rather than reporting. There's also proxy measurements. So the one that we are talking about the most is ANC services. So in your first ANC visit, because we know in general that procurement of one ANC visit is fairly high across most of our countries. And so what can we do in that first visit to really understand some of our interventions? This requires high ANC1 visit seeking. We need to have a good base population, but we can use that as a proxy. There has been a lot of work by Imperial College by Patrick Walker, looking at whether we can use that as a proxy for understanding community use given access. And I think there's confidence that that is possible. So this would require asking women in their first visit how many nets they have, if they've used their nets. It would require sometimes needs register modification, so that's a really big thing. Not saying that it's not, but if you're looking at less MIS and less DHS, perhaps investing in that register modification and being able to get this information monthly over time is going to be really useful. There is an additional quantification need if you do this, so you need to quantify additional RDTs. You're testing every woman. These aren't giant numbers, but it needs to be in consideration. And I would say, and ACTs as well, as you find women who are positive for malaria. It is not only necessary to calculate these as the supply chain, but to work with your supply chain people so that those supply chain needs are throughout the system, are understood throughout the system, and people are able to pull out of regional warehouses, out of district warehouses as needed as ANC increases. Sorry, I went too far. So that is it. That's my short presentation. And I wanted to give you guys time for questions after all of our presentations. Just a huge thank you to Hannah Conacher. As I said, she really worked on this. Nirali Chakraborty and the team at Metrics for Management. Estefanos is here with us. At the Global Fund, Marcy, Laura Anderson, and Arnaud, who worked really hard with us at GMP to make sure our indicators were harmonized. So, thank you.
Thank you, Molly, for the presentation. Let's welcome Mukhtar. His presentation is pretty much a continuation of Molly's presentation as he demonstrates how they have used CLQAS in Somalia. Thank you. Karibu.
Thank you all. I wouldn't be so long without blocking you to go into the cocktail. I'll make sure to be very short and brief. And first and foremost, I would like to share with you that this study is being conducted by an independent company in late 2022, where we have done a mass campaign, 6 months after we have done the mass campaign. And that was the last campaign that we have done. And the second one will be in this year. Right after the meeting, we're going to start, inshallah. And furthermore, I'm not going to contradict my activities and efforts. I'm here to take an account of the findings that have been found in the assessment. Federal Ministry of Health and UNICEF, in collaboration with UNICEF and Global Fund and other partners working to eliminate with malaria across Somalia for a quiet period of time. One of the key methods used was LLIN. In 2026, 27.1% household owned the nets, late 2026, even after the mass distribution. That was background information before we come to this stage. Many children were still in danger during that time for malaria. To conduct this study, we assessed the best global best practices. Since 2000, LLIN and indoor spraying and better treatment have introduced malaria in worldwide. Giving out free nets was widely helps us to ensure more people have them compared to selling. So it was that time when we moved that strategy of having free nets, mosquito nets. So the distribution from 2018 to 2021, LLIN was widely distributed across the country with support from Global Fund. Reports claimed that high coverage, but there was not enough independent data to confirm this. Reason why we conduct this study was this. In 2019, a survey found that over 9% of the people in some areas own and use LLIN. Almost 90%. Still, these findings were not enough to guide future planning because some of the data that has been used was secondary data. And for us to get more factful, we have tried to use primary data, and that's why we have conducted this study. In 2022, we have done to check next coverage, ownership, and usage. After we realized that it's not adequate to use the secondary data, we plan to use primary data. This aim was to understand if there is any sort of improvement for future programs. Our aim was to go beyond better and better. Main goal was to check how well people in 26 districts from our own country use LLINs in 2022 after 2022 mass distribution. Reason why we have chosen these 26 districts is because the mass distribution usually goes, many of these nets goes to riverine areas where usually malaria and mosquito comes from. Among the specific goals that we were going to achieve was to make sure how many households got these mosquito nets. See how LLIN use matches national malaria strategy. Focus on how vulnerable and marginalized groups are using LLIN. Understand people's attitude and social factors that affect LLIN use. Find out what helps or prevents proper LLIN usage. These were the specific goals and indicators that we were going to measure in this study. The methodology used in this study was focused on how people use and own mosquito nets, and it has been used in both quantitative and qualitative. The whole coverage cluster method was being utilized to select communities for this study. A total of 7,436 households in 26 districts were targeted in this study. As I mentioned before, these districts were being chosen because of the riverine areas. As we all know, Somalia has two rivers, Juba and Shabelle. In each district, 22 groups clustered were randomly picked, and 13 people from each group were interviewed. After we picked these 26, we decided to interview 13 of them. Among the interviewers, we have managed to reach 7,106 people were interviewed successfully, which is high response equivalent to 95% of the target. Basic statistics were used to understand the data. I've mentioned that we have used both qualitative and quantitative. Also, logistic regression were applied to explore difference in the use of people's background and economic states. It has also been assessed. The study used 95% confidence level. After assessing it, we realized that up to 99% has significant in statistics. Interviews were also analyzed and understand community stakeholders with views through narrative analysis. So, among the findings we have managed to reach is slightly more women have been reached, which is approximately 52%, compared to male percentage, which is 47% participated in this study. 85 respondents were married, 74 were household heads. We were trying to reach the heads of the household for them to have a concrete and real information. On average household, it had 5.2 members, with nearly equivalent split of male and females. Most households, almost 63% were permanent residents. Others include internally displaced people, which was approximately 33%. Pastoralists also was 3% and refugees 0.4%. Household groups were into three wealth levels: poorest were 34%, poor which are 33%, and least poor which were 33%. Most participated interviewed people was 72% live in the urban areas, while 26% were in the rural areas. As we all know, in Somalia there is a security issue which may not allow us to reach some urban rural areas where this terrorist group are already managing. The ownership of the LLIN, 79% household had mosquito nets. On those interviewed number of people, 79% of them have nets. The highest ownership was in Bai region, which is among the riverine area, and 9% were in Hiran, which is also among the riverine area, and also Bari, which is 6%, and Lower Juba, which have 57%. The types of household, IDP had the highest ownership, which is 81%, followed by permanent residents who have almost 8%, 79.4%, and urban household, which have 82%. Pastoralists and rural household had lower ownerships. In this type of communities, they always move from one place to another, and they have a problem hanging the nets from where they move to one place to another. Average nets, each household had 3.3 for 5.2 people. That is 1.9 per net. Highly slight above WHO's ideal, which is 1.8. Types of nets, most nets were LLIN, 81%, another treated were 7.7%, untreated were 10.5%. Usually the source of these nets were majorly comes from the government and the source of Global Fund and our partner UNICEF. The ownership of LLIN also continues, as 83% of households receive nets less than a year before the survey during the mass campaign. As I have mentioned before, this study is being conducted 6 months later than the mass campaign, after the mass campaign. Usually the mass campaign goes over a period of time from start to end. So, net condition of the nets, 61% were good condition, and 26.6% had small holes. Some had size of finger, and some of them have a hole size of fist. Each household got an average of 2.8 nets. Households without nets were 21%, had no nets, mostly in Bardere region, Kismayo, Bosaso. Reasons of having no nets was lack of money. Some people believe that they have to buy the nets. Lack of knowledge and awareness because they don't know the use and importance of the nets in a rate of 19%, or not available, which is 16%. After studying the attitudes of these communities, 70% said that they would like to use if provided. And 24.4% said that they will use them regularly. So there's still positive towards these nets. The use of insecticide-treated nets, net usage was 95.8% household with nets, and at least one person used it the night before the survey, at least. 92% of the nets were in use, only 6.8% were not in use for various reasons. Because of, I said, these pastoralists, most of them, they have the nets, but they may not have enough time or adequate time to hang the nets and use it. Pastoralists and nomadic household use nets at least compared to IDPs and permanent residents and refugees. Net use was similar in both urban and rural areas and across different regions. Still, household use of these nets, 87% people sleep under the net mosquito night before the survey. As I mentioned before, highest usage was among the children under 5, which is 95.1%. And 12.8% did not use the nets, mainly due to not enough nets to everyone, not nets available, 23%, discomfort in using the nets, which was 14%, family refusing to use them, which is 7% almost. Pregnant women who are among the most used community, part of the community, said that that shows that 22.7% of the household had a pregnant woman among the selected number. More in the urban areas, 23%, and the rural was 21% almost. Refugees has highest share of pregnant women, which is 26%, followed by IDPs, which is 23%, and permanent residents, which is 22%, and pastoralists, which were 19.4%. Pregnant women, as I've said, it is almost 85. Women slept under the net, highest among the IDPs, lowest among the nomadies, which is 6%, and refugees, which is 63%. Lowest districts which use pregnant L-line in pregnant women was Lusmreb, Dolo, and Elwak, around 63 up to 65. Most other districts were over 85. Where nets were used, 94% nets indoors. Some used them outdoors, which is 11%. Okay. Among the challenges which is showed in the study, the common challenges was among 25% households reported difficulties in using the nets. Main issues include feeling hot, because due to temperature in the country, sometimes people feel uncomfortable, and because of the net, treated net. Some people felt allergies, which is 32%, and poor air condition, which is 32%. Preferences of the type of nets in these communities, 42 of the household has preference of net color, which were chosen black dark color, 73, and 22 liked our nets. 54.6 had a shape preference, which is 81 preferred one. The type of preference were cone shapes. These nets have different shapes. One have a rectangular shape, which is used mainly on the bed, and the others are on cone shape, which is normally hung on top of the roof of the house. Some mentioned health concerns. Some people experienced skin or breathing problems after using the nets. This effect may be due to poor understanding of how to use the nets. perceptions of this malaria transmission in the community. People understand that 96.2 new malaria caused by mosquito bites, while, however, 18.8 mistakenly believe it could come from eating or drinking with infected people, and 12% came from a dirty water. Drinking a dirty water, not caused by mosquito. 5.2 reported losing family member to malaria in the last year. This is self-reported data, which is not the actual data, which does not indicate the actual data in our systems, in the DHIS2. Malaria prevention practices in their community understanding was that said that 84% believe mosquito nets are most efficient prevention, while almost 67% mentioned keeping surrounding clean. They believe like that. 26% use mosquito repellents. This is somehow a kind of lotion used. And 21.4 reported spraying insecticide indoors and outdoors. They believe that the best practice for prevention is like that. Current strategies, Ministry of Health and UNICEF partners use various methods which may include IEC, materials, health workers, community levels, and World Malaria Day, and field visits and raise awareness. This helps increase of knowledge about the nets. Limitations may include communication mostly reached people at health centers or distribution of points, limiting its overall impact. Suggestions for improvement, which were said by the community, recommended using wider ranging methods like TV, radio, songs, and plays to spread messages on effective to a larger audience. Among the recommendations in this study, which may include targeting low coverage areas, which have been discussed, include Barderex, Maya, and Bosaso, prioritizing and understanding populations. We have different types of population in understanding of these nets. Other recommendations may include improving district level coverage, address household habits, and increase awareness on proper use. Designing preference should be considered also. I've said that the cone type will be most conically shaped nets was the most preferred one, which is 81%. Improve health communication, combat health misconceptions in the community, and enhance communication strategies were among the recommendations from the communities. Thank you.
Thank you, Hassan Mukhtar. I request everybody to stand up for about 10 seconds and we get a really good stretch in. Let's get up.
It's good that you did it. Otherwise, I would have done
it. Really good one.
You only need to mention the competition.
Yes, yes, yes. Okay, 10 seconds are over. And we now welcome Julianne to give us the last presentation of the day. Welcome.
Good afternoon, everyone. It's good that we just did the stretch. I'm the last talk of the day, so I'll try and keep it as short as I can. But I ask for kind of the last 20 minutes of your time before we go into the questions and the cocktails after. So I'm going to kind of follow up on the conversation and the presentations that have been going on throughout the day about durability monitoring. I think it's been mentioned in several presentations. And so we've been trying to develop, and we're still in the process of developing a post-market data collection toolkit really focused on control programs to help them design their post-market data collection plans, but also how to use that into action. So it's not just about what are the questions that we're interested in, but what are the questions that we actually can make decisions through. So whatever data that is collected is actually used in the decision making, in the actions that follow up on that. And because it's still not a finished toolkit, I'm really interested in hearing your thoughts, ideas, comments as well. Everything is up for, you know, discussion, because I think at the end of the day we want to develop something that is useful for everyone that is working with post-market data collection. Oh, sorry. So I'm going to kind of go into something that everybody already knows, but I just want to highlight it again. Variability in the net and the environment, it shapes the lifespan. More than 3 billion ITNs have been distributed since 2004, and this is a huge mix match of yarn, chemicals, knitting patterns, size. When we're talking about ITNs, we're not just talking about one type of ITN. There are many different types that have been distributed. And so when we're talking about how long these nets last in the field, it is not only about those physical insecticidal properties of the net, which differs, but also the sleeping environment, the other environmental factors, the individual, and then the community. And of course, these are all interconnected with each other as well. And these are all aspects that hugely impact the lifespan of a net. And so post-market data collection, really the field measurement of net durability has been done through program data, academic studies. There was mention of MIS, DHIS that also collects some post-market data, but most importantly, it's the durability monitoring studies that are these huge resources that we are currently really benefiting from in a lot of different analyses that we're doing. And this has really helped us understand a lot about what is happening to nets in the field. This is something that everybody already has seen, but 3 years is the recommended lifespan. More than 50% reported less than 2 years. And there's a high variability across net types and areas as well, and that's really important. It doesn't mean, you know, this kind of overall summary is for everywhere. It really is dependent not only on the different countries, but even within countries. When we're talking about subnational tailoring, the data needs to come from a lot smaller scale to really understand how we can distribute bed nets in the right regularity, which types of nets that we're distributing, what kind of communication needs to be in that community to ensure that whatever resources we're using are used most effectively. But of course, there's a huge insufficiency in resources. I mean, that's been mentioned in almost every presentation, but that also is for durability monitoring. There's a severe budget constraints that limit country adoption of durability monitoring. High level of resources and skills are required to collect the data, to analyze the data, to actually make that data useful in decision making as well is a whole part that requires a lot of investment. And those challenges in translating data in actual decisions is a really important part of how is that data used, and once we've collected that, can we actually use that for decisions? And one size doesn't fit all. One durability monitoring isn't something that can be used everywhere. Every different country, maybe even on subnational level, you have different questions that you want to answer that your durability monitoring study needs to be tailored to. And this, of course, is further exacerbated by recent funding cuts as well. I mean, durability monitoring has mainly been funded by PMI, and so we need to really rethink how are we going to get that data to make sure that we can use that effectively in the future. So the real key is how can we help country programs collect the information they need for tailored decisions in a very complex ITN landscape under severe resource constraints. So listening exercises were done in 2022, already a few years ago, with 5 countries to really understand what are the challenges that they're facing, what are the needs, and what really came from that is that there's a need for more granular durability monitoring data for targeted decisions, subnational tailoring. There needs to be more data on the different areas of interest, understanding how they differ, understanding the heterogeneity across the country, but even we were talking about the urban settings and how heterogeneous such a small area can be as well. And then budget constraints call for more tailored monitoring focused on key programmatic decisions. And those two together are really challenging, because on the one hand, we're asking for more data, and on the other hand, we're saying we don't have even enough resources to do that. And one of the key things that came out of that was also that we need to ensure that the collected data is utilized to its fullest potential. And I think that's where we really hope that the PMDC toolkit can help ensure that whatever data is collected is utilized. So there's a clear call for guidelines to help identify and collect durability indicators for country decision making. And so the post-market data collection toolkit that we're currently developing is to help guide programs to designing a post-market data collection study, something that they could also maybe share with potential funders. So it's not just about the plan, but also what kind of resources are needed, what are the cost estimations of doing something like that. Also, so that it's a reiterative project where you can go back and go, okay, this is, we don't have that funding, we're never going to get that. How can we even tailor this more specifically to the key questions that we need to answer? And what we're using is an entomological surveillance planning tool. For all the entomologists in the room, I hope you've heard of this before, maybe outside of the entomologists as well, which is a very modular approach developed by the Malaria Elimination Initiative. It's online, you can see it, and it's really focused on this kind of step-by-step focus on situation assessment. So what is the situation in the area of interest? What is the tailored response that is needed? And then also looking at program management and sustainability. And so instead of creating something entirely new, we know that this works really well in the different programs where it's been implemented. We want to use that kind of initial development that has been done for the entomological surveillance and kind of tailor that to the post-market data collection, and focusing really on programmatic decisions and actions related to procurement, distribution, monitoring, everything that has to do with the design of ITN campaigns in country. And so the toolkit is consistent of several modules. I'll go through these one by one later on, but just to kind of highlight, the initial module 0 that we talk about is ITN quality control. This is everything that happens to the net and its quality prior to it actually being distributed into the household. The post-market data collection toolkit itself is really focused on once the net arrives in a household, how long does it last? What is the acceptance? Everything that is related to that part of the life cycle of a bed net. And so the modules start with, what is your question? What is the question that you're trying to answer related to the decisions that you're trying to make? What are the key indicators required to answer those questions? What is the background information already available? What kind of methods do you then need to answer your key indicators and thus your question? What study design is most appropriate? What sampling approach and site selection is required for your minimal essential data? And then what resources and funding are actually required to do what you're hoping to do? And have this be an iterative process where we have a response pathway to help kind of identify what are the outputs of your different methods, and does that actually help you answer the question that you're trying to answer at the start? So just to kind of help us kind of go through these different modules, very simple case study. I know that it's so much more complicated than what I'm saying here. The thing is, with 20 minutes, I'm trying to keep it very focused. So the case study is just country-wise discussing how often nets should be distributed as there's indication that coverage is below 50% 1 year post-distribution. So a decision might be, how often should ITNs be distributed? To start with module 0, the net quality control. As I mentioned, like an ITN life cycle from the start of the R&D until it gets to the household are many different steps. And some of those steps also include quality control of the nets itself, specifically pre-delivery quality control, post-shipment quality control, and then storage and distribution. Within the post-market data, we're really focused on kind of that last step. But in module 0, we want to highlight all those different other parts of quality control that are really important to focus on before you even look at your post-market data to ensure that your nets are up to standards. And so in this first module, we kind of highlight all those. We identify the resources, but we kind of make the assumption that nets distributed to households comply with manufacturer suppliers specifications the moment that they arrive at the household. That is the assumption we need to make when we're looking at post-market data collection. How you can confirm that assumption is by, within module 1, we kind of highlight all the different avenues, methodologies that are available to do that. And then module 1 is your question. You need to identify your programmatic decision of interest and transform these into key questions. We've tried to make this into 4 different themes to help you kind of merge all your different questions into key themes that can help you with your indicators. The first one is the physical durability of the net. So are you interested in the net itself, its attrition, its proportion to hole index? If that's the physical part of the net, if that's a part of your interest, that is theme 1. The insecticidal chemical activity is the second theme. The third theme is net use and individual behavior, which is really focused on SBCCs, so data that can be changed, that you can use the information that you collect from those questions to really change the behavior maybe in the community, increase acceptance of nets. And then the fourth one is the ITN setting, which is less easy to change. I mean, climate, environmental factors, what kind of what kind of bed they're sleeping on. Those are things that are important to know because that can inform what kind of maybe net you want to procure, or it could help kind of identify key areas of innovation within nets, but it can also maybe identify some areas might not be places where nets last very long, and maybe then other control methods should be considered because a net is just falling apart within 3 to 6 months. And so these 4 themes are really used to then help you identify your key indicators. So here, if we go to our case study of how long are ITNs lasting in the field, that's purely going to be on the physical durability and insecticidal chemical activity. I know that the others also can have an impact, but for simplicity's sake, I'm using those. When we go to module 2, it's about the key indicators. So from those 4 themes, there's going to be a table that highlights within every theme what kind of indicators could help you answer those questions in that theme. Primary indicators, this is not necessarily related to how important they are. This is related to data that is more regularly collected by programs already. And this is also still changing through the conversations that we're having. So we're looking at primary and secondary indicators, highlighting what these mean, what the outcomes are, and the strengths and weaknesses of each, because every indicator has a strength and weakness, and it's important to understand what can you answer using that indicator, but also what can't you answer. And that's really important when you're looking back at your decision, if that indicator is actually going to help you answer your question. So when we're looking at how long are ITNs lasting in the field, it could be that physical integrity, attrition, functional survival, and insecticidal activity are your key indicators there. Module 3 is about the background information. So this is about engaging stakeholders and investigating online resources. There is a lot of data already available. We were talking about durability monitoring data, huge amount of data. We're talking about all this knowledge within the different stakeholders, communities, and they need to be incorporated in the development of your questions and your key indicators to ensure that whatever is being developed is based also on the questions that are actually of relevance and decisions that are of relevance. So for the case of how long are ITNs lasting in the field, it could be related to heterogeneity. So maybe need to talk to different provinces and understand what kind of information is there available, what are the questions that they're struggling with. And maybe regarding the ITN type, if you're distributing a certain ITN, there might be already information from other countries that have highlighted challenges or strengths that you can incorporate into your plan. What are the appropriate methods? This is again then linked to your indicators. So once you've identified your indicators, now these indicators are related to the methods that can help you answer your indicators. So this is related to the methodologies. We're not creating new methodologies. This is purely about collating everything and pointing everyone in the right direction of where these methodologies are available. It's about outcome measures. So what is the outcome measure of your method, and does that then relate back to the decision that you're trying to make? And other useful guidelines of importance. Again, strengths and weaknesses about which ones to make is highlighted there, and specified where appropriate for different chemicals. And this is especially for the insecticidal part. It's important that there's a clear differentiation of if you're having dual AI nets, then you might have different methodologies that you want to use compared to PBO nets. So for how long ITNs lasting in the field, these were the 4 indicators that we selected at the start. just focusing on one, which is insecticidal activity. So these are the different methodologies highlighted: cone test, tube test, tunnel test, experimental hot test. The idea here is that for each one of them, we go into detail of not just the methodology, we highlight the different methodologies required depending on the net type, but also their strengths and weaknesses of what they can answer and what they can't answer. Module 5, which study design is most appropriate? This is really benefiting from, I think, the information from the durabilitymonitoring.org information. You have to identify the methodologies that best align with your objectives. So what is your time frame? Is it prospective, retrospectives? Are the net already in the field or not? Study structure, is it a longitudinal study, or do you just want to do a cross-sectional to identify if certain thresholds have been met or not? Or is it a combination of both? And so for how long ITN's lasting in the field, I mean, one of the questions is, are they already distributed or still in storage? If they have been distributed, can you easily identify them retrospectively or not? Because if you can't, then maybe a retrospective study is just not possible. Module 6 is about study sampling, approach, and site selection. LQS was mentioned before. Standardized monitoring, streamlined monitoring. We're trying to make sure that for the net part, the household questionnaire part, and the net kind of chemical part, there are clear roads of how you can identify the best sampling approach within your study, and highlighting things that might need less resources like LQAS, but which are very related to thresholds, which might be really useful for what you're trying to decide, or it might not be because a threshold is not what you're trying to look at. You're trying to look more deeply into what is happening in the study area. And site selection, of course, sentinel sites. Are we targeting high malaria areas, transects? What is the type of sites that you're looking at? Module 7, resources and funding. This is really about breakdown. So we're trying to separate for every methodology what kind of costs are associated to it on average. I mean, this, of course, is really dependent on the country. But we're trying to help give an indication of when you're planning your study to have an understanding of, is it 100,000? Is it 1,000? Is it, 3 million? What is the budget that you're looking at, so that it might not be the exact budget you come out with, but if you're ending up with millions, then maybe it's also a good time to kind of go back and go, well, that might not be feasible, so how can we minimize the amount of study sites, the number of questions we're trying to answer, and further have that iterative process. And then that is Module 8, iterative, until a feasible plan is produced. So review, refine, plan. It's all about going back to the start again, going through your indicators. Are they still, are they really going to answer your question? And this is really, for that iteration, the response pathway is a key part, which we're calling Module 8 and 9, which is trying to link every indicator outcome with a response or decision. So when we're talking about, for example, attrition, I mean, what is going to be your output? And does that then actually answer the question that you're trying to answer? Is attrition really what you're trying to get from this, or do you want more detailed data on this? And if you do have that data, what are you going to do with it, and what are your options regarding that? Also to include key limitations within the program. So we want to make sure that the endpoint isn't just going to be, you need to distribute more nets or more regularly. If that is not feasible within your National Malaria Control Program, then that isn't something that you want as an answer at the end. So then we have to think about, okay, what other indicators could we use that can actually help us influence things that we have influence over? And not just the outcome to be, the nets aren't lasting long, we just need to we need to distribute more nets, if that is not a feasible part of your budget. And what are the other key things to consider? So the endpoint is really a consolidation of all the outputs from the modules that can hopefully help you refine your PMDC, share with potential funders, but also really important is of it to be a summary of all the information there. So even if we just use Module 3 or Module 4 to kind of understand what are the key methodologies again that might be of interest, or what are the indicators that might be of importance to have that as a resource available as well. So you don't need to necessarily go through all the modules to get your benefit from it. So the timeline is a draft ready by the end of this month. We're still working on it. Feedback, improve and refine. I mean, that's going to be a very intense process as well. We really want to kind of trial it in different national malaria control programs to understand and get feedback and further improve, make sure that all the different indicators, methodologies, everything is included. Publish it on the AMP webpage so that it is accessible for everyone to use in an interactive way as much as possible, and finalize it and updating resources where necessary. So thank you to AMP, Tropical Health, Malaria Elimination Initiative, and CHAI, because they've been a key part of this, the National Malaria Control Programs that have really helped us kind of identify what the key challenges were. And yeah, thank you.
Thank you, thank you. Thank you, Julianne. We're open for questions. I do have some questions that were posted online. And, okay, let me read those. We have questions from Asma from Sudan, and she has quite a few questions for the Somalia team. Okay, so was this study conducted in South Central Zone? So that is her first question. The next question is, she observed that 21% had no net, and this is a very high figure, given that the study was just 6 months after the campaign. So she's wondering what was the coverage from the campaign. And also 75% of the study population was from the urban area, while we know that malaria endemicity is higher in the rural setting. So she would like Hassan to comment about that. And finally, Asma asked, is there any concern regarding one net to 1.8 persons, as in Sudan, in some areas, there is a cultural barrier, and it is more common for not to have two people sleeping under one net. Okay, so those questions are for Somalia, from Asma. From Hamad Habib in Pakistan, he's also asking Somalia, what are the actual numbers of malaria death reported in DHIS as compared to the 5.2% that was taken, that you received during the survey? And then he would like you to comment about the preference for conical nets, which is remarkably high. Is there any particular reason for this preference? So those questions are online. From here, okay, let's start from the center. In front of me, middle table. You can use the mic in front of you. Just press that button.
Thank you very much. I've been listening from morning, and I waited to ask my question last because I needed to have a good understanding. This is my first time to interact with the AMP. The last presenter has presented very well, and she has touched certain aspects of what I wanted to ask. I've been listening to the introduction, the financing, the data programs, the landscape, and many other things. Because I want to be understood properly, I'll begin by saying that understanding the science of modern medicine, it requires a study in the psychology of mass manipulation, because there is very little science involved in that. And I'm speaking from a researcher perspective. So now, moving forward, researchers cannot commit the professional suicide of raising certain hypotheses because of fears or certain things. Now, if a researcher is courageous enough To partake of such self-destruction, it would also be an endeavor in futility because they could be ignored institutionally, or some of these things require controlled testing, which sometimes is unthinkable. For example, you require a test group and a placebo, that's the control, in order to isolate the test against the result. Now, as a researcher, I would find it very difficult to admit that maybe I caused injury to some children for the sake of science. Now, to my question. How is AMP collaborating with science, academia, and research generally to ensure that the plans and the programs involve the target groups from initiation to completion? That is all.
Yes, my question is to the Somalia team. I think in the survey you mentioned that about 21 or 22% of people did not have net, or households did not own net. What did you do after that to ensure that these people have net? Because most often what we see is that we do these post-campaign evaluations or surveys, but we don't really act on it. It's just the data that tells us that this is what we have. So what else? Did we actually try to do anything between the period and maybe before you have your 3-year campaign to ensure that you improve the net coverage? The other one is on the population or the household that had pregnant women. You had about 22.8%, which is very high. How does this affect your routine distribution? Because if you are doing routine distribution and you have households of 22.8% having ITN, assuming everyone is receiving ITN, it means that you are actually covering a lot of households through your routine. So how are you using this data as well in terms of your routine distribution? Over.
On my right. Go ahead.
Okay, thank you. It goes to the Somalia presentation. Thank you so much for that insightful presentation. You mentioned that, we are talking about universal coverage, improved access, equity, and the like. But during the presentation, you mentioned that the households that are behind rebel lines, you are not able to reach them with the bed net. I don't know what you put in place, if at all you try very hard to reach them. I give an example in Sierra Leone. During the rebel war, we are doing our EPI campaigns. So it was very difficult for us to reach those people, and they are Sierra Leoneans, so we needed them to also benefit. So what we did, we have a discussion with the leaders of the rebels. We have discussion with them, and they also supported and helped us to take those the interventions along to the people behind rebel lines. That's what we did at that time. So I wanted to know what you did for those people, because they are Somalians and they need interventions as well. Over. Thank you.
Thank you. Yes.
Yes, thank you very much. My name is Francis. My question goes to my friend from Somalia. So you have really given us a good stuff. But one thing you are lacking there is just the role of the civil society in that, because we cannot really believe when some government is doing something without other stakeholders. Where the role of the civil society in that program? Thank you.
Thank you. Yeah, go ahead.
Okay. Yeah, thank you. My appreciation to the presenters and brother from Somalia. I just have a few things to to inquire, and given the fact that the context in Somalia is more or less similar to our local context in South Sudan. And looking at this study, knowing, of course, we understand that the results are based on the surveyed population. However, I get it a bit surprising to see that the net ownership in urban and ownership or utilization between urban and rural to be the same. The context always tells us the urban are not really compliant in most of the time. The other thing is also seeing the percentage of the pregnant women, both in the rural and in the urban, more or less the same. My last point, I expected to hear a bit of misuse of nets in the context of seeing that the nets ownership declined by 50% after only 1 year, which would also likely mean by the third year we might hardly get anybody owning the nets. In the context of our region, not just even South Sudan, we know that the misuse of the nets is very much common. We know the fishing populations, what they do to the nets, plus the farmers and so on. So basically, I wanted to ask, was there any aspect that look at the misuse of the nets within the communities? The last point, which I also want us here in this meeting to also link to this idea of one net for every 2 people. We know there are already limitations to that. Even if the nets are available, there are certain individuals within the household that cannot share the net. And that definitely will not make it one net for every 2 people, because if it's a mother and a son that is above 18, they can't share the net. The same thing applies to the father and an 18-year-old girl. So there are limitations, and within the context and the social norms that we have, there are certain things that we really need to know. Some formulas will not be absolutely applicable across the board. Otherwise, thank you, and I appreciate your presentation.
Thank you. Any other question? Great. Okay, so I think I'll give Marcy the first question, just to give Hassan time to figure things out. No answer?
Yeah, so just to be very clear about the 1.8 people per net, in that we are moving away from that as a coverage indicator. So I understand that there's problems with it. There's problems with it not just because of cultural barriers to how how sleeping spaces are arranged. So we're looking at coverage as access to an ITN and then use over of that ITN. So I think that will help, and then it will not help with not having enough nets. I mean, there's not going to be probably the possibility of having a net per person, right? So then you have to decide on your net distribution strategy, knowing your sleeping spaces, knowing how people are sleeping within the household, and then deciding how you're going to target your nets, and if there's going to be targeted distribution. If there's bigger households, how you deal with bigger households, how you deal with making sure that pregnant women and under 5 who are most vulnerable are getting those nets. So all of that will require a lot more work, but an understanding that 1.8 did not tell us what we needed to know about coverage, and that's why we are moving away from it. Thank you.
Yes, thank you very much. So I think my own suggestion or maybe question is to Molly, and it's just about the indicators, because the new indicator is actually very good because it actually covers the things that we don't really understand. But my suggestion is that now that it is new, is there an opportunity where you actually would train the government, implementers on how to really actually calculate this and to have like harmonized templates on how to report such data so that it's much easy whenever you want to do maybe like systematic reviews on those data. Thank you.
Yes, so one of the things that we're looking at as well is having an analysis plan. So we know that indicators themselves don't analyze themselves. Having an analysis plan that goes along with that, so it's clear how you analyze these indicators. As I was showing, actually the new indicator is just a compilation of 2 other indicators, so it shouldn't require any additional data collection. It's really just an analysis of the indicators that you already have, and we'll make that, we'll make the suggestions for that analysis very clear.
Thank you. I thought that the people wanted to go to the cocktail, but it seems they don't want to go. Let me start by the first question from Sudan, mentioning, a lot of us mentioned 22% number of lagging LLIN. And in my presentation, I mentioned that almost 16% of these people, and 19% of these people have no knowledge about it. And coming to regarding the social stakeholder engagement, like the civil society, before the distribution, we normally engage the civil society for them, which are the most part of the community, which were part of the people who plays a significant role in this mass campaign distribution. In that case, we are still lagging some cultural beliefs, we are still seeing some cultural beliefs which didn't allow us to distribute the mass nets because of the community doesn't want. They have some irregular beliefs which they normally narrate about the alliance. That's the 22%. 1.8 is already been mentioned. Unreachable areas, about the Sudan said that unreachable areas exist. Yes, we have unreachable areas where controlled by the terrorist groups. And these terrorist groups, as we all know that, they don't want to collaborate with us. They don't want, they don't recognize us, even our existing government, and it's very limited. And in general terms, it's highly prohibited to deal with these terrorist groups. And we are not in a position to support them because we are not in control of those areas. They may sell back, they may misuse, as you have mentioned. So in that case, we try our best through these stakeholders like civil society to help us, but we don't normally deal with those groups. Regarding the equality of the urban areas and the rural areas, we have been targeting riverine areas where people live. Among those people are farmers who live in the riverine areas. So there may be some number of communities in those areas compared to urban areas. In the urban areas, we are normally targeting refugees and internally displaced people. So there may be a slight number which is equal to these refugee people compared to these farmers, and so forth. Pregnant, yes, they are the same, because in our culture, marrying more than one wife has a very high number in the rural areas compared to urban areas. Maybe that could be a reason for the study, and the study may have some limitations, which may include the misuse of the nets. It does not indicate in the study, and it may be a kind of limitation. Among these questions that has been raised, we are trying to take an account of some recommendations and findings in the study. In that case, we are now trying to implement a digitalized system in this upcoming campaign, which is in line to our normal routine reporting DHIS2 system, which will allow us to collect data before and after the distribution also, of the mass campaign. And in that case, some of these findings have already been responded through different types of mechanisms, including the civil society, and by engaging the media, by engaging the schools, by engaging the students even in the school. And we might overcome some of those challenges mentioned in the study. Over.
Thank you.
Yeah.
Yeah.
I can't answer for AMP, but just to kind of follow up on the question you were asking about how do we engage communities, I think one of the first slides that I showed is the BedNet is one part, but actually everything else is what happens in that environment. And that's so important to collect information on to ensure that the community is actually receiving, what they need in their local setting. And at least for the toolkit, it's not just going to be household surveys that the focus is on. It is about all the other methodologies available regarding ranking, mapping, focus group discussions, key informant interviews. You have all this methodology that is available that can help you get certain information. And one key is also that community as a researcher, which is coming up a lot more, where you're giving that research question to the community and saying, okay, what is the challenges in your community? How do you want to investigate that? And I think that's really important to highlight, that there are a lot of different methodologies that can be used, and they all have their strengths and weaknesses, and it's important to highlight the importance of the community in that.
Yes, and typically, I mean, you asked about AMP and what AMP does about it. Typically when, at the time when we had more funds flowing, and I can't believe we thought we were extremely resource constrained even those days, AMP TAs move in teams of 3 to support various subcommittees that have been developed in the country. So there's the technical aspect, logistics, and communications subcommittees. And AMP would provide a TA for each. Now, the communication subcommittee have various funded activities where they engage political leaders up to the highest level possible, and then administrative leaders all the way down, religious leaders, women's groups, local champions, all sorts of celebrities, all the way down to whatever is the unit in the village that communicates and communes. And so there are all these activities that take place during the campaign, and that's how we engage communities during the campaign, before, during, and after. So if there's a good budget, and this has been a challenge all through, this engagement continues even after distribution.
If we could have a round of applause for our last panel. Thank you very much to Molly, to Julianne, to Hassan, and to Dorothy, who actually made up a pile of time in this last session. Much appreciated. So very quickly, the PowerPoints for today will be up on the AMP website this afternoon, so you can check when you're back in your rooms. The cocktail starts now on the same floor where we had lunch, but it's just on the other side of the pool. You need to wear your badge to get access to the cocktail area. And then we will start tomorrow in this room right at 9 o'clock. Dr. Rock is going to be leading that first session. So we see everyone tomorrow at 9 a.m. here. Thank you very much. And thanks, participants online.